Good morning. It's my pleasure to introduce Dr. Ihab Al-Hamidi. Dr. Ihab is a consultant, adult hematology and bone marrow transplant at Princess Noura Oncology Center, King Abdulaziz Medical City, Jeddah. Dr. Ihab will talk about CML management updates beyond second TKI. This is a satellite symposium sponsored by Novartis. Welcome, Dr. Ihab, to the stage.
Assalamu alaikum. Thank you, Dr. Hind, for the kind introduction. I will be talking about CML management updates beyond second TKI. So as an introduction, now we've reached a stage in CML that patient experience and clinical outcomes has improved significantly, and the life expectancy of CML patients now is almost similar to the general population. So the next phase of management of CML has to be individualized therapy. Optimal treatment management will require the physician to have appropriate treatment selection for patients from the outset, and adherence and compliance of the patient and proper monitoring to facilitate the choice of the right therapy. Physicians need to consider how safely to discontinue after starting the appropriate treatment for the patient, and have to have the equipment, the ability, skills of dealing with intolerance and disease progression. So when we get a new CML patients in this study, 50% of patients will have a comorbidity, hypertension in quarter of the patients, cardiovascular disorders in a significant number of patients, diabetes in this study is 10%. Obviously, in our population, it might be higher than this figure. And you find that in this study, quarter of the patients actually had two morbidities or more. And this, we have to bear this in mind because it will affect the way we manage such patients in terms of intolerance. So this is a quality of life survey in a study using bosutinib. And we as physicians, we try and concentrate on with the patients that we want to achieve an MMR. So what does this produce for the quality of life of the patients? Obviously, the most important thing is emotional well-being, and the emotional well-being produces a medium effect when we tell our patients that you have achieved an MMR, so that patients are usually happy with that. However, when you go to physical improvement, you find that the physical improvement of such patients is very limited and very trivial. So although we have achieved an MMR and we are happy with that as physicians and the patients are happy, however, the patient's physical well-being has not improved by achieving this MMR. This is a survey of quality of life in patients who are going to have treatment-free remission of more than 1,000 patients. And the survey was done in many countries, including the Middle East. It was in Arabic as well. And the outcomes of this survey has shown that when patients want to achieve a TFR, they were asked, why do you want to go through this? And 50% of patients, said they want to get rid of the current side effects. So that's a significant number of patients. Their motivation for TFR is to get rid of the side effects. So in this survey, what are these side effects? And the side effects were given a number of 1 to 5. 5 is a life-changing side effect. And you can see here fatigue, regardless of which TKI is used, fatigue score 3.3. So patients are usually fatigued, and they are more fatigued than actually how we perceive fatigue is. How about muscle soreness and cramping? A significant number as well, saying that they experience this. Disturbed sleep using the therapy. Pain. Remembering things. So these are all things that affect the patient quality of life. And headaches, and even feeling sad is something that patients experience when they are having such medications. These are the side effects the physician usually concentrates on. What does imatinib cause? What does satinib cause? Bosutinib cause? But actually the profile of side effects are much more than this. There are more things that affect the quality of life of the patient than these side effects that we all know. How about discontinuation of the TKIs? By 2 years of starting a TKI in the decision trial and the NS10D trial, 25% to 30% of patients have actually switched from the primary medication. About 5 years down the line, 40% to 50% of patients have switched from their primary medication. So a significant number of patients will have switched by 5 years. So this is another figure that we have to bear in mind, that switching happens quite a lot in the CML patients for different reasons. So what happens to these patients who switch? So this is a group of patients who had imatinib and dasatinib, and you can see achieving a complete cytogenetic response in this group of patients who had already 2 lines of therapy. Achieving a complete cytogenetic response is not great, ranging between 20% to 30%. This is the group of patients who had imatinib and nilotinib. Again, the complete cytogenetic response is not great in this group of patients. So this is a high-risk group of patients who actually have a difficult disease to treat. How about overall survival of these patients who are switching? So the blue line is post two lines, the red line, orange line is after 3 lines, and the green line is after 4 lines. And if we look at 5 years, the overall survival after 2 TKIs at 5 years, 80% of patients are surviving. After 3 lines is 60% of patients. After 4 lines or more, only 40% will have a long-term survival. So again, the more switching that happens, the more difficult the patients become. Why are patients switching? And in this study, it is showing that intolerance has become the most frequent cause of TKI switching. And this graph is showing the ratios of switching of intolerance compared to resistance. And after second line, 4 out of 5 would switch because of intolerance. So we have a new agent that works in a different way, myristoyl pocket inhibitor, Ssbmt. The able molecule TKI has got 2 sites, 2 pockets, the ATP binding site and the myristoyl pocket. These sites are sites that inhibit the molecule, the normal molecule. So this is a normal able molecule, when this is the myristoyl moiety of the molecule, and this moiety enters the pocket, and when it enters the pocket, it inhibits the able gene. So this is what happens in a normal able gene. What happens in a CML patients is that when the translocation occurs, instead of the myristoyl moiety being there, it is replaced with the BCR moiety, which is, as you can see, its structure is bigger in size, and it can't enter into the myristoyl pocket anymore. So the molecule becomes active most of the time. So Ssbmt binds to the myristoyl pocket and inhibiting the molecule, the able gene. This is the selectivity, the TKI selectivity of different TKIs that we have at the moment. The less sites it inhibits, the less the side effects. So let's look at the BCR-ABL specificity of each of the TKIs that we have. This is the sensitivity or the concentration of the TKI, and the red dots are the leukemia cells, and the blue dots are normal cells. So the more the distance between the CML cells and the normal cells, the less the side effects, because then the drug does not inhibit the normal cells. So if you look at imatinib, you can see that there is overlap between the red dots and the blue dots. So inhibiting imatinib, when it inhibits leukemia cells, it also inhibits normal cells, so then there is more side effects. However, the distance between the asciminib and the normal cells is greater, telling us that there is a larger safety profile compared to the current TKIs that we have. And this has been shown clinically. If you look at the most recent TKI use and the median time on it, compared to asciminib, you can see the difference that the median time on the most recent TKI is 1.2 years compared to 5.9 years in the asciminib. And after 3 TKIs, again, the median time is longer with asciminib. So the tolerance of asciminib, what one can deduce from this, the tolerance to asciminib is compared to other TKIs is better tolerated. This is in the phase 3 trial showing that asciminib side effects are less than the bosutinib, which was used as a comparator in this trial. How about the quality of life? We spoke about the quality of life. And in the phase 3 trial, if the chart goes to the left, then the quality of life has improved after the switch. And you can see here the side effects that have been looked at in the trial, and all the side effects that we spoke about, like the pain, the lack of sleep, lack of appetite, the feelings of sadness is there. And you can see the green bars reflect the asciminib, and all the bars are directing towards the negative side, which means that they have improved and they have been reduced after the switch, compared to bosutinib, where some have improved, some quality of life has improved, but some have not improved. So again, showing the tolerance of the medication. How about the efficacy? Do we reduce the efficacy of the medication if we switch? And you can see the primary endpoint has been achieved. There is a 12.2% MMR achievement difference and bosutinib. And at the end, in ASH 2023, an update was published, which has shown that the MMR achievement has even increased more to 23% difference between asciminib and bosutinib. How about time to treatment failure? Again, the time to treatment failure, asciminib, 50% of patients did not require any change in medication, while almost 90% of the bosutinib patients required a change in their medication. So significant difference between the two in the terms of time to treatment failure compared the two arms. How about the 3 months ABL transcription level difference? And you can see that to achieve this PCR-ABL marker for efficacy, you can see that there is a difference between asciminib and the other TKIs. Almost 47% of patients achieve MMR3 after starting it. MMR2, 84% of patients, and less than 10% is 92% of the patients achieve that marker of efficacy. So it's quite an efficacious medication in terms of achieving these levels. compared to the rest. So in summary, we are entering a new era of CML therapy. Novel agent Ssbmt has a novel mechanism of action which has the potential of transforming the therapy of CML. It has a favorable side effect profile compared to the others and similar efficacy. It's highly efficacious due to its unique site of inhibition. And now we have, as hematologists, we have to think in a different way. Those of us who treat Hodgkin's lymphoma have gone through this before, is that when you achieve highly efficacious therapy levels, then the emphasis becomes on improving the quality of life. In addition to keeping the efficacy that you have to think about what are the means through which you can achieve a better quality of life for our patients. And doing this and having the skills of being able to switch appropriately with new therapies, I think is something that we all have to think about for the future benefit of our patients. And with this, I end my talk. Thank you for listening.
All right, Dr. Ihab, thank you very much. We'll leave the question to the end of the session. Our next talk is about the CAR T-cell in multiple myeloma. And this talk will be presented by Dr. Samir Al-Amoudi. He's a consultant in adult hematology and PMT. He's a section head of stem cell transplant and cellular therapy at Princess Noor Oncology Center at King Abdulaziz Medical City, Ministry of National Guard Hospital, Riyadh, in Jeddah. Dr. Samir. He's not here. Okay. So meanwhile, we'll take questions for Dr. Ihab. Go ahead. Can you have the mic here, please?
Thank you very much, Dr. Ala Alwan from Baghdad, Iraq. I would like to ask about, with this plethora of TKI, how you will position for which you will give Ssbmt or ponatinib, or apart from T315I, how you will position these TKI, for which patient you will give this, and for which patient this is the question. Thank you.
Thank you for the question. Yes, we are spoiled for choice, so that's a nice problem to have many choices for your patients. Currently, the Saudi FDA approval is for Ssbmt is being after 2 lines of therapy. So that's where we are positioning Ssbmt is after 2 lines of therapy currently. Obviously, this can change with the change in evidence that comes through. What we are doing at our center, obviously, we have our own guidelines that we follow. We are using 2nd generation TKIs for those that are high intermediate risk CML, and we're using imatinib for those who are low risk CML patients. And then we switch if there is a need in cases of intolerance to one of the other 2nd generation TKIs if they started on imatinib. If they started on a 2nd generation TKI, we can switch to the other one if it is obviously it is available. So we use nilotinib and dasatinib.
Thank you very much. Any other question for Dr. Ihab? Okay, so we'll move to the next session. So it's my pleasure to present Dr. Samir Al-Amoudi. He's head section of stem cell transplant cellular therapy, Princess Noor Oncology Center. King Abdulaziz Medical City in Jeddah. And he will present a CAR T cell for multiple myeloma.
Assalamu alaikum. Good morning, everybody. Thanks for the introduction. I want to thank the Ssbmt and the organizer committee for invitation to talk about CAR T cell in multiple myeloma. So, as we know, so from locomotion study, actually, so they look, actually, it's real world study. Look at the patient, actually, they are refractory or relapse on multiple myeloma therapy. And what the outcome for these types of patients. So here, as you can see, this one seems not working. So actually, the overall response rate around 28%, and these like the different lines of therapy. And so here you can see the median progression-free survival was around 4.6 months, and the median overall survival around almost 1 year. So what's the solution for that? What's next? You have patients that are refractory or relapse, and what's the next step for them? It's CAR T cell. So before talking about the CAR T cells, just we'll talk about some structure about the plasma cells. So plasma cell, actually, there are several antigen-presented plasma cells. So as you can see, there is CD138, K light chain, CD19. But the most thing that I will be interested in was the B cell maturation antigen, BCMA. Why that? Because you can see it's expressed in the B cells, but you can see it's over or heavily expressed in the malignant plasma cells, as you can see at the end. So it's overexpressed and heavily expressed in the malignant plasma cells. It can express also in the normal cells, actually. So here it's the same. So you can see that's expressed in other cells, but you can see how the number of copies of plasma or B cell maturation antigen in the plasmacytoma can express also in the lymph node and blood lymphocyte. And this, like BCMA, it's important in the cell growth and survival. So what are the two current approved CAR T cell in multiple myeloma? So currently, actually, we have two products that are approved in multiple myeloma. So the first one, which is the ID cell, it's approved in 2021. The second is Cilta-cel, it's approved in 2022. So ID cell, actually, it's like second generation CAR T cell, anti-BCMA, murine, it's FV with 4-1BB co-stimulatory domain. The Cilta-cel, second generation CAR T cell, also it's targeted BCMA, but it's two BCMA. So what are the studies that leads to approval of these products? So start with the first one, which is the KARMA study, which lead to approval of ID cell, actually. So you can see here they included the patient, they have like refractory to 3 or more lines of therapy, and they did the process of the leukapheresis, then bridging therapy, then reinfused the products again. So actually here you can see the primary endpoint with the overall response rate. So if you look at so here actually they give different doses. So you can see there is the 150, the 300, and 450. So if you look at overall response rate around 73%, this is actually good because we are talking about patients who are refractory to 3 lines of therapy. So overall response rate around 73%. And if you look based on the dose, actually, the overall response rate 82% if the patient received 450 dose, compared 50% if received the 150 dose. And if you look at about the duration response, you can see here, as I mentioned, so this is the blue line, it represents actually the dose of 450. It's better compared the patient received the green light, which is the green lines, which is green dots, which is the 150. Duration of response, according to best response, if the patient achieve after the infusion CR or CRI, actually, or stringent CR, they do better compared the patient still having like PR disease. And also, if you look at the overall survival, the same. The patient received the full dose, they do better compare if they receive the 150 dose. Here, if you look at subgroup analysis, actually most of the patients actually favor the CAR T cell, the ID cell, except if the patient, as I mentioned earlier, received the smaller dose, which is the 150, will not favor the CAR T cell. What about the second product? So second product, which is the Cilta-cel. The same, so the study is called CARTITUDE 1, actually. So also included patients who is actually they're refractory to three or more lines of therapy, including PI, IMID, and anti-CD33 antibodies. But here, actually, in cilta-cel, it's not like ide-cel. Cilta-cel, actually, it's like fixed you give the dose based on the weight, actually. So the dose given based on the weight. So you can see the overall response rate around in 97 patients, it's around 97%, and around 80% they achieve stringent CR. And if this is the updated, actually, so if you look at the time, like so the progression-free survival around almost 35 months, overall survival actually is not reached. So, and you look actually, if you look at this, also the study, CARTITUDE. So if you see the patient, they achieve actually CR or the MRD negativity, actually they do very much better compared to they achieve that response. So what about, so this is what we're talking about patient and clinical trial. So in real life, so we know this, some patients, they are not eligible to the, to be eligible for this clinical trial. So what are the data about the therapy outside the clinical trial? So to answer that, actually we have like two, this actually real world study. So they look actually one actually for the ide-cel, the second cilta-cel. Still, so these patients actually were excluded from the clinical trial where they are not eligible for many reasons, either organ failure, or there was previous therapy, anti-BCMA. Regardless of the cause, even though they underwent CAR T-cell, you can see here, like, the progression-free survival actually around almost like 7 months, with the median follow-up 5 months. So these like patients that are refractory to multiple lines of therapy and they're not fit for the clinical trial. The same also for the cilta-cel. You can see these types of patients also the median follow-up around 5 months, and with the 6-month progression-free survival around 79%. So still, if the patient are not fit clinical trial, still they can, real world data show that they showed benefit from the CAR T-cell. So CAR T-cell approved like after failure of the, after a patient received 3rd or 4th line of therapy. So can you move CAR T-cell earlier? So to answer that, actually there is 2 studies. One, the KarMMa-2, phase 2 study actually for ide-cel. They included patient early relapse within 18 months after autologous stem cell transplant. And there is the CARTITUDE-2 cohort study, actually evaluated cilta-cel after 1 to 3 period lines of therapy. So what is the result? So this is the KarMMa. And the result for that, you can see the ide-cel given a second-line therapy showed overall response rate around 83%, CR rate around 45%, and MRD achieved negativity around 85% of the patient. Median progression-free survival almost 11 months. What about the CARTITUDE-2? The same, showed almost the same response, so overall around 95% of our response rate, CR 90%, 75% with the 12-month progression-free survival. Median not yet reached. So what else? So actually this is like the phase 3 trial, the KarMMa-3 and CARTITUDE. So I'll talk about first the KarMMa-3, so it's phase 3 trial. Actually, and the patient received 2 or 4 period line of therapy. So this is eligibility. So actually this patient actually, they receive 2 or 4 lines of therapy. They receive either the standard of therapy, randomized, either receive standard of therapy or the CAR T-cell. Then they will look about the primary endpoint, which is progression-free survival. So actually here you can see with median follow-up 18 months. So the ide-cel actually median progression-free survival 13 months compared to standard regimen, which is 4 months. So here we have phase 3 trial about the CAR T-cell, which you can use after if the patient failed multiple lines of therapy. Not only that, you can see the outcome also. If the patient achieves MRD negativity, the outcome will be better. So you can see here, so the MRD negativity achieved, so the median progression-free survival will be around 17 months compared to the one who didn't achieve MRD negativity. This is at 6 months follow-up. At 1 year, you can see if the patient achieves MRD negativity, they do better with around 14 months progression-free survival. So actually, so the most important thing, so usually we treat the patient either by CAR T-cell or autologous transplant, and the patient achieves, let's say, CR or a very good partial remission, but what about the quality of life, which is important for the patient? So the patient, his disease is in good, his disease like with excellent response, but what about the quality of life? So here actually it shows that with the patient who achieve actually CAR T-cell, actually the quality of life is good and favor that compare if the patient receives standard of therapy. So this is very important slide. So this reflects about the outcome of the patient multiple myeloma if they have high risk feature. So you can see here the progression-free survival differ, it depends. So let's say, so here actually the overall survival around progression-free survival 13 months, but if the patient has high risk cytogenetic feature, so they do actually better with the CAR T-cell compared to the, sorry, this one not working. So second graph actually has high risk cytogenetic feature. The ID-cell group, they do better compared to the standard regimen. Also, if the patient has RISS stage 3, they do better with the CAR T-cell. If the patient has high tumor burden, actually they do better with ID-cell. If the patient has extramedullary disease, you can see the progression-free survival almost 7 months, which is difficult to control sometimes. If the patient having like triple classes refractory disease, so actually with the CAR T-cell, will be better. What about the CARTITUDE, which is about cell-to-cell? This is almost also phase 3 clinical trial. So you can see with the median follow-up 15 months, actually the progression-free survival is better with the CAR T-cell group, the cell-to-cell, compared to the standard regimen of therapy. And this is also showed us here about the progression-free survival and comparing with the, depend how many lines of therapy the patient receives. So let's say, actually the cell-to-cell group, they better compared to standard of care, but if the patient receives only 1 line of therapy, they do better compared the patient receive 2 or 3 lines of therapy, the same with the the standard of care. So this is the future. Actually, the future now, they're moving, the plan to move CAR T-cell earlier. So this actually to CARTITUDE 5 and 6. So CARTITUDE 5, actually they say the patient who is not eligible for transplant, then will be randomized either to see if like the standard of care, and in addition to the CAR T-cell. And they will look for the result. Or even if the patient eligible for autologous stem cell transplant, so the patient will be randomized either to receive the autologous stem cell transplant or the CAR T-cell. So we'll wait the result of these 2 clinical trials. So we'll talk about the efficacy about this CAR T-cell now. So what about the safety profile? So actually CAR T-cell has several toxicity. One of them is cytokines release syndrome, ICANS, cytopenia, and hypogammaglobulinemia. So it's important also to look for that. So CRS, so what actually is triggered by activation of T cells, lead to release of the cytokines within, especially interleukin 6, so it leads to the patient start to have symptoms, fever, hypotension, and hypoxia. So, and there is a grade 1, 2, 3, 4, and based on grade, usually we treat the patients. So what about, so this is actually just to show us about the incidence of CRS comparing 2 products, the ID-cell compared to cell-to-cell. So you can see the CRS grade 1 or more, it happened around like 84% in the ID-cell group compared 90, which is more in the cell-to-cell group. And not only that, so that's just to show you the median onset of CRS. So in ID-cell, actually it's 1 day. So if they give the product, so within 1 day, the patient can develop CRS. But for cell-to-cell, take about 7 days. And median duration of the days actually around 5 in the ID-cell group compared to the cell-to-cell. What about neurotoxicity? So neurotoxicity actually grade 1 or more in ID-cell, around 18% compared to 20%, almost 21% in cell group. So here actually showed us the infection. So actually the percentage of infection grade 3 or more, almost comparable in both groups. COVID actually is not, wasn't mentioned in that study actually. So what about cytopenia? It's one of the complications either due to lymphodepletion, But you can see here the median onset of the time until count recovery around 2 months in the ide-cel group, and 60-70% of the cilta-cel group actually recovered by day 30. So by that, I conclude my presentation. Thank you.
Thank you so much, Dr. Samir. We'll leave the questions to the end.
Okay.
Now I would like to invite Dr. Mohsen Al-Zahrani to the stage. Dr. Mohsen Al-Zahrani is a consultant hematology and stem cell transplant. He's the head division of stem cell transplant and cellular therapy at King Abdulaziz Medical City, Riyadh. He will talk about the role of CAR-T in management of acute lymphoblastic leukemia.
Assalamu alaikum. Good morning, everyone. Thank you, Dr. Hind, for the introduction. Thank you, the scientific committee, for inviting me to present in the meeting today. So I was given the task to talk about CAR-T role in ALL. This is my disclosure. As you know, the relapsed refractory ALL carry very poor prognosis. And in these two studies, large two studies showing that the 5-year overall survival in relapsed refractory ALL is less than 10%. Actually, in the first study, 7%, and the second study, 8%. So it's very poor prognosis. Now, even after the introduction of novel agents like BiTE therapy or bispecific, there is improvement, but it is the long-term survival achieved here is only 20%. So the prognosis here is dismal. The chimeric antigen receptors came into the field as a treatment of this type of disease. And the CAR-T is a modified, genetically modified T cells that will carry this CAR receptors, again, specific antigens on cancer cells that will maintain the control of the disease. CD19 is an interesting antigen to target on B-cell malignancies. As you see, it's expressed in different phases of B-cell development. Inside the bone marrow, you can have ALL, and the CAR-T can target ALL, and in the lymph node where the lymphoma will develop, so the CAR-T here can be used to treat lymphoma. And these are the two main types of the anti-CD19 CAR-T constructs. The main differences here is the co-stimulatory domain. We have two co-stimulatory domains, the CD28 and 4-1BB, and this will give some features regarding the proliferation, expansion, and disease control. So we have two co-stimulatory domains. In comparison to 4-1BB, the CD28 co-stimulatory domain is associated with rapid expansion, as you see in the left side figure. Rapid expansion, and this can be associated with higher risk of toxicity like CRS, ICANS, but earlier exhaustion and lack of persistence, and this is clearly demonstrated in the clinical trial using the CD28 CAR-T. So FDA-approved CAR-T cell therapy in different diseases, but basically in ALL there are two products approved. Proxacel for adult patient age more than 18 with relapsed refractory B-cell ALL, and Tisa-cel for pediatric patient up to the age of 25 with PALL that is refractory on second or later relapse. So the first product approved is Tisa-cel, or Kymriah, was approved by FDA in August 2017. For pediatric patient up to the age of 25 with BALL that is refractory in second or later relapse. And the CR overall response here was 83%, with the CR 63%, and all patients had MRD negative. And in the initial report, the overall response was 81%, CR 60%, majority MRD negative. Overall survival was 19.1 months, and the event-free survival was not reached. The 3-year follow-up showed the 3-year event-free survival was 44%, and 3-year overall survival 62%. The latest follow-up at 5 years showing that the 5-year event-free survival was 42% and overall survival 55%. So if you compare this to the initial two studies, the first two slides that I show, the traditional therapy for relapsed refractory ALL, the long-term survival was less than 10%, and with bispecific antibodies it was 20%. So this compared favorable to the old type of therapy. And this was also confirmed in the real-world evidence. We have in this table in the second column the Ssbmt data for large number of patients, 249 patients. The result regarding response, event-free survival, overall survival in the real-world data was almost equal to the pivotal trial, where the CR was achieved in overall response was achieved in 85% in the real-world data. Event-free survival at 12 months was 52%, and overall survival at 12 months 77.2%. The second CAR-T approved is Brexucil, and this is used mainly for adult patients 18 years or older. And this is ZUMA-3 study, phase 2, single-arm, open-label, multi-center. 55 patients infused. Previous blinatumomab was used in 46% of the patient, and allogenic transplant was used in 39% prior to CAR-T patient. Regarding the responses, you see 71% overall response. CR was 56%. And the relapse-free survival was 58%, and overall survival was 71%. And this is large systematic review of 16 studies, 489 patients. The cumulative 12-month progression-free survival 37%, and 12-month overall survival 57%. But the major problem here is so we can cure, like you can say, from 40 to 50% of the patient. Still 40% of the patients they relapse post CAR-T. So this we need to target this population of the patient to reduce the risk of relapse by intervention, either pre-CAR-T or after CAR-T. So if we look to this group, the non-responder and relapse, this is a study from multi-center from USA with the use of T-cell CAR-T 185, children and young adolescent. 80 patients relapsed, 12.5 were not responder, and 36% relapsed. The 12 months overall survival was lower than the whole group here. The 12-month overall survival was 19% for the non-responder and 52% for the relapsed cases. And for the whole group from the Eliana study, it was more than 70% 12-month overall survival. So we need to look to this target, and in the next few slides, I will try to take you over different factors that can correlate with increased risk of relapse or non-response post-CAR-T, and if we need to do different type of therapies or modifications to reduce the risk of relapse. So there are multiple factors that can correlate with the increased risk of relapse, including the type of the CAR-T cell construct, either 4-1BB or CD28 costimulatory domain, the T-cell phenotype at the time of transduction, baseline disease characteristics like leukemia cytogenetic, molecular targets, previous therapies before CAR-T, either blinatumomab, transplant, or other agent, factors at the time of the infusion like bone marrow disease burden, extramedullary disease, CD19 antigen load, lymphodepletion type, and post-infusion factor like the persistence of CAR-T or loss of B-cell aplasia, detectable NGS, post-CAR-T infusion, and CD19 expression. So the first one is the type of the co-stimulatory domain. As I told you, there are two types, 41BB and CD28. And as you see here, if we look to the CR, these are the 5 studies using different types of the co-stimulatory domain, the first 3 columns for 41BB and the last 2 columns for CD28. If you look to the CR, the rate of CR is lower in studies that use the CD28 domain, co-stimulatory domain, and even the event-free survivor, overall survivor is also lower in this study that use the CD28 co-stimulatory domain. So based on this, some guidelines recommend you may need to do transplant as a consolidation post CAR-T using the CD28 co-stimulatory domain. The T cell phenotype at the time of transduction is also important. The immunophenotype of T cells used to manufacture CAR-T cells has also been studied and shown to influence the CAR-T cell persistence, expansion, and long-term activity. There are compelling data demonstrate that T cell population enriched for early lineage cells have improved expansion, and that early lineage cells are selectively depleted with continued courses of chemotherapy. So this is very important. When you give multiple lines of treatment, you will exhaust or reduce the early line T cell at the development of the T cells, and this can be associated with worse outcomes. So once the patient is relapsing, it's better to take him to CAR-T if there is indication, and avoid delay and exposing the patient to multiple lines of the treatment. The other important factor is the baseline leukemia genetic at the time of the diagnosis. So this study, they looked to 230 adult and pediatric patients who were treated with CAR-T, and they stratified them by the cytogenetic risk or molecular risk into high risk, intermediate, favorable, and uninformative, depending on the genetic markers. And as you see, the relapse-free survivor and overall survivor post-CAR-T was not different whether the patient is in the high-risk group or the lower-risk group. So all of them, they will have similar response post-CAR-T. There was one Chinese study showing that TP53 mutation at the time of the diagnosis may associate with lower leukemia-free survivor and overall survivor. So this patient, we know TP53 is in general is associated with very poor prognosis in many malignancies. So we may need to target this population with different approach. Now the impact of CD19 targeted therapy, exposure to like blinatumomab prior to CAR-T. So this is a large retrospective study, 420 patients, median age 12.7, treated with Ssbmt or other CAR-T. 18% received prior blinatumomab. If you see the figure in the upper part there, the CR rate is different in the group who had CR to blina compared to those who did not have CR to blina. So if the patient doesn't have CR to prior exposure to blina, they may have lower rate of CR post-CAR-T. Also, the same thing, the event-free survivor, relapse-free survivor, and overall survivor is lower in the group that did not have a response to prior exposure to blinatumomab prior to CAR-T. The disease burden at the time of the infusion is also important. In the same study shown in the previous slide, they looked to the disease burden at the time of the infusion. And they divide them into high disease burden, low disease burden. The high disease burden defined by more than 5% blast in the bone marrow. And as you see in the blue curve, the high disease burden, they have lower event-free survivor, relapse-free survivor, and overall survivor. So we should have some interventions to reduce the disease burden prior to the infusion of the CAR-T by giving bridging treatment or by intervention post-CAR-T. Also, this was shown in other studies from Memorial Sloan Kettering. Those with high disease burden, they have lower probability of survival. And in this other study also showed the same effect. So this is a strong prognostic factor. What about the extramedullary disease? In general, those with non-CNS extramedullary disease tend to do less favorable after CAR-T treatment. And in this study by Elizabeth from multiple USA centers, 180 patients, 21% had extramedullary disease. The response at best was 72%. As you see in the figure there, different organs involvement. The red bars indicate the extramedullary disease involvement at the presentation, prior to CAR-T, and the blue bars post-CAR-T. So as you see, not all organs respond to CAR-T infusion. And this was proven in other studies, in Ssbmt study. The CR/CR8 was 50% lower in extramedullary disease. And also in the City of Hope, and in the larger prospective consortium study, also they have shown worse event-free survival in extramedullary disease. What about CNS disease? CNS disease involvement did not impact the outcome post-CAR-T. And in this large study from CHOP, 195 patients, majority had CNS negative disease, 66%, 34% had systemic plus CNS disease, and 22% had isolated CNS involvement. So CNS disease did not impact the outcome, as you see in the curves there. In the left side, in figure B and D, even the CNS involvement is associated with better responses and overall survival compared to systemic disease. So those patients with CNS involvement can be considered for CAR-T. Attempts should be made to try to reduce the disease burden in the CNS prior to CAR-T cell infusion to reduce the risk of ICANS. And caution should be practiced considering the risk of ICANS and the use of prophylactic anti-epileptic post-CAR-T infusion. What about the MRD post-CAR-T? So we know MRD is a very strong predictive prognostic factor post in the treatment of ALL, and this also has been shown post-CAR-T. And patients who did not achieve MRD post-CAR-T at day 28 and 3 months, they had they have worse outcome regarding event-free survival in this study. Also in the Liana study, they studied the impact of MRD and the B-cell aplasia. If you see the left figure there, those who had MRD 0, the curve is much better than those who had MRD positive. Even if the patient was still in B-cell aplasia and MRD positive, they tend to have worse prognosis. And also in Ssbmt study, CAR-T cell persistence did not impact the outcome. So even if the patient have CAR-T resistant, they will tend to relapse. So if there is no detectable CAR-T cells beyond 6 months, the area under the curve of CAR-T cells not correlated with duration of response. And they have shown here most patients recover B cells by 6 months, but no correlation with duration of response. So in Ssbmt, if the patient lost the B cell aplasia after 6 months, this was not correlated with worse outcome. But prior to 6 months, yes, there may be increased risk of relapse. In these two studies, they show different result, where if there is loss of B-cell aplasia, there is increased risk of relapse. The first study from Seattle, PLAT-02 trial, 45 patients, loss of B-cell aplasia was associated with increased relapse risk. And the other study from CHOP, where they used humanized CD19 CAR-T, 74 patients were treated at the time, and the B-cell recovery was associated with worse relapse-free survival, as you see in the blue line there in the figure there. Now, at the time of the relapse, we have 3 types of relapse: CD19 positive, in the majority of the cases, CD19 negative, and there is lineage switch. So the factors that the group that may have CD19 positive relapse is patient with 2 or more previous remissions. The group that may have CD19 negative relapse, those who were exposed to 4-1BB co-stimulatory domain, prior blinatumomab non-response, higher disease burden, and older age. And the lineage switch usually is associated with KMT2A rearrangement, as shown in this retrospective study, 420 patients. So in general, the relapse is around 40%. Now, we studied the factors that can correlate to increase risk of relapse. Regarding interventions post-CAR T to reduce risk of relapse or to treat relapses, one of the important interventions, of course, is allogeneic stem cell transplant. So in this Ssbmt study, they studied the patient who underwent CAR T, and they compared the group that received transplant to the group that did not receive transplant post-CAR T, and there was no difference in the outcome between both groups, as you see in the figures here, to those who received subsequent transplant versus those who received CAR T alone. The overall survival was the same. Also, this was shown in other studies. The upper figure from Memorial Sloan Kettering, there is no impact of transplant post-CAR T in improving the outcome. And also from Fred Hutch, also there is no impact on the relapse risk by receiving or not receiving the transplant. However, there are some studies showed some benefit from a transplant, as shown in these two studies. The first study there from University of Pennsylvania, there is positive impact of transplant post-CAR T, as you see regarding the overall survival and event-free survival. And in the BLOOD-02 study, there is some improvement in the leukemia-free survival, but was not statistically significant. However, it was statistically significant in those who have short B-cell aplasia. So in those patients who have short B-cell aplasia, there may be benefit of doing transplant. Also, in this large study using T-cell real-world data, 26% of underwent post-CAR T allogeneic transplant, 13% of the patient in CR, and 12% after relapse, and 1% for post-CAR T MDS. As you see, the curves of overall survival, event-free survival, duration of response, and the duration of B-cell aplasia was maintained, showing that favorable effect of transplant post-CAR T in this situation. So in this paper from Blood by Myers, they tend to show, based on the factors that we presented, you may have different approach to reduce the risk of relapse. So if we take the pre-infusion risk factors, we can divide them into standard risk, where you expect event-free survival more than 50%, and the group here, the standard risk, less than 5% blast pre-infusion, so low disease burden, or no other risk factors. So what you will do for this patient, you will do just post-CAR T monitoring by monitoring the MRD either by NGS or BCR, or monitoring B-cell aplasia. If the patient did not develop MRD positivity and he continued to B-cell aplasia, he will stay in the standard risk. And we have the high risk group. They have more than 5% blast pre-infusion or prior non-response to blinatumomab. You can consider transplant for this group and initiate donor workup, or the other alternative, you just do the monitoring, and if the patient become positive or lost the B-cell aplasia, you can take him to the approach that we mentioned later on. And the baseline genetic factors of the disease, as we mentioned, it did not impact the outcome post-CAR T, except the B53. So B53, you may put them in the higher risk group. And post-infusion risk factors, we have very high risk group where the event-free survival less than 10%. Those who lost the MRD at day 28 or 3 months, or those who lost B-cell aplasia prior to 6 months. And in this group, the treatment options can be consolidative transplant, CAR T-cell reinfusion, especially if you target other antigen like CD22, if the patient lost CD19, alternative CAR T cell infusions, or other experimental strategies. So in summary, CD19 CAR T cells have transformed to the treatment of relapsed refractory BLL, and now the responses reach 80% overall, and CR more than 60%, leukemia-free survival more than 30%, and overall survival more than 60%. This compares favorable to the traditional treatment without CAR T, less than 10%, and with Blina or Ssbmt 20% overall survival. Relapse after CAR T therapy remains a substantial concern for many treated patients. So we have to apply risk factors and look to the risk factors associated with the success or failure of the therapy to optimize the outcome, and this is crucial. Post-CAR T transplant can be considered for those who are at high risk of relapse, those who have pre-infusion high disease burden or persistence MRD post-CAR T infusion. Thank you very much.
All right, thank you, Dr. Mohsen. Now we'll move to the next session, which will be treatment of chronic GVHD updates. And this session will be presented by Dr. Mundir Al-Maliki. He's an associate professor in the Department of Hematology and Hematopoietic Cell Transplantation. He's also the director of Unrelated Donor BNT program and the Haploidentical Transplant program at the City of Hope National Medical Center. Dr. Mundir.
Thank you. Assalamu alaikum. Good morning, everyone. If I can get my slides. Good, thank you. Apologize for the wait. Great, thank you. Sorry about that, and okay, now it's working. I'm gonna get rid of that. Okay, so sorry about the delay, and I'll start with the slides. Chronic graft-versus-host disease is a multi-system fibroinflammatory process seen in 50 to 70% of the transplant patients. Organ damage caused by alloreactive T cells, B cells, and macrophages. It remains the most common cause of late non-relapse mortality. And we have seen increase in rate of incidence and severity of this disease in the last couple of decades. That's due to increased use of unrelated donor, BBSC graft, and the switch from bone marrow to peripheral blood, older patients, and more recent data showing even older donors, myeloablative regimen, and prior incidence of AGVHD and HLA mismatch All those factors have shown recently to increase the rate of GVHD. The slides I'm showing now is showing annual number of allogeneic and autologous transplant reported to CIBMTR from the United States. And as you can see here, consistent increase in the number of allogeneic transplants. And now number have passed 12,000 annually. So, and looking at the number of transplant by donor type, as you can see here in blue color, match-related donor transplant have been the largest group up until 2010, when match-unrelated donors start to grow and became the largest number of transplants in the current years. Similar trend we are seeing with more BBSC compared to bone marrow, and now it is reported around the rate of 10% only of the transplant using bone marrow grafts. In this paper, with all the growths that I've shown and all those risk factors, this paper shows the reflection, as you can see on the curve here, increase chronic graft-versus-host disease over the years, and later on we'll show more details about that. And as we say, prevention is the better than cure. Those are some recent strategies shown to reduce the incidence and severity of chronic graft-versus-host disease. They all targeting removal or alloreactive T cells, either in vivo or ex vivo. In these slides, I'm showing graft-versus-host disease prophylaxis platform used in the last decade. And as we can see here, the green showing the rapid increase in the use of post-transplant cyclophosphamide due to the data emerging about the benefit in reducing both AGVHD and chronic GVHD incidence and severity, regardless of the type of the donor. So now almost 30% of transplants are done based on a post-transplant cyclophosphamide platform. In this European study, we can see the difference in chronic graft-versus-host disease in patients receiving ATG versus no ATG in a randomized phase 3 fashion. In this paper, there was no increase in relapse or infection, while there was a subsequent paper from the American showing increase in relapse made that approach less favorable. In the CTN study 1703, which we have just published in New England Journal of Medicine, we showed with multi-center randomized fashion that GVHD is less when post-transplant cyclophosphamide is used in the reduced intensity conditioning and peripheral blood stem cell transplant. Short-term follow-up so far showing no increase in relapse in this approach. In this study, 430 patients were randomized blindly to either tacrolimus methotrexate or post-transplant cyclophosphamide and tacrolimus and MMF. Primary endpoint, as shown here on the curve, is graft-versus-host disease-free, relapse-free survival. And as you can see, significant improvement with post-transplant cyclophosphamide group. This is considered the new standard of care, at least in the United States now, in patients undergoing reduced intensity conditioning peripheral blood stem cell transplant from a match donor. Other strategies to decrease the chronic graft-versus-host disease, including graft manipulation strategy. And as you can see here, those are different methods that allow us to remove the T cells ex vivo. In a CTN study published, I think, 10 years ago or so, more than that, 2 years ago, patients were randomized to 3 different approaches in a myeloablative conditioning in younger patients. Patients received CD34 depletion, bone marrow with post-transplant cyclophosphamide as a single agent, and a tacrolimus methotrexate, what was thought to be the standard of care at that time. And as we can see here, even though all those approaches were equal in decreasing chronic graft-versus-host disease, Overall survival was lower with patient receiving CD34 depletion, most likely due to infection and relapse, similar to what we've seen in ATG as well from the Dana-Farber study. Again, making this approach less favorable. Another approach is T-cell depletion of CD45RA, which is the naive T-cells. And by removing the naive T-cells, which are responsible for growing graft versus host disease, we are leaving memory cells that are important for fighting infection and relapse. Also, some of the other cells that are important, like NK cells, are left behind in the graft. And this study was shown here, showing excellent results, but in single-center approach, and need to be reproduced in multi-center study, especially in the setting of complicated graft manipulation process. Another recent advances that have been, a little more focused on recently in the last couple of ASH is the Tregs TCONS approach. And in this approach, Tregs are infused with CD34 depleted stem cells on day 0 for Tregs to be allowed to expand and to prevent GVHD. And then later in 2 days, TCONS, which is similar to the donor lymphocytes infusion, just regular T cells, are given on day 2 to allow prevention of infection and relapse. In this phase 1b/2 multi-center study, donors were 8 out of 8 matched with myeloablative regimen and showing excellent rate of GVHD again, allowing the company that sponsored that study to proceed with a phase 3 randomization against dacrometotrexate, which is supposed to be, which was thought to be a standard of care at that time. So now, how does the chronic graft versus host disease develop? We have 3 phases. Phase 1, as you can see in this cartoon, is characterized by tissue damage resulting in the translocation of bacteria and fungi, leading to the release of PAMPs and DAMPs. And those are pro-inflammatory substance. They activate multiple receptors, including, as you can see here on the left side, P2X7 and P2Y2, ST2TLR, and NOD-R. All of those substances lead to endothelial cell injury and inflammation, including antimal arthritis and loss of microvessels. This also will lead to platelet activation and von Willebrand factor release. All of this process will allow more inflammation to propagate. In phase 2, effector population, including adaptive system, including alloreactive B cells, T cells, they both are getting primed with antigen presentation and lead to expansion and polarization towards more effective, more effector cells as type 1, type 2, and type 17 helper. The activation will lead to multiple cytokine secretion, leading to more activation further. And at that time, conditioning-induced damage to the thymic tissue also lead to decrease in the Tregs population. That is supposed to help with the peripheral tolerance, which is lost in this setting. In phase 3, which is the last phase of this process, activated macrophages will produce PDGFR and TGF-beta. Both lead to fibroblast activation, forming extracellular matrix and sclerotic phenotype. Now, at the same time, with the activated B cells, making by those BAF factors will produce pathogenic immunoglobulin, and those will be deposited further in the organs, causing more damage and fibrosis. So that's kind of like a summarize of this important paper on the pathophysiology of GVHD. Now, the diagnosis of chronic graft versus host disease was always based on the time before or after day 100. But the new consensus from NIH showed that this is mostly should be based on the clinical symptoms. We have diagnostic features, which is sufficient to diagnose GVHD, and distinctive feature, which is suggestive only for GVHD, as you can see on those two lists. With those graded together, an NIH severity score will be able to differentiate for us mild chronic GVHD, moderate, and severe. This is important for prognostication as well as treatment approaches. And once GVHD developed, we have 3 levels where we could interfere to either stop the progression of GVHD or make it milder. We have the level of alloreactive T cells, where we can see, as you can see on the left side, we've discussed how we can remove those T cells to prevent or decrease GVHD. And on the right side with orange box there, you can see how we can inhibit T cell signaling through different type of pathways. Second level will be alloreactive, first before that, Tregs level, which we could adaptive transfer those cells when we are, purify them from different donors. That's one way to do it. Other way, on the right side, as you can see, we have techniques that spare Tregs, including sirolimus, Cellcept, Rox, and bortezomib. Or we could expand it in vivo, including ECP or low-dose IL-2. The last level of interference, which we can do for management for those patients, is B-cell, alloreactive B cells. And this, we can use, a depletion process by CD19-directed therapy, or we could inhibit the B-cell signaling by either BTK inhibitor or SEC inhibitor. So, corticosteroids have been, the cornerstone in treating GVHD with response rate close to 40-50%. Multiple attempts have been, over the years tried to add second agent for upfront setting and, trying to improve the response rates, but all failed, as you can see here. All of this leading to either corticosteroid refractoriness or dependency, and they have different definition for those. Beside all of that, as you all know and aware of, the side effects of steroids and possibility of intolerance. And steroid refractory GVHD is really difficult disease management. There is no real consensus. As you can see here, NCCN have listed every single drug that you could have. But really, basically, recently, FDA has approved 3 drugs back-to-back based on decent evidence in this population. Starting by ibrutinib, it's a proton tyrosine kinase inhibitor, was approved for chronic graft versus host disease based on phase 1b/2 study in only 42 patients with steroid refractory GVHD. In this study, patients were selected based on erythematous rash or mouth. So very spiky type of, early inflamed GVHD type of approach. Patient received 420 milligram of the ibrutinib until progression or toxicities. And as you can see in this slide, best overall response was 67%, but with only 20% CR. Around 70% had sustained response for 20 weeks or more. No specific organ had better response, but as we said before, most of those patients had only skin and mouth. Safety and AEs reported on the study were similar to what we've seen in ibrutinib, including fatigue, some GI symptoms, and some bruising, rarely cardiac issues. This is the Rockstar study, which is a phase 2 study of belmosudil, where more advanced cases were included. As you can see here on the left side, 2 to 5 prior lines of therapy were allowed Patients were randomized to 2 different doses, 200 milligram daily or 200 milligram twice a day, in a larger sample size of 120 patients. Best overall response was 76%, mostly partial response, and CR was only 5% and, on the early endpoint. Median time to response was very short, 1.8, and you would see something on those patients, with a median duration of response of 50 weeks, so longer than what we've seen in ibrutinib. And we have data here showing that there is a good high response rate in GI and joints, GVHD, while response rate in lung was modest at 25%. AE on this drug were mostly low grade, fatigue, GI, LFTs, muscle spasms, but grade 3 and 4 were rare, in the range of 5 to 10, mostly pneumonia, hypertension, and hyperglycemia. Very important, I've seen patients with DKA, diabetes ketoacidosis, because of the drug, so that's one of the things that I've seen. AE were similar to both doses also, so increase in dose did not increase the side effects of the treatment. REACH3 is a study of 330 patients with the strongest evidence for this. Patients were older than 12 years old and are randomized to either Rox10, BID, or best supportive care, or best available therapy, I'm sorry. Overall response was 24 years, significant for ROX, around 50% compared to 25. Again, CR is expected in this population is low at 6.7, but I think with more time, it went up to 12%. Well tolerated with the grade 3 or above only, showing in a bone marrow suppression. Infection, as we can see here, is similar on both arms. Some of the attempts also try to use those novel agents upfront to try again to improve response rate of steroid, and also in this attempt of adding ibrutinib to prednisone also failed in having any positive results. Those, again, novel agents are under investigation, and the list is too long, but I'm going to pick 2 only. Axatilimab is a anti-CSF1 antibody targeting macrophage infiltration and activation. Usually is this the last step before activation of fibroblast. In a phase 1 to 2 single arm escalation and dose expansion, real sick patients included in this study with multiple prior lines of therapy. Most of them received all the 3 agents that are approved. And we see really good overall response of 60%, very promising drug. Some GI, mouth, and eye, which are difficult site to manage with the GVHD. Patient actually, even in the lung, had multiple cases of response. Now they have a study comparing 3 doses to see which dose is the best for expansion. Baricitinib is another, a 3rd or 4th, lost counting, of JAK inhibitor. It is, again, very promising with overall response close to 60% and seems to be more durable than what we see with other drugs. Beside the chronic graft-versus-host disease-directed therapy, supportive care is very important in this population, as you all know. I'm just going to summarize that we have to be careful with vaccination, IVIG replacement, infection prophylaxis, social and emotional support, and a lot of physical therapy for lungs and joints. So to conclude here, features of chronic graft-versus-host disease is heterogeneous. One size does not fit all. Prevention is better than cure. Long-term morbidity and mortality is significant. And risk of disease should not really allow us to think that we could cause chronic graft-versus-host disease to decrease relapse, because that has been shown in multiple studies that this is not true. Way safety profile drug against patient-specific symptoms and disease characteristics in making treatment decision. And cost and insurance, in different countries are factor to consider. Majority of patients with moderate to severe AGVH, this should be chronic graft-versus-host disease, were will need additional lines, and steroid will not be enough, and supportive care in this chronic illness is very important. Thank you.
Thank you so much, Dr. Munzir, for this excellent lecture. We'll leave the questions to the end. Now I would like to invite to the stage Dr. Ahmed Al-Huraiji. Dr. Ahmed is a consultant internal medicine and hematology at Kuwait Cancer Center. He will present bispecific in myeloma.
Assalamu alaikum. Good morning, everyone, and thanks to the organizing committee, Dr. Absi and Dr. Asker, for inviting me today. I think whoever attended last night's talk by Dr. Ayman and Dr. Ghazi on the BITES will consolidate his knowledge on the same topic. We will readdress the issue of bispecific T-cell engagers in the field of multiple myeloma. Just waiting for the slides. As you all know, the patients with relapsed refractory myeloma has many options nowadays. We are living in a transformative era where the bispecific T-cell engager and T-cell redirected therapy, such as the CAR T-cell therapy, are addressing an unmet medical needs in the field of relapsed refractory myeloma, and more specifically on the triple class refractory patients. Can we move on with I can talk without the slides if you want. So you all know that the triple class refractory patients who failed IMiDs, immunomodulator, proteasome inhibitor, based on the locomotion trial that looked into the patients who were triple class refractory. It was a prospective, non-interventional, multinational study looking at the real-world current standards on the triple class refractory patients, where they included around 250 patients who were triple class refractory. And as you can see here, the median progression-free survival is around 4 to 5 months, and those patients usually live for 1 year. So this represents an unmet medical needs. Moreover, the triple class refractory are evolving and growing in the early relapse refractory setting of myeloma, where we can see from this survey in 2020, they said that the triple class refractory in the second line is around 20%. And now I think more and more we're using the CD38 monoclonal antibody in the frontline setting, making the triple class refractory in the second line treatment is approaching, I would believe, 50 and 60%. As you know, the myeloma cell can be eliminated by bispecific T-cell engager through the T-cell activation, proliferation, and cytokine production. And we have 3 approved medication by the FDA, the teclistamab, on October 25th, 2022, where they approved the first bispecific in patients who failed at least 4 prior lines of therapy. And a year later, in August 2023, on the same month, they approved 2 medications, one anti-PCMA, which is elranatamab, and the other one, which is an GPRC5D bispecific T-cell engager, talquetamab. Now, these bispecific T-cell engager, usually the patients will respond in a proportion of around 2/3 of them, they would have good response. 1/3 of the patient might have a refractory disease from the get-go, and majority of patients who were responding will have eventually relapse through the acquired resistance mechanism. Now, the teclistamab was approved based on the Majestic trial, which was an open-label dose escalation phase 1/2 trial, where the patients who were triple class refractory included. And as you can see here, the median prior lines of treatment was around 5. 80% of the patients had a prior transplant, and all patients were triple class refractory. With this heavily pretreated patients, the overall response rate was around 63%. Majority of the responses were deep responses, VGPR or more, but there are 3 groups of patients who stood to be refractory and have an inferior outcome, such as patients with an ISS stage 3, patients with extramedullary disease, and patients with high plasma cells in the bone marrow of more than 50%. Those who responded had a median duration of response of around 18 months, and the median PFS for the whole cohort was 11.3 months, and the median overall survival for this heavily pretreated patients was 18 months. Now, 40% of the patients died during the study, mainly due to progressive disease. Now, what does the teclistamab do in the real-world data? This is an investigator-initiative retrospective analysis of 123 patients from Germany who at least received one prior full dose of teclistamab from 18 German centers. Between July 2022 and October 2023, they included 123 patients. We can see that those patients in the real world, they were a little bit heavily pretreated than those in the study Majestic 1. They had more median prior lines of therapy, more extramedullary disease, and more high risk as per the ISS staging system. With a short follow-up of 5.5 months, we can see that the median overall response rate was around 60%, median PFS of 8.7 months, and the median duration of response and overall survival was not reached. Now, when it comes to the subgroup analysis, the patients who were pre-treated with ide-cel in the past, they have inferior overall response rate of around 33% in comparison to those who were not treated with ide-cel in the past. Notably, the anti-BCMA therapy was only noted to the CAR T-cell therapy, but not to the patients who had belantamab mafodotin, which is an antibody-drug conjugate against BCMA. The PFS was also noted on the subgroup analysis on multivariate and univariate analysis that the patients who had an ISS stage 3 and bone marrow infiltration of more than 50%, again, they have an inferior outcome as per the real-world data. The safety outcome here was comparable to what's been seen in the Majestic 1 trial. We can see a very high rate of infection, high rate of CRS, but mainly grade 1 and 2, lower rates of ICANS of 7%, neutropenia and anemia thrombocytopenia were noted. TPO and GCSF were given to a group of patients on the study. The median hospital stay here was around 10 days. Most of the patients were able to go home. 7 patients required ICU admission either because of CRS, ICANS, or infection or other complications. Now, the French have examined the use of teclistamab on the dialysis patients. They included 13 dialysis patients, and the median prior lines of those patients was 4. They used a similar Ssbmt dosing schedule. However, the teclistamab was given 1 or 2 days after the dialysis. They had similar outcome to non-dialysis patients. Therefore, the teclistamab is feasible in patients who are on dialysis. This is the dosage and administration as per the FDA label. So where are we moving with the teclistamab in the future? In the future, the teclistamab, the Majestic 3 trial, is testing the teclistamab with daratumab in the relapsed refractory setting in comparison to the Dara-PD or Dara-VD. The Majestic 4 trial also testing the teclistamab in newly diagnosed patients in addition to lenalidomide in the maintenance setting after autologous stem cell transplantation. Now, Majestic 4 trial is a study comparing teclistamab in combination with daratumab, lenalidomide, in patients who were newly diagnosed transplant ineligible. As we know that the Dara-Revlimid Dex is an approved protocol for the frontline setting. It's been used now, I think, in every patient who has access to monoclonal antibodies. The Majestic 9 trial is another phase 3 trial comparing the teclistamab with as a single agent in comparison to the patients who failed Dara in the past. So those patients who failed Dara in the past, they were randomized to either teclistamab versus pomalidomide Velcade-Dexa or KD. I'm not sure why they use the doublet combination here, but not the KPD, for example, in this study of Majestic 9 trial. Now moving on to another anti-BCMA, which is the elranatamab, which is based on the magnetism 3 trial. They included 233 patients who failed at least one IMiD, PI, or monoclonal antibody. The Ssbmt dosing schedule was given at day 1, 4, 8, and then weekly thereafter. The primary endpoint here was the overall response rate. The secondary endpoint was the time to response, PFS, OS, and safety. As you can see here, they included 123 patients with a median age of around 68, median prior lines of therapy of 5. 70% of the patients have had transplant in the past, and all the patients were triple class refractory. With the single agent elranatamab, the overall response rate was around 60%, and we can see a deep remissions among the responder up to 60%. The patients who achieve CR or more, they tend to have a longer duration of response and longer progression-free survival. Again, similar poor responders among the BITE, high plasma cells in the bone marrow, high risk ISS staging, pentarefractory, and extramedullary disease. They still behave poorly, and I think this represents an unmet medical need. Now, the PFS data and OS data from the ASH 2023 was reported to be at 17.2 months, the median PFS and median OS of 21 months. Now, what are the safety profile with the elranatamab? The anemia and neutropenia is very common. We can see here 69% of the patient developed infection, and 40% of those were grade 3 and 4 infection. 6.5% were fatal infection. Immunoparesis was noted almost on all patients. Patients who developed a severe hypogammaglobulinemia was 75%. Therefore, I think the supportive care that we'll be touching upon soon on the infection part. The cytokine release syndrome was also noted in the first 3 Ssbmt dosing schedule, but not after the 4th dose, at a rate of 70% in grade 1, 2, and no grade 3 or 4 toxicity. The ICANS reported at a very low rate of 3.4% as well. Here is the dosage and administration of elranatamab, day 1, 4, 8, and then weekly. And once you reach cycle 7, which is week 25, then you can move it every 2 weeks. The monumental study have tested the patients with GPRC5D talquetamab on 232 patients. The median age was 64, median prior lines of therapy of 6, and that 1/3 of the patient had an extramedullary disease in the past. So again, overall response rate very high, 70 to 72% among the sub-Q and IV administration. We can see very high rate of VGPR or more. However, the grade 3 and more infection is noted here again. Hypogammaglobulinemia is noted. Very low rates of ICANS again. The CRS, thankfully, it's mainly grade 1 and 2. And I think we are in a better position where when we did the studies on the myeloma than before, because the bispecific T-cell engager has been approved and used extensively in the field of leukemia as well as lymphoma. Now, what's peculiar about the talquetamab is the on-target toxicity, because the GPRC5D is expressed on the keratinocytes, so it can cause nail dystrophic changes and palmar keratoderma, for which the monumental modified dosing schedule was proposed. This is a prospective cohort of patients who were responding to talquetamab, and then they tried to reduce the dose from the 0.8 milligram per kg every 2 weeks to 0.4 milligram every 2 weeks, or they move the regimen every 4 weeks instead of 2 weeks. So the talquetamab dose reduction typically occurred after achieving a response. The median time to dose reduction was around 3 months in general. Most patients who underwent response dose reduction maintained the response, with a median follow-up of around 27 months, the median duration of response of around 20 months. Again, the median time to dose reduction following a response was 3.1 months. The overall response rate among those patients was 80%. The outcomes in these cohort of patients was observed on the 0.8 milligram per every 2 hours registration, was comparable to what was seen in the registrational cohort. Now, this is the anti-BCMA bispecific in the myeloma, where we have 3 approved medication, and I think we have 4 to come in the pipeline. BCMA density at the time of relapse usually reduced, which makes sometimes the other immunotherapy or T-cell redirected therapy difficult in this group of patients, as this correlative analysis study done from the Majestic-1 trial. Now, monitoring prophylaxis and treatment of infection is very, very important in this cohort of patients, and this is, would refer you to a very nice review article published at the Blood Cancer Journal last year, where you can see that the patients with myeloma have a 7 times higher risk of bacterial infection and 10 times higher risk of viral infection. And the infection usually happens in the first 3 months of diagnosis or in the relapse refractory setting. It depends on multiple factors, the patient-related factor, the disease-related factors, treatment-related factors, and also the infection history. As you can see here from all the studies that we have on the PITE, that we can see that the grade 3 or more, not any grade, it's ranging from 20 to almost 50% of infection. Therefore, this is a pooled analysis from all single agent bispecific antibody used in the multiple myeloma. They included in this meta-analysis 1,100 patients where they had 70% were anti-BCMA and 30% were the other, either GPRC5D or FCRH5. The median prior lines of this meta-analysis was 5, and the median follow-up was 6 months. As you can see here, the infection rate on this cohort, on this meta-analysis was 50%. Grade 3 and 4 pneumonia was 10%. Grade 3 or 4 COVID infection was 11%. Neutropenia was very common, and mainly grade 3 and 4. Another French analysis, they looked at the cumulative incidence of infection following bispecific T-cell engager. What was noted here that the rate of infection was lower among the patients who received GPRC5D antibodies in comparison to the PCMA, 73 versus 51%. Most of the infections were bacterial, 56%, 38% were viral, and 5% were fungal infection. Important measures to take is the IVIG administration, prophylactic antibacterial, antiviral, and vaccination. As you can see here, we knew that the baseline, there will be a drop in the immunoglobulins from the baseline. Therefore, I think we have to anticipate this and be proactive and start the IVIG promptly, because it will significantly reduce the rate of infection by almost 80%. So neutropenia is common, 70%, 65% were grade 3 or 4 neutropenia, and usually it occurs late during the treatment, is around 2 to 3 months. GCSF can be used, but here you have to be careful, because the GCSF should not be used during the step-up dosing schedule. You have to use it after you achieve a response, or at least after the dose number 4. Before starting treatment with bispecific, I think we have to take things in consideration: the functional status of the patients, taking a very comprehensive medical history, vaccination history, and whether the patient had previous infection, latent infection, etc. And whenever you suspect infection, then if fever is there, then an early intervention with the broad-spectrum antibiotics, and then tailor your treatment according to the microbiological confirmation. We have to do all the basic lab imaging modality that's possible, and sometimes we need to do some biopsies. So the take-home message here, I think, from the infection and PITES, the monthly immunoglobulin monitoring is important. keeping the immunoglobulins above 400 milligram per deciliter, prophylax the patients with antiviral, anti-BGB. Bacterial prophylaxis is recommended for patients who were having prolonged neutropenia. Fungal infection in general is not recommended. However, it should be considered for patients who had steroids, who had prolonged neutropenia, or who had a prior history of fungal infection. Now, the mechanism of resistance here, we will look into it into two things. The first, primary refractory patients. They can have it either because of the disease burden that we discussed earlier, high risk ISS stage 3 or more, high plasma cells at the time of the infusion, or the patients who had an extramedullary disease. The other potential cause for primary refractoriness is the soluble BCMA. We know that the BCMA is a cell surface protein. However, it can be cleaved and be present in the serum because of the gamma secretase enzyme, which can cleave the BCMA from the cell surface, and the soluble BCMA will be in the serum. Therefore, when you give the teclistamab or other anti-BCMA, there will be what we call it a sink effect, that the teclistamab will bind to the BCMA in the serum and will not reach to the cell surface protein and causing cytolytic activity on the myeloma cell. Therefore, there is two ongoing studies, the Magnetism-4 and Majestic-2 trial, trying to address this issue by combining the teclistamab and elranatamab with the gamma secretase inhibitor in order to overcome this effect of sink effect. The other mechanism that we can overcome and this has been validated from clinical studies, is to increase the dose of the teclistamab or design the teclistamab to bind only to the full length of the BCMA, but not the soluble BCMA in the serum. Another mechanism of primary refractoriness is the T-cell fitness. So T-cells are exhausted, and from the Majestic-1 correlative analysis, when they looked at the T-cell function, they found that the T-cells that are expressing PD-1 or TIM3, usually they have a lower response rate in comparison to the PD-1 negative, TIM3 negative. The relapse usually happens due to an antigenic escape, and this is mainly due to deletion or mutation at the BCMA in 40% or almost universal in GPRC5D. Therefore, a redirect TT trial is addressing the sequential use of the teclistamab followed by talquetamab with an overall response rate of 96%, and in patients with extramedullary disease, the overall response rate is around 81%. So with that, the take-home messages: the bispecific T-cell engager is effective in triple-class refractory patients. They are less effective in patients with ISS stage 3, extramedullary disease, and high disease burden of diagnosis. Very high rate of infection. All precautions should be taken. CRS is common. However, this is mainly grade 1 and 2. ICANS seems to be manageable with a low grade. We have different bites. I think sequencing is still to be determined, and several ongoing trial testing its combination with the other agents in earlier lines of treatment. With that, I thank you so much for listening and happy to have any questions.
All right, thank you very much, Dr. Ahmed, for the nice presentation. Now I'd like to ask all the presenters to come to the stage for a Q&A session. شوي خليني بس. Okay, if there is any questions for the audience.
Yeah, question for Dr. Mender. Thank you for your nice presentation. I'd like to ask about the post-transplant cyclophosphamide. You mentioned about the efficacy and in some format now it's considered to be a standard of care. Can you elaborate about mentioned toxicity of post-transplant cyclophosphamide, especially cardiac toxicity?
Okay. Three points for cyclophosphamide. First one is cardiac toxicity, hemorrhagic cystitis, and infections. In the study that I presented in New England Journal of Medicine, was just published recently, there was increase in grade 2 infections, but 3 were not increased. And CTN has grading 1, 2, 3, as you know. So it was only increased in 2. Later on, we did some T-cell repertoire analysis and showed that there is a delay in immune recovery when you use post-transplant cyclophosphamide. So the infection risk is real, and we need to be careful with that. Beside the delay in engraftment and other things. Hemorrhagic cystitis, enough mesna, enough hydration, you should not see a lot. In our center, we use mesna, same 1 milligram, 4 milligram of cyclophosphamide, and we do it in split every 3 to 4 hours, and we do hyperhydration versus bladder irrigation, depends on the patient's situation. If patient is old, have some cardiac issues, borderline cardiovascular problems, I would do irrigation in a way that you put Foley in, and then you do like a continuous irrigation. You don't need to do the IV fluid. You don't need to make the patient volume overloaded. Last thing is cardiac risk. There is one study from French group that was published a couple of years ago that shows that there is an increase in around 10% increase in cardiac events. And when you look at the details, really there was very small numbers of arrhythmia and cardiac problems, mostly heart failure. And I wonder if those cardiac heart failure reasons were related to mostly hyperhydration to prevent hemorrhagic cystitis. So there is some increase in cardiac toxicity. They have some multivariable models with specific issues that they've seen that can cause increase, mostly patient who comes in with borderline cardiac issue, history of cardiac vascular, older than age of 70. All those factors are listed in the paper, but really probably is overrated type of side effects. We have 2 studies ongoing now to decrease the dose of cyclophosphamide, one for haplo and one for match donor, and we will see if there is a decrease in the cardiac toxicity. Thank you.
Okay, next speaker, next question.
Congratulations to all speakers, excellent presentations. So I have one question for Dr. Samir and one for Dr. Mohsen. So for Dr. Samir, I mean, the CAR T-cell therapy, I mean, you showed us very nice curves, but there's no plateau in the CAR T-cells for myeloma, suggests that probably nobody's been cured with the CAR T-cells. So the question is, in a significant proportion of these patients, you achieve stringent CR. So in those who are fit, I mean, and eligible for allo, I mean, there are not many of them, but at least, should there be a study looking at bridging with CAR T-cell therapy, as for allo in these patients? And the question for Dr. Mohsen is, we'll soon, or if not yet, we're going to have CAR T-cell therapy for adult ALL patients here. So the question is, what strategy will you follow in your institution, taking into account that, a lot of patients adults who receive CAR T-cell therapy for adult ALL, they relapse after CAR T-cells. And the question is, how can we improve? And the issue is, should we be going for preemptive allo in these patients? If you don't have an algorithm which definitely will be highly predictive of positive outcome with CAR T-cells. Because, if you're going to reach the point of allografting someone who's going to become MRD after CAR T-cell, what's the point? We know that MRD positivity is a factor for poor outcome even after allostem cell transplantation. Thank you.
Thanks for the question. So as you know, like multiple myeloma, it's an incurable disease, unfortunately. So as you mentioned, yes, so using a CAR T-cell like late at the stage, like already the patient has multiple relapses, this will the patient usually will have like refractory disease at that time, the outcome will be not that good. So moving like CAR T cell earlier, if the patient like achieving CR or stringent CR, it will improve the outcome of the CAR T cell. So this is what is addressed like in the study. So in the KARMA, they randomized the patient either to receive the standard therapy compared to the CAR T cell and showed there is significant improvement with the CAR T cell. But still we are waiting for CARTITUDE study like 5 and 6, which is actually comparing the stem cell transplant with the CAR T cell. Because, you know, to leave the CAR T cell at the end, we know with the multiple myeloma, with each relapse, usually disease is more aggressive, difficult to treat. And to leave it, and especially with the patient triple class refractory, so what we're going to give the patient to bridge him until the product is ready. So moving CAR T cell area will be, I think, the future for the CAR T cell and multiple myeloma.
Yeah, thank you for the question. So now the outcome of adult ALL is improving in general compared to the previously, because we are using like pediatric inspired protocols. We have new drugs like BITE, Benitumab, Anituzumab. So the outcome in general is improving, and but still we will have patients who are refractory or multiple relapses, in whom you may either do transplant or CAR T. So in general, now we will go with the recommended guidelines for CAR T for those who are refractory and the 12 months and relapse in the 12th month, or primary refractory, or those who relapse after 2 lines of the treatment. Most likely they are after transplant. We don't have now clear guideline to do CAR T first before transplant. We don't have any randomized trial between them. But in general, we will go with the current recommended guideline after 2 lines of treatment.
Next question.
Thank you all four for a great morning. This was fantastic. Mansour, how important is day 3 and day 4? We had a patient who got day 3 cyclo, and then it was found out on day 5.5 that the day 4 had not been given. Then the argument broke out, do we give it now or do we skip it?
Yeah, those are all questions that are coming now with more people using cyclophosphamide. Very important questions. I think it goes back to the original mouse model that was done in England, where they did this timing of cyclophosphamide, and they thought that this is very important. Later with the Hopkins group, they made sure that everyone has 72 hours of T-cell upregulation or proliferation before cyclophosphamide can go. And then when they did the study with Seattle, first cohort was receiving only day 3. And they show that this GVHD rate was like in the 30–40%. When they add day 4, the rate of GVHD went down to 5 to 10%. That's the original paper in Ssbmt. So timing is very important. We think it is important. Again, it has to do with the clinical trials. Since that moment on, everyone has been giving it on day 3 and 4. With the new data, with the new studies that are coming, we are going to use 25 milligram per meter square, per kilogram on day 3 and 4. So we will know what is the importance of the timing and the importance of the dosing. Another thing is that they would always advise us that days 0 to 3, you should not give any immunosuppressive therapy to allow more alloreactive cells to ramp up, right? There's a group in France who published recent data where they start MMF and cyclosporin on day 0 and then give cyclophosphamide, and their data were fine. I mean, they had nice comparison with people starting on day 3 and 4. Didn't show a difference. The mismatch degree and the population were different a little bit, but again, we don't know a lot of details, but we have been doing it the way that it was done in Hopkins in the beginning, and it's been the same for all of us.
Thank you very much for excellent talks from everybody. So I have 2 questions. One question to Dr. Malki, and the other question is for the CAR T-cell talks, Dr. Mohsen and Dr. Samer. So the first question is regarding the organ-specific CAR T-cell response. So if you look on the multiple myeloma patients, those with extramedullary disease, they had a lower response. So my question to you, would you give radiation therapy for debulking the tumor before proceeding with the CAR? And for the ALL trial, I saw from your slides that the response in the CNS is great, but in the lymph node is not. Could you explain that? And the question for Dr. Al-Maliki, could you comment regarding the increased relapse using the PTCY in haplo, in sibling match, and in particular in sibling match related transplant? Is there a risk of increased risk of relapse using PTCY for GVHD prophylaxis in sibling match related to transplant? Sorry for being long. Bye-bye.
So start first question regarding extramedullary disease. Actually, unfortunately, extramedullary disease is a bad disease. Difficult to control it, even with the available therapy. Even with CAR T-cell, showed in the graph, although it's better compared to the standard of therapy, standard care of therapy, but still the outcome is very bad. So unfortunately, it's the only option left. So usually when you collect the stem cell for processing, so until the product is ready, you need to give the patient something. So if the patient complains symptoms like related to the extramedullary, radiation is one of the options, just to keep the patients like stable until and fit enough to receive the CAR T-cell products.
Regarding the CNS, yes, CNS responses were, especially in those with isolated CNS, they tend to have good responses, and as I show in the slides, the outcome is good. Why there is no response with the other extranodal, but there is responses in the CNS, I don't really know what's the reason, but it could be related to the relapses or resistant in the extranodal or extramedullary, could be from CD19 negative disease. But maybe there are other explanations, yeah.
Thank you for your question. You get asked this question all the time, and it is for sure that reputation that started all the way from the beginning when Hopkins started using the non-myeloablative regimens for myeloid disorders. And we know from data from multiple centers, that non-myeloablative regimen is not good for leukemia, period. So you use whatever GVHD prophylaxis, you will have increase. I mean, one time, I think, was it in Seattle where they compared flu TBI, which is the very non-myeloablative regimen, with their Tacro plus minus Cellcept. They showed that the relapse risk is high, and it was not using post-Cy. Post-transplant cyclophosphamide has some delay in recovery of immune system, and there is expectation that the GVL arrival will be late. Until the GVL arrive, you really need a good conditioning and a good disease coming into transplant. Later on, I think when they did look at non-myeloablative, they looked at MRD status at the time of transplant, and they showed that people who come in with MRD negative, getting post-Cy with non-myeloablative regimen, did well, and relapse risk was in the range of 30%. But those patients who come in with no good control of disease, getting non-myeloablative regimen, getting post-Cy, those are bad combinations, and they get relapse risk in the range of 60–70%. So really, the relapse has to do with multiple different factors. And later, when we use, our favorite conditioning with post-Cy is Flu-Mil, and Milfinane, as we all know, is very strong. Reduced intensity is probably real close to myeloablation. But relapse risk in our hands is in the range of 20%, which is way lower than anything else reported. So I think it has to do with the combination. It's all called platform together. So you have to do your GVHD prophylaxis with the right conditioning, with the right disease set, to get your best outcome. Thank you.
Right, next.
So just a comment regarding Dr. Khalid, the patients with extramedullary disease, whether they need radiotherapy or not. I think the CAR-T or all immunotherapy have shown that they have a very low response rates among all leukemias, myeloma, lymphoma, if you have a high disease burden. So I think reducing the disease burden by all means, whether chemo, other modalities, is very important before giving the CAR-T. So we try to give the CAR-T at a low disease burden and then proceed.
Assalamu alaikum. Mohammed Al-Hunaini from Oman. Thanks to all speakers for the wonderful talks. I have a question for Dr. Al-Malki regarding steroid refractory GVHD, chronic GVHD. I did not see slides on phototherapy unless I missed some of the slides. So my question is regarding the sequence of initiation of Roxo, ibrutinib, ECB. When do you start ECB if you are a believer? And do you combine ECB with either Roxo or ibrutinib? And what's your personal experience about ibrutinib? We are not seeing, based on the data is showing like 79%, I think, overall response rate. We are not seeing that. Is it the timing or there is something faulty about the published data? Thank you.
Thank you for your question. I've shown, I mean, due to the short time, I could not show all the details on the prior old therapies that we are all using. So I thought, you know, those was missing. And those are mostly, you know, phase 1, phase 2, case series type of data. So it's all over the place. The data is not very clean, and you cannot really understand how you can sequence things in chronic graft-versus-host disease. It has to do with the research that you have, and if not, it's the center experience. Some centers, even in the United States, don't have ECP. So then that's out. They don't use it. I've seen people using rituximab, for example, for skin GVHD, and I've seen some responses with that. Again, you know, all those data are sporadic. They don't have really consistent message, and you cannot tell how to sequence things. So you have to use your judgment, your experience, and see how you do every organs. And that's why I said that one size does not fit, because you have to make sure, you know, you use the specific therapy that is good for specific organ. For example, ECP, usually when I get a lung or skin, and those are fibrotic, like really bad GVHDs, I usually start with ruxolitinib, high dose 10 BID with azole, which, as you know, azole will increase even the dose, the level of rux, and then I add ECP all the way from the beginning. I use combination therapy. I think with the activation process that is happening, I need to be ahead of it. I need to do something to go faster than the fibroblast activation. And just serial adding drugs, it seems to me that we are always behind and we cannot catch up. So in a lung or skin, scleroderma type of skin, GVHD, I usually start with both Rux and ECP and steroid. I calm down the inflammation with the steroid, I get them off, I keep them on ECP and JAK inhibitor for long period of time. There's a couple of attempts where I see plateauing with this regimen, especially with the skin. And I've had some sporadic experience where I increased the dose of Rux to 20 BID, and I've seen improvement after a real long plateau. So again, you have to recognize what is the benefit of each drug and where are you interfering, and all those. Always go back to the level where you are interfering and what you are trying to do. Anything else is fixable, but skin and lung are bad and they are difficult to treat.
Dr. Absi.
Thank you all for the excellent talks. I have three actually questions for Dr. Mohsen. Actually, it's more like a comment. I mean, at least in our centers, we've been using inotuzumab as a salvage therapy for first relapse right now, and we're shying away from using chemotherapy for those agents altogether. And to be honest, with our responses has been really good. The CR rate is very high with good MRD negativity. And even if MRD positive, those patients can still be bridged with BLINA before they go to allo. So for that patient population, and given the fact that we're treating almost half of the patients that we treat in the adults are actually pediatrics by definition, because mostly between age 14 and 20. I'm still having very difficulty to see where we're going to be situating the CAR T-cell therapy for that group of patients. I asked this question for an international speaker who visited our center. It comes to my mind, I think that Dr. Scott is still here, he left. So one of the things that came to my mind for patients who are between ages 14 to 20, whom are, again, technically pediatrics, and we've been transplanting all those patients who relapse, even though in the pediatrics literature, some of those low-risk relapses, they could salvage with chemo alone. Do you foresee that for such a patient population, in order to decrease long-term toxicity, and since we still have a backup allo, if they do have a second relapse down the road, using a strategy of novel agent plus CAR T-cell transplant-free approach? I know there's no data, but do you see that this is something that we can do? Because to be honest, for our group of patients, CAR T-cell, it seems, it's only going to be situated post-allo relapse. I don't see it happening anywhere else. But can you comment on that?
Yes, so we don't have studies about the patients who were treated with inotuzumab. We have the study that have shown regarding blinatumab, so no response to blinatumab correlate to the response post-CAR T, so we don't know about this group who were treated with inotuzumab. I assume they may have better response post-CAR T compared to blinatumab group because the target here is different. But I agree with you, maybe in the future we'll have a clear algorithm once we have many patients studies who were treated with inotuzumab and then they received CAR T. One thing in this group of the patient, we know inotuzumab may increase the risk of VOD post-transplant, so by doing CAR T may be more encouraging than doing the transplant in the patient who relapsed post-inotuzumab.
All right. Thank you very
and
much.
then I asked two more questions.
Sure.
For Dr. Hareji, for the rate of infections, it seems that 25% of serious or grade 3, 4 infections is pretty high. Are you aware of any ongoing studies for strategies of utilizing time-limited therapy or response-adapted therapy in order to decrease the rate of infections?
Yeah, I think the elranatamab has been used in a fixed duration approach in order to mitigate the infection rate. And some of the earlier study there where they used the bispecific T-cell engager in newly diagnosed or patients who had relapsed refractory in like period of their therapy, and then they will be stopped later on. Because the fatal infection can go up to 10%, which is significantly high.
And finally, for Dr. Munzer, for centers that they don't have a high load of allogeneic BMT, are you aware of any clinical decision tools that are based on real life data from big registries that can help in taking the decisions in terms of, as you said, how to sequence therapies for chronic GVHD? Is there like a practical clinical decision tool support model to help into taking those decisions, or at the end of the day is going by experience?
Yeah, I don't think we have that, and unfortunately we have a lot of support group that patient can join, but I have not seen a real nice tool. Like you have like this Seattle tool online to calculate the non-relapse mortality, which is very helpful. I use it all the time with consulting patients. You plug the numbers, it tells you exactly what's the mortality and what it is for, and how you could read a little bit about it. But for GVHD, I have not seen that. Regarding the variability in treatment of chronic GVHD, believe me, even in our center, we have 40 transplant doctors. Everyone does different things. So chronic GVHD is very difficult. It's a spectrum of disease. It's multi-organ problems. We have a chronic graft-versus-host disease clinic, and I'm one of the physicians who round on that in that clinic, and we have 5 other doctors. Everyone does differently, and we learn from our dermatologist is that, you do this, the other guy does this, the other guy does that. So unfortunately, we don't have a way to figure it out. And that's probably one of the toughest part of GVHD studies, that we cannot really unify or standardize that approach.
Thank you.
Okay, we are concluding the session. Thank you to the audience. Thank you to the presenters. And we'll see you in probably 20 minutes from now.
We'll start at 11, 5 minutes
At 11
earlier.
sharp. Okay.
Thank
you very much.
On behalf of the Saudi Society of Blood and Marrow Transplant and the Saudi Society of Hematology, I welcome you again to this meeting. And it's time for recognition, and we have, before we start our recognition for the research, there is an announcement about a book that has been compiled recently, which we are launching today and informing you about it, which is the Hematology Publication Book. The Hematology Publication Book under the Saudi Society of Blood and Marrow Transplant and the Saudi Hematology Research Group has been compiled, and we collected all the publications in hematology that have been published in 2021, and we're working on the subsequent years. Can you show it? So this is the Hematology Publication Book that contains all publications in 2021. And this is the barcode which you can scan and download this book. This book is indexed where all publishers, all authors are indexed, and you can view each author, how many publications he had within that year, and you can, this is content, and then it goes in categories. There has been around 400 publications from Saudi Arabia in the hematology field in 2021. And hopefully this will increase in the subsequent years. We're working in the subsequent years, and hopefully we'll have this ready soon. So with that, we'll come to the recognition part. You know, the Saudi Society of Blood and Marrow Transplant has made efforts to improve research within the Kingdom of Saudi Arabia, and annually we have recognized researchers in the field of hematology, and the objectives of this research recognition is to enhance hematology research in the Kingdom of Saudi Arabia, and to emphasize the Saudi Society of Blood and Marrow Transplant commitment to establish medical research culture in Saudi Arabia. Also to improve the representation of Kingdom of Saudi Arabia at international meetings. The research award has been made in different categories in the field of hematology. The categories are clinical hematology, basic research, hematopathology, and stem cell transplant. So for this year, we have 3 winners. And just before announcing the 3 winners, if I may ask the president of the Saudi Society of Blood and Marrow Transplant, Dr. Ahmed Al-Askar, to come to the stage, and the president of the Saudi Society of Hematology, Dr. Ahmed Barifa, and the vice president, Dr. Mohammed Al-Shahrani, to come to the stage to recognize the winners. So in the field of stem cell transplant category, Dr. Mazen Mohammed Abdul Salam is the winner, who is a staff physician in the adult hematology and stem cell transplant divisions at King Abdulaziz Medical City, Riyadh. He's awarded for his work that has been presented in the last ASH meeting, entitled Favorable Fertility Outcome in a Large Cohort of Sickle Cell Disease Patients Underlying Allogeneic Hematopoietic Stem Cell Transplant. Dr. Mazen. The second winner is Dr. Hind Salama, who is a consultant of adult hematology and stem cell transplant at King Abdulaziz Medical City, Riyadh. She's awarded this award for her work in the comparison of a modified pediatric protocol versus a hyper-CVAD in adolescents and young adults with Philadelphia negative acute lymphoblastic leukemia, a multi-center retrospective analysis. The third winner in the category of hematopathology is Afnan Al-Muhanna, who is a stem cell lab technologist from the Department of Pathology and Laboratory Medicine at King Fahd Specialist Hospital, Dammam. And she has won the award for her work in the validation of long arm handling and storage conditions for hematopoietic stem cell products for autologous transplants. Dr. Ahmed Al-Bahrani, the senior author, will be here to get the award and present the work. Dr. Ahmed, تفضل. ها ناخذ صورة سوا. So I'll ask Dr. Ahmed Barifa for a special recognition today.
Thank you, Dr. Ayman and Prof. Ahmed and Dr. Muhammad. Allow me to speak in Arabic. بسم الله الرحمن الرحيم. في رحاب التكريم وأجواء الإجلال نقف اليوم مفعمين بالتقدير والاحترام لنعبر عن بالغ شكرنا وعرفاننا لشخصية وقامة علمية بارزة، معلمنا القدير ذو بصيرة نافذة، الطبيب الخبير والباحث المتميز، إلى القائد الملهم الذي أضاء دروب العلم بحكمته وعطائه، إلى من صاغ بخلقه الرفيع أنموذجاً يحتذى وقدوة يقتدى بها، الأستاذ الدكتور محمد حسن قاري. تتشرف الجمعية السعودية لأمراض الدم بتقديم أسمى آيات الشكر والعرفان لسعادتكم، تقديراً لجهودكم وإخلاصكم اللامحدود في قيادة الجمعية وريادتها نحو آفاق النجاح والتميز على مدى السنين الماضية. لعل أسمى ما يمكن أن يقال هو الدعاء بالخير والبركة لشخصكم الكريم، فبارك الله فيك وفي صفاتك النبيلة وزادك من فضله علماً وكرما. حضوركم في قلوبنا باق محفور في ذاكرة كل زميل وصديق، فأنتم بحق تستحقون هذا التقدير وأكثر.
Now it's time for the winners of the research awards to present their work. Each and every one has 10 minutes. So the first presenter will be Dr. Mazen Abdussalam. Again, his work, his paper is entitled Favorable Fertility Outcome in a Large Cohort of Sickle Cell Disease Patients Undergoing Allogenic Hematopoietic Stem Cell Transplant. Dr. Mazen.
On behalf of myself, Hematology and Stem Cell Transplant Division at National Guard Riyadh. I would like to thank the committee for selecting us as the best winning paper for 2023. And I would like to thank Dr. Mohsen Zahrani, who had an obvious fingerprint on this achievement, without forgetting to thank Prof. Ahmed Al-Askar for giving us the opportunity to be here, and Dr. Ayman Al-Hijazi for his tremendous support. We have been honored to present our oral abstract in ASH a couple of months ago, and now again we are honored to present it here in Jeddah. So without further delay, our abstract title was Favorable Fertility Outcome in Large Cohort of Sickle Cell Disease Patient Undergoing Allogenic Hemobaric Stem Cell Transplantation. So speaking about the burden of disease in Saudi Arabia, as you can see, according to a last update from the Ministry of Health, we have more than 100,000 patients of sickle cell disease. These patients represent 0.2% of the whole population. And as you can see here in the map, most of them are located in the eastern region and in the southern west area. And according to a study published by Professor Sultan and his colleagues, 10,000 patients of these patients in need for transplant, taking in consideration only severe indication, including vaso-occlusive crisis, acute chest syndrome, and stroke. As we all know that hemobaric stem cell transplant is curative therapy for sickle cell disease. However, one of the negative outcome is the premature gonadal failure and infertility. Many transplant-related factors can increase or decrease this risk. Both male and females have a different risk factor that may impact the fertility post-transplant. Therefore, those patients should undergo fertility preservation counseling pre-transplant. And in this study, we've reported the fertility outcome of large cohort patient undergoing an myeloablative conditioning regimen. So having a quick look on our conditioning protocol that we use for them, as I mentioned, it's non-myeloablative conditioning protocol, which is alemtuzumab of 1 milligram per kilogram as a total dose over 5 days, starting from day -7 up to day -3, followed by total body irradiation of 300 centigrade with gonadal shielding for male patient, then a rest day, followed by unmanipulated hemobaric stem cell transplant infusion for them. So preservation fertility, pre-transplant fertility preservation protocol in our center, it's a sperm cryopreservation after holding hydroxyurea for 3 months for male patient, and testicular shielding for them during the TBI session, as I've mentioned. While for our female patient, they got referred to specialized oncology fertility clinic, where they get counsel for either oocyte cryopreservation or treatment with GnRH agonist pre-transplant, and hopefully in the future tissue implantation. After IRB approval, we retrospectively collected the data for all sickle cell patients who underwent allogenic stem cell transplant in our center from 2015 up to 2022. And our inclusion criteria were all sickle adult patient and adolescent who are 14 and above, and a myeloablative conditioning of alemtuzumab, total body radiation with a minimum of 1 year follow-up. And our exclusion criteria were those who got expired or needed second transplant, or those who used a different conditioning regimen than we've mentioned. Our primary objective was to assess the post-transplant fertility by the ability to conceive for the married patient, and the presence of the viable sperms on semen analysis that done 1 or 2 or 3 years post-transplant for male patient, and for female patient regaining of their menstruation. While our secondary objective is to assess pre-transplant fertility and success of different fertility preservation methods, such as sperm cryopreservation, oocyte cryopreservation, GnRH analogs, and to assess for the risk factor of a pre-transplant, the effect of the fertility potentials. Actually, our transplant in our Center for Sickle Cell started it in 2015. A total of 200 sickle cell patients underwent hemobaric stem cell transplant were eligible for this study. We started our fertility preservation program in October 2019, where 50% of female patients and 56 of our male patients got counseled for this preservation methods. Having a quick look at the patient characteristic, as I mentioned, there were a total of 200 patients, 112 male patients, and 88 female patients. 58 of them were married, and 142 were single, with a median age of 26 years. And indication goes mostly to a recurrent vaso-occlusive crisis, followed by stroke, then acute chest syndrome. Hydroxyurea used by all of them, and the median dose was 1,000 milligram, with a median duration of use of 2 to 5 years in general. Having a look at the laboratory results, as you can see that we have shown a significant improvement in the hemoglobin to 135 post-transplant, and significant drop of the hemoglobin S and the ferritin. LH, FSH almost remained the same, while AMH and testosterone drop significantly post-transplant. And just to mention, our median duration of follow-up was 3.5 years. So pre-transplant fertility results for our patient. Among our 58 married patients, 82% of them had children pre-transplant, and among our 112 patients, 36 of them attempt sperm cryopreservation with success rate of 91%. And among our 88 female patients, 1 patient had amenorrhea pre-transplant, 6 attempt oocyte cryopreservation, and all were successful. Just 1 of them developed cerebral venous thrombosis, and 39 of our female patients received a leprolide pre-transplant with no direct complication to mention. The post-transplant fertility result, among our 57 married patients, 26 of them were able to conceive. And just to elaborate more in this 26 pregnancy, so 20 of them ended with successful live birth, 1 ended with abortion, 5 were still pregnant the time that we wrote the abstract, 6 patients were able to conceive twice, and 1 patient had 1 twin babies. Among our 112 patients, 74 of them, they did semen analysis at least of 1 year. 47% had azoospermia, and 53 had viable sperm. The majority of our patients recovered their spermatogenesis at 1 year, which is 24 patients, 9 at 2 years, and 3 at 3 years. And just to mention that 3 of our patients had azoospermia at 1 year, but they were able to conceive successfully without repeating the test. Among our 88 female patients, 80.7% of them were able to regain their menstruation, and only 19.3% developed secondary amenorrhea. Having a look at our hormonal profile, actually this slide showed gonadal hormonal changes pre and post transplant as a secondary objective in our study. For FSH, if we focus on the high value post-transplant indicating a gonadal failure, it was high on 24.5% of them. And for anti-Müllerian hormone, for female patient with a low value indicating gonadal failure, it was low in 16 out of 17 patients. However, we have already mentioned that it was done mainly for patients who had amenorrhea or underwent a workup for gonadal failure. And for testosterone for male patient, post-transplant, it was low in 8% of the patient. Again, one caveat in interpreting this table, that is to note, not all patients had these tests done for them. So in conclusion, in this study, we have shown another favorable advantage of using a non-myeloablative transplant regimen for adult sickle cell patients, where majority of male and female patients maintain their fertility potential post-transplant. 45% of our married patients were able to conceive. 53 of our male patients and 80.7% of our female patients were potentially fertile. And that's led me to my last sentence of my presentation, that all adult patients should be counseled for fertility preservation method before undergoing an allogenic hemobaric stem cell transplant. At my end of presentation, I would like to acknowledge my colleague in the team, stem cell transplant coordinator, nurses, educator, stem cell lab, IVF team, radiation therapy colleagues, and definitely patient and their family for their collaboration and for the support. Thank you very much.
Thank you, Dr. Mazen. We'll have one or two questions if there is any. No questions. Thank you, Dr. Mazen. We'll go ahead for the next abstract or the next paper, which is by Dr. Hind Salama. And the title of the paper is Comparison of a Modified Pediatric Protocol versus a Hyper-CVAD protocol in adolescents and young adults with Philadelphia negative acute lymphoblastic leukemia. Dr. Hind.
Thank you for selecting our abstract, and thank you for Dr. Ahmed Al-Absi, who is the team leader for this project, and he's the one who wrote the proposal, the abstract, sorry, not the protocol. So it's, as a background, we know that the introduction of pediatric-like regimen to manage adults with acute lymphoblastic leukemia has shown promising outcome among several analyses. This is a combined study between King Abdulaziz Medical City Riyadh and Princess Noura Oncology Center Jeddah, where before the two centers used to give patients from 14 years and above with newly diagnosed acute lymphoblastic leukemia hyper-CVAD protocol. But after 2016, we started to use this protocol, which is on a backbone of BFM, German protocol, with 7 steps, modification steps with an aim to improve the efficacy and reduce toxicity in the adult group. And I will go through those steps first before we go to our protocol. And then, after we got an IRB approval, we compare the result of those patients who were treated with the modified protocol versus those who were treated traditionally with hyper-CVAD. So those are the 7 steps that we went through. So the first step is the use of pre-phase steroid and dexamethasone in induction, asparaginase modification, the use of high-dose methotrexate in interim maintenance, whether it's B-cell or T-cell, the incorporation of MRD in decision-making, and use of blinatumomab or nelarabine for MRD-positive patients, elimination of second phase of delayed intensification, incorporation of rituximab for B-cell, and 30 months maintenance duration. I will go briefly through those steps to make it clear. So the use of pre-phase dexamethasone, the aim of that is to give time for the BCR able to turn out, because as you know, we are excluding Philadelphia positive chromosome, and the use of DEXA instead of prednisolone. In the original BFM, they used prednisolone in induction. Here we use dexamethasone. The rationale is that DEXA is has more CNS penetration, and as well, it has less risk of relapse. However, we know that dexamethasone is more toxic than prednisolone. That's why in the induction, antibiotics, antifungals, and GCSF were added. Asparaginase is a very important medication in most of pediatric protocols. However, the adults don't tolerate asparaginase like children. And that's mainly because of, I will go back, because of liver toxicity. Liver toxicity is affected mainly by the body mass index, increased age, fatty liver, and the dose. That's why we capped the maximum dose to 5,000 units. There was an age-adapted scheme, so those who are less than 25 years will receive the full dose, while those who are more than 25 will receive reduced dose. There was further reduction in the dose of asparaginase to a total of 1,500 units per meter square if there is fatty liver. So we obtain an ultrasound. At the beginning, this was moderate or severe fatty liver. There is more modification. The asparaginase we use is a big asparaginase. Erwinia, we use it in case of allergy. Since studies showed no difference between IM and IV route, we choose the IV route to avoid the bleeding during the thrombocytopenia. In the original BFM, they use high-dose methotrexate for T-cell ALL, but for B-cell, they use the Kabizi methotrexate. But the COG ALL 0232 study compared high-dose methotrexate with scabizi methotrexate, and they found that high-dose methotrexate has better overall survival and even free survival in high-risk ALL, regardless whether they are B or T cell. So we incorporated high-dose methotrexate in the protocol to both subtypes of ALL. And we use a smaller dose for those who are more than 25 years, and 5 grams per meter square for those who are more than 25 years. We know that recently MRD became the only or the most important prognostic feature to decide on high-risk features and the need for transplant. So MRD after consolidation is the only indicator for transplant to our patient, regardless of their initial high-risk features. And we choose MRD after consolidation, which is after 3 months of starting treatment as an indicator for transplant. We have the cutoff of 10 to the power minus 4. Both centers, we do it by flow cytometry, 8-color flow cytometry, with the sensitivity of 10 to the power minus 4. And also, for those who are MRD positive, if they are B cell, we'll go for blinatumomab and then off-protocol transplant. Since there is no standard of care in T cell ALL eradication of MRD, we selected to choose either nilarabine single agent or high-dose methotrexate just to try to put them in MRD negative before transplant. Also, the CCG 1961 study found that there is no benefit of delayed intensification phase 2 when it comes to even free survival. So to reduce the toxicity in this adult group, we decided to omit that part from our protocol. And also, studies showed that use of continuous steroid has more risk of osteonecrosis than use of intermittent steroid, so we changed the protocol to intermittent steroid also. Rituximab is used for those who are CD20 positive in the hyper-CVAD group, but here, and because of the theory of CD20 upregulation after exposure to steroid, we decided to give it to every B-cell ALL, whether they are CD20 positive or negative. And the optimal duration of maintenance selected in our protocol was different a bit from the BFM protocol. It's 2.5 years, not 3 years, not 2 years. Now we'll go to our protocol. So our inclusion criteria was newly diagnosed patients with Philadelphia negative ALL or T-cell ALL. They should be from 14 to 40 years. They should have adequate organ function. Patients with Down syndrome or Philadelphia positive or above 40 are excluded. Our primary endpoint is the overall survival and disease-free survival. Our secondary endpoint is toxicity, MRD eradication after consolidation, and the rate of transplant. So this is the general patient flow. So as I said, there are 3 to 5 phases of pre-phase of steroid. We are giving IT, but after the lecture yesterday, maybe we'll postpone the IT in the future, we'll amend the protocol. And then the patient goes through the induction phase. After induction, we do bone marrow to check for remission. And after consolidation, we do another bone marrow to check for MRD. And if patient is MRD positive, off protocol. If MRD negative, we'll go through the phases of the protocol. 58 patients were selected from the 2 centers in the BFM protocol. These are the general features, characteristics between hyper-CVAD and modified BFM. As you see, the total number of patients is 103 from the 2 centers. Hyper-CVAD had 45 patients from the same age group, and modified BFM, 58 patients. The general characteristics are the same between the 2 patients, and the demographic is the same. However, there are more risk of complex cytogenetic, more complex cytogenetic cases in the modified BFM. More patients in the modified BFM received received rituximab than hyper-CVAD, and this is explained because those patients we give to B-cell, whether they are CD20 negative or positive, while there we only give to CD20 positive. 0 patient received hyper-CVAD, and this is of course because received blinatumomab in the hyper-CVAD, and this is because in 2016 when we stopped using hyper-CVAD, the blinatumomab was not yet approved for MRD clearance. It was approved in 2018. The result, the median follow-up for the hyper-CVAD was 39 months. For the BFM, 41 months. There were significant rate of MRD positivity in the hyper-CVAD than the BFM. So in hyper-CVAD, 26%, almost third of the patient had MRD positive after consolidation, while in BFM, only 10% had MRD positive after consolidation. More patients in hyper-CVAD group went to transplant, so 40% of the patients in the hyper-CVAD went to transplant, while only 12% in the BFM had a bone marrow transplant. Our 5 years overall response rate was in favor of BFM, so the BFM protocol showed 83% 5 years overall response rate versus 65% for the hyper-CVAD, with a significant p-value. Also, the disease-free survival rate was 67% for BFM protocol versus 44% for the hyper-CVAD, again with a significant p-value. When it comes to toxicity, the toxicity regarding the neutropenia and the ICU admission were the same between the two groups. However, liver toxicity was more in the grade 3 and 4 liver toxicity was more in the BFM protocol. And of course, this is most likely related to the asparaginase. And also there were 5% risk of pancreatitis and 0% in the hyper-CVAD. Osteonecrosis, there were 20% cases of osteonecrosis in the BFM protocol and only 2% osteonecrosis in the hyper-CVAD. But this is not really fair because in the BFM protocol, this is part of the protocol to do bone density assessment, and we are looking for osteonecrosis before we start maintenance, while in the hyper-CVAD, we did it only for one patient who was symptomatic. But maybe if we are doing it the same like in, we will detect more cases. For the causes of this because of sepsis were the same was the same in between the two groups, but this due to disease progression was higher in hyper-CVAD, 24% versus 3% in the BFM. In conclusion, our analysis demonstrated that the use of pediatric modified protocol has superior outcome when compared to hyper-CVAD. The modified BFM protocol was associated with increased risk of certain toxicities, including high-grade liver toxicity. This might need more modification in the asparaginase dose, maybe. Larger multicenter prospective randomized trials are required to accurately compare adult and pediatric inspired protocol. And with the current data favoring moving novel agents to frontline protocol, the protocol is suspected to further modification, and maybe we'll add novel agents. And we have published our data in Leukemia Research a few months back. And I would like to thank my colleague. Without them, the work would not be possible, from Princess Noura Oncology Center, Jeddah, and National Guard, Riyadh. Thank you so much.
Thank you very much, Dr. Hind. Any burning question? Yes, please.
There is no big component compared with the BFM protocol. So using big asparaginase based probably would decrease the risk of relapse, especially the CNS. Is there any CNS relapses in both the groups? Thank you.
Unfortunately, we did not look at that, but this is maybe we'll have a look at that in the future for the future publication. But this was not included in our analysis.
How about your impression?
How about my
impression?
Yeah, I'm very happy with the pediatric inspired protocol. Of course, CNS, whether it is more with BFM or hyper-CVAD. It's difficult to answer this question really, but we need to go back. But during using BFM, the cases were really from the two centers, 58. In our center, it's much less. I only saw one patient who had CNS relapse, but I'm not sure about the actual number.
All right, thank you very much, Dr. Hind. So the last winner will be presented, the last research will be presented by Dr. Ahmed Al-Bahrani, who's the senior author. He's from Department of Pathology and Laboratory Medicine, King Fahd Specialist Hospital, Dammam. And the paper is titled validation of long-term handling and storage conditions for hematopoietic stem cell products for autologous transplant. Dr. Ahmed.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Dr. Ayman. First of all, I would like to thank the organizing of this conference, and also I would like to thank the selection committee for the award, the Ssbmt and the SSH led by Dr. Ahmed Al-Askar, and also all the board members of the society. This study is about the validation of long-term handling and storage conditions for hematopoietic stem cell product for autologous transplant. There is background, methods, results, and conclusions. As you know, the stem cell have two characteristics, the self-renewal and also the differentiation into various other cell type. The proliferation and the differentiation, the hematopoietic stem cell is the same as the other type of the stem cell, have also the capability of self-renewal and also the differentiation into different blood cell type. As you know, the hematopoietic stem cell product storage types, there are almost two types that are clinically practiced now. We have the fresh product, which is stored at 2 to 6 degrees centigrade for a maximum of 72 hours. And this is primarily used for allogeneic stem cell transplant and bone marrow transplant, and also it is used for the myeloma cases post high dose melphalan. The rest of the conditions, we cryopreserve the product in liquid nitrogen after, of course, adding the DMSO at a temperature of minus 140 to minus 195 for 10 years. The rationale of this study, because there are previous research on the extended shelf life for fresh hematopoietic stem cell type is very limited, the available research. Also, most of the study evaluate the fresh hematopoietic stem cell product for a short-term storage condition less than 72 hours. The study protocol, we collected between July 11, 2021 and February 12, 2022, the BMT unit at King Fahd Specialist Hospital in Dammam. We collected 12 autologous hematopoietic stem cell by using apheresis technology. And all the participants provided written consent to participate in the study. We get IRB approval from our hospital and from Imam Abdurrahman bin Faisal University, because they are involved with us. And our technologist, this was her thesis to get the master degree. All patients were mobilized using combination chemotherapy, cyclophosphamide and GCSF. Leukapheresis was performed after assessing the pre-CD34 count, and when the pre-CD34 count exceeded 20 cells per microliter, we started to collect the stem cell. We processed 3 to 3.5 total blood volume of the patient, and the collected volume was minimum 250 and maximum 550 ml. The duration of the procedure ranged between 3 and 5 hours. The inlet blood flow rate ranged between 40 and 60 ml per minute. So what we did, we took 5 to 15 ml from the hematopoietic stem cell product from the bag, and were transferred to sterile bag and stored at 2 to 6 degrees centigrade. We did 3 assessments on the product on day 1, day 3, and day 5. We did total cell viability on day 1, CD34 enumeration, CBC, and sterility study. On day 3, we did total cell viability, CD34 enumeration, and CBC. And again, we repeated the same test on day 5. This is the characteristic of the patient. There were 8 male and 4 female, 5 cases with myeloma and 6 with lymphoma. The product mean volume was 400 ml. The mean processed total blood volume almost 12.5 liter. The hematocrit of the product was excellent. The mean was only 1.8%. And the WBC count, the mean WBC count on the product, 98,000 per micro. And the collected CD34 dose per kilogram of the patient body weight, the mean was 6.7 million per kilogram of the recipient body weight. This is the result, as you can see. On day 3 storage in the refrigerator 2 to 6 degrees centigrade, the mean was 89, and on day 5 it was 76, which is acceptable if the collected dose is higher and enough. The CD34 recovery percentage on day 3, 92, the mean was 92, and on day 5, 83. The total cell viability percentage on day 3, 91, and on day 5, it was 86, as you can see. So there is no much drop in the viability, in the enumeration, and also in the TNC count between day 3 and day 5. This is the summary, and we did also bacterial culture by using aerobic and anaerobic, and all shows no growth of bacteria, either on day 3 or day 5. So our conclusion that 5 days hypothermal storage of peripheral blood hematopoietic stem cell product maintain optimal CD34 cell count and TNC count, and all, actually we had before experience of 4 patients, 2 of them had fever, and we lay the infusion up to the day 4. And also another 2 patients, they were collected over 4 days. So we have to infuse the day 1 on day 5. So all those 4 patients, they were engrafted very well, and all engrafted on day 28 post-infusion. So, in conclusion, this is especially true for some conditioning protocol that require additional days until transplant, and also it is applied in case of expected delay of stem cell infusion or poor stem cell collection that need more than 3 collections. Also, it gives higher cellular recovery and viability than the cryopreserved cells. Also, the advantage of the fresh stem cell product are less expensive than cryopreserved, less processing time, less DMSO, less reaction, less toxicity, and also no need of thawing. Our direction for future, of course, we need more study in the future to assess the viability and the enumeration on the bone marrow and also on the cord blood. We need higher samples, population size of the samples, and also to compare the outcome between the cryopreserved stem cell product, the short-term cryopreserved stem cell product, and the extended non-cryopreserved stem cell product. Thank you very much.
Thank you, Dr. Ahmed. Excellent work. I guess 72 is not a magic number. Guess you have a question somewhere. Any question? Yes.
Yes, Ken, thank you so much. This is so helpful because there are so many times when you wish you could wait till day 5 or day 7. Have you considered a little stretch?
Hopefully in the future we can see the effect of day 7. Now let us see day 5.
At least the data they have is up to day 5. Well, thank you very much, Dr. Ahmed.
Two important things. The collected dose have to be more than 3 million.
Yes.
So in case of any
drop
in the recovery, we have enough dose for engraftment. Okay, thank you.
Thank you very much. We come to the conclusion of this session, and the next session is a satellite symposium from BMS, moderated by Professor Muhammad Gari. Professor Muhammad Gari.
Good morning, ladies and gentlemen. It's my pleasure to present this very small session on the management of lower risk myelodysplasia. Our eminent speaker is Dr. Badr Al-Ahmari. I will introduce him later after they took a couple of slides just to tease your interest. My disclaimer, and obviously myelodysplasia is a disease that's becoming very popular with the introduction of newer therapies. There is more interest, and of course we know that it's a multifactorial disease. It could be due to cytogenetic mutation, could be due to molecular mutation or epigenetic changes, or obviously microenvironment alteration. Altogether, this multifactorial causes can cause a change in the differentiation of the common myeloid progenitor cell, leading to impaired differentiation and a clonal expansion and accumulation of the abnormal cells. And of course, this is at the expense of the normal maturation, altogether leading to the non-cytopenia that we commonly see in myelodysplasia. And this can be on the side of the committed myeloerythroid progenitor cell or on the side of the granulocyte monocyte progenitor cells, or both, causing pancytopenia of all the committed stem cells. In the incidence side, in the United States in 2019, there was 59,000 cases of myelodysplasia, and the median age of diagnosis was 77 years in the United States and 73 years in Europe. Very much close together, and as you can see in the graph here, it starts to appear at the age of 40, and then there is an exponential rise as the age grows, and maximally between the 70s and 80s, you will see the majority of cases. As overall adjusted incidence is 4 per 100,000 cases in the United States and 4.3 or 3.2 for females in the German numbers or the European numbers. There is a scarcity of data when it comes to the incidence and prevalence of myelodysplasia. You can only see that there are limited number of studies showing the incidence and the prevalence in Europe and the United States. But in Saudi Arabia, I've looked at more than 100 publications published in Saudi Arabia, and none of them was addressing the prevalence or incidence. And even through the Middle East and the Arab world, there is no solid data on the prevalence and incidence. When it comes to the overall survival, you can see that MDS falls behind most of the solid tumors in the hematological malignancy. When you are looking at the 5-year survival, there is 37% 5 years achieved with the treatment, and 31% for acute myeloid leukemia, and the maximum 5-year survival in hematological malignancy, as we all know, is in both chronic myeloid leukemia and in non-Hodgkin lymphoma. The other solid tumor, the least, is pancreas with 12 years, 5-year survival, and prostate achieving marvelous figure of 97%. With this brief introduction, I would invite our prominent speaker, Dr. Badr Al-Ahmed. He is a consultant, adult stem cell transplant and adult hematology, as well as cellular therapy. He is in the Department of Oncology, Ministry of National Guard. Dr. Badr.
All right, thank you, Prof. Qari, for the introduction and the presentation. As Prof mentioned, he highlighted an important issue with myelodysplastic syndrome and how it is really a heterogenic disorder and difficult to treat disorder, and also associated with a poor survival outcome for some of the high-risk patients that almost matching those difficult to treat solid malignancy. So today I will highlight the important aspect in terms of classification, risk stratification, and we'll talk about how to manage low-risk MDS, especially the anemia part of it. There has been a recent update in terms of classification according to either WHO or the ICC. They have a lot of similarity, but there are some discrepancy between both classification system. One of the most important thing is nomenclatures. So in the WHO they call it myelodysplastic neoplasm, while in the ICC they still call it the myelodysplastic syndrome. The lineages, the multi-lineages or single lineage or multi-lineage was removed from the WHO, and morphologically defined subclass still using the excess blast in the ICC, but also they include MDS AML criterion for those who has more than 10% blast. While in the WHO, they name it according to the blast percentage with different like low blast or increased blast 1 or 2, and they add fibrosis to those with MDS and myelofibrosis. In terms of genetically defined MDS, both of them, they incorporated the SF3B1 and the TB53 with the different criterion for each one of them when you go to the details. And both of them, they kept the same 5Q MDS syndrome. Over the past decades, there has been multiple scoring system that help to classify, to risk stratify the myelodysplastic syndrome. 10 years ago, we had the IPSS or revised IPSS that we have been used so far. However, 10 years later, we had the new IPSS-M, which is adding the molecular data into the equation. And by using that, the IPSS-M, it's basically an IPSS-R with the addition of molecular data for certain set of genes that we'll talk about it. And by incorporating that, you will be able actually to upgrade some of the intermediate and low-risk MDS into a higher-risk MDS. So basically better definition or defining certain subset of MDS patient that they are really a high-risk patient and should be treated in a totally different way. This is an example where you're able to calculate the IPSS-M. It's a very difficult way of calculating this. You will need really a calculator because you're looking into Cox regression, sophisticated Cox regression model that by entering some certain variables and some list of genes that will help you to define exactly where your patient will be located in terms of risk stratifications. Those are most of the genes that are incorporated. There are around 16 or 17 gene mutation that is incorporated, and also there's another subset of residual genes that also can be incorporated into this. Each gene has specific strength that can incorporate it into the model. One important thing here is the number of driver mutation the patient has. So the higher the number of driver mutation, you can see the survival curve will drop significantly based on how many driver mutation the patient has, indicating that this is really a syndrome that is really driven by genetic mutation, and it has a huge impact on the outcome for those patients. Looking into the survival outcome based on the risk stratification, the new IPSS-M system has been validated by multiple cohorts involving thousands of patients, indicating how strength it is to use this model. And comparing it to the IPSS-R, you can see that the median survival for those with low-risk MDS has been prolonged a little bit, indicating that removing some of the previously, we thought that they are low risk or intermediate risk into a higher risk patients. So in general, in terms of treatment for MDS, really there hasn't been any huge progress in terms of intervention since the azacitidine or a hypomethylating agent. So none of the recent interventions can actually improve the overall survival, but there are some disease-modifying agents that we will talk about them, especially for the low-risk MDS. So what are the low-risk MDS? According to, depend on what kind of scoring system that you will use, but usually involve very low, and moderately low MDS if you look into the IPSS-M. And the goal of treatment depends on the risk. So for high-risk patient, of course, our goal of treatment will be cure and preventing disease progression into acute myeloid leukemia, because we know that they have a higher risk of progression. So the aim is to cure those patients, and usually by delivering curative therapies such as intensive therapy and followed by allogeneic stem cell transplant for those patients. However, for low-risk patients, because their median survival is more than probably 10 years or so, so the care or the goal of care in this situation is completely different. Is usually focusing on the improving quality of life, reducing the transfusion burden. That will be the ultimate goal for those patients. Anemia is the most common presentation for those patients, especially with low-risk MDS. And actually, it is associated with increased mortality based on multiple cohorts. And it is really associated with a huge decrease in the survival, especially for those who are transfusion dependent. So you can see clearly patients who are heavily transfusion dependent, they have a drop in their overall survival. And this is actually regardless whether they progress into acute myeloid leukemia or not. So the death in those patients usually are related to their risk of progression into acute myeloid leukemia. The use of chelating agent is important for those patients, but really there is no really strong data to suggest or support the use of these agents. However, this is a recent randomized trial for enrolling patients who are transfusion dependent with the use of XJ versus placebo. And the primary endpoint was the event-free survival, defined by time from the date of enrollment into the first documented non-fatal event, and that's including cardiac dysfunction, liver dysfunction, and acute leukemia transformation, in addition to death. And this study showed clearly the use of XJ was able to reduce the ferritin level over the years, and after a good median follow-up, there was actually an improvement in EFS for those patients. However, they could not demonstrate an overall survival, especially because of the inability to continue the study because of the poor accrual into this study. The first line of treatment for anemia in patients with myelodysplastic syndrome is the use of erythropoietin-stimulating agent. There has been multiple studies showing a wide range of efficacy ranging between 30 to, I would say, to 50% of response rate. But this kind of summarize the response rate for those patients. So basically, 1/3 of patients, they will respond initially, and those responses usually durable to 1 year or so. However, there are a good fraction of patients, they are primary refractory to use of erythropoietin agent. More recently, the use of darbepoetin has been evaluated in randomized study, showing a good response up to, I would say, 50% or so. There was no risk of secondary malignancies or transformation into AML, where most people they are afraid of when they are thinking about using those agents. So it's still an effective way to treat patients with low-risk MDS. According to the data from a Sweden registry, showing that those with low transfusion burden is the most important, most people that will respond into the use of erythropoietin stimulating agent, and even some of those, some of these data showing that there are improvements, although it's retrospective data, but there are improvements in overall survival for those who were treated with erythropoietin agents, especially when it's combined with the GCSF. So we'll talk about a novel agent, the luspatercept, which is used for the ineffective erythropoiesis. And this is a kind of first-in-class erythroid maturation agent, especially it's like a recombinant fusion protein that consists of the extracellular domain of the activin receptor type 3B and attached to the human immunoglobulin FC domain. And you can see here that the fusion protein will attach to the TGF beta ligands, and this will lead to the inhibition of the SMAD signaling. And by inhibiting the SMAD2/3 signaling, this will lead to enhancement of the erythroid maturation. And this enhancement of erythroid maturation usually happen in the later stage because erythropoietin is important in the initial stage of erythroid progenitor. However, the luspatercept work mainly in the later stages of erythroid maturation. Based on the early phase studies, use of luspatercept, specifically in a subset of patients with SF3B1 mutation, and with the use of SF3B1 mutation and those with ring sideroblast myelodysplastic syndrome, randomized double-blind placebo-controlled study conducted in the low-risk patient. And those include patients with SF3B1 mutation or ring sideroblast MDS with, of course, less than 5% blast, no 5q deletion, with who are refractory to erythroid stimulating agent, or they are erythroid stimulating agent naive, but they have higher level of EPO more than 200, and they are transfusion dependent. So this is randomizing patient between luspatercept to placebo, and the primary endpoint was free of transfusion for 8 weeks. This is a patient demographic. You can see that's almost equivalent between both arms. Around more than 40% of patients, they are really heavily transfusion dependent, requiring more than 6 units per 8 weeks. And almost more than 95% of patients, they are refractory to erythroid stimulating agent. So this is the primary endpoint where it's met. Around 38% of patients, they met the primary endpoint, which is red cell transfusion independence in more than 8 weeks, versus 13% only in those on placebo arm. And these responses were somehow durable. And in this slide indicating the other secondary endpoint where erythroid responses that last more than up to 24 weeks reach up to 53% in luspatercept versus 12% in the placebo arm. At first event, there was no significant signal in terms of adverse event between luspatercept and placebo arm. Looking into any grade symptoms, fatigue was actually more prominent in the patient receiving luspatercept. Diarrhea as well was also prominent in those patients, but none in the grade 3. So based on this, another trial was designed, building on that, looking into using this into the first line. So the command trial was designed to answer the question whether using luspatercept in erythroid stimulating agent naive patient as a first line, comparing this with the standard of care, which is ibotene alpha. So this is a ruling, basically any patient with myelodysplastic syndrome, doesn't have to be ring sideroblast or SF3B1 mutated MDS, and also including a patient with low risk or intermediate risk, and they should have an erythropoietin level less than 500, so you can compare with erythropoietin stimulating agent, and also a patient should be transfusion dependent. So they compare luspatercept versus erythropoietin alpha. Primary endpoint was transfusion independence for more than 12 weeks. Patient population were equivalent between both arms. You can see here more than around 60% of patients, they have lower actually transfusion burden, less than 4 units per 8 weeks. For some reason, majority of patients actually they were ring sideroblast, around 70%, which is not the usual typical distribution of low-risk MDS patient. And the primary endpoint was met actually, where 60% of patients receiving luspatercept, they were able to achieve transfusion independence for more than 12 weeks, versus 38%, 34% in ibotene alpha, which is the typical number that we see in those patients. These responses were actually also equivalent in the different subgroups. As you can see here, looking into ring sideroblast patient, the responses was actually higher in the ring sideroblast versus no ring sideroblast, but also it was equivalent to the patient who are erythropoietin alpha, receive erythropoietin alpha. Looking into different secondary endpoints, the luspatercept was actually higher when you compare it with erythropoietin, and looking into the duration of responses, median duration of response was actually 126 weeks for patient receiving luspatercept versus 89 weeks for patient receiving ibotene alpha. So based on these trials, luspatercept was approved as a second line by the FDA, EMA, and Saudi FDA, and approved as a first line based on the US FDA. Another important intervention that is really interesting, the use of lenalidomide. So lenalidomide was evaluated, and it's the standard of care for patients with 5Q myelodysplastic syndrome, based on multiple studies, that even some of those studies showed that there are some improvement in overall survival, especially for those achieve cytogenetic responses. But this trial was actually answering the question, what if we use lenalidomide as a preventive measure, so we can prevent patient from getting into the transfusion dependency. So this is a multi-center randomized double-blind placebo-controlled trial, enrolling patient with low-risk MDS with a hemoglobin of less than 12, but they are not transfusion dependent, and those should be 5Q patients, randomized between lenalidomide, smaller dose than what we used to do, which is only 5 milligram per day, and versus placebo. The endpoint was the transfusion time to transfusion dependency. So this was the result. Around 25% of patients in lenalidomide they went into transfusion dependency versus 65% of patients with placebo, And what's important here, that time to transfusion dependency was not reached after 5 years of follow-up, while a patient on placebo, the time to transfusion dependency was reached within, at the median time of 11 months. Of course, in this study, they actually look into the cytogenetic responses, and more than 90% of patients actually achieve cytogenetic remission. We don't have data about the overall survival yet, but we know that from previous data, achieving cytogenetic responses might improve overall survival for patients with 5q. So this is something might change the practice. What about the use of hypomethylating agent? The use of low-dose hypomethylating agent has been evaluated for patients with low-risk MDS, especially those who failed erythropoietin therapy or with low platelet count. So multiple study done in different way, different combination, different duration. For example, the first study using the low-dose decitabine in a different schedules, showing some CRs and transfusion independent up to 60%. Also the use of decitabine versus azacitidine for 3 days, showing also the ability to achieve CRs and the ability to have some transfusion independence, especially with the decitabine. And more recently, the use of oral azacitidine that is approved already for maintenance therapy for AML. In this randomized study, around 30% of patients, they were able to be transfusion free versus 11% in the placebo group. More recently, data comes from the use of emelistat, which is a telomerase inhibitor that is clinically developed for the use to be used in myelofibrosis. This has been tested in the almost the same patient population who were enrolled into the Medalist trial, but without mandating the ring sideroblast or the SF3B1 mutation. So this is a kind of low-risk MDS who fail hypomethylating, who fail erythropoietin. And the patient randomized between emelistat, 1 IV injection every 4 weeks versus placebo. Of course, you will continue other supportive measure with it, with the primary endpoint is transfusion independent within 8 weeks, for more than 8 weeks. So the primary endpoint was met, where 40% of patients receiving emelistat, they were able to be transfusion free for more than 8 weeks. And it looks like those transfusion independence are durable. And one of the side effect of emelistat is the cytopenia. So you have to deal with the cytopenia initially with the patient at the initial stage, then hemoglobin will improve with time. So we shouldn't forget, of course, to talk about how to treat thrombocytopenia in those patients. TPO agonist has been tested in multiple studies, initially with the use of romiplastim, showing good outcomes up to 50% response rate. In more recent randomized study between using L-Thrombobag versus placebo, the responses were more than 50%. And also there was good clinically meaningful responses in terms of reduction of bleeding for those patients. There was no increased risk of leukemia transformation in those studies, but still it's considered a major concern with the fibrosis as well. Of course, patients with hypoplastic MDS, the best standard is to push them into allogenic transplant if they are young. However, if they are a little bit older, so you can try ATG with the cyclosporine, like immunosuppressive therapy, and if they fail, consideration of allogenic transplant should be there. There are a lot of novel agents under evaluation and testing in low-risk MDS. One of the interesting things that the use of IDH1 or IDH2 inhibitor during the ASH, there has been some data presented in this field. We know that IDH1 and IDH2 can be found in up to 5 to 10% of myelodysplastic syndrome. And the use of those inhibitors in this specific patient population, they were able to achieve transfusion independence. With that, I conclude and looking forward for the questions. Thank you.
Thank you very much, Dr. Badr, for this nice and comprehensive presentation, and I'm waiting for your questions. If not any, I would like to ask Dr. Badr, is any of the study addressing the progression or the impact of luspatercept on progression of lower risk MDS to higher risk or intermediate risk? That means obviously the number of the blast. Is there any impact on the number of the blasts?
Yeah, there was no specific data about that, but there was no signal for that this will lead to increased disease progression in those patients, low risk MDS.
Please. Mike, please.
Thank you. Excellent presentation. So luspatercept indication, this is for RS SF3 mutated, but what about RS negative? Patient with SF3B mutation, would you still recommend?
They rule actually SF3B1 mutation if they have variable frequency more than 5%. So they were enrolled.
And the response?
Regardless if they are RS positive or negative.
And the response would be the same, like for the...
Well, I mean, I don't have data about the medalist, but for the command trial where they used an upfront, 70% were RS positive. Probably this is like selection bias by the investigator, because they know that luspatercept work better in the RS positive. This is where they enroll more patients for that. But if you look to the subset analysis for RS negative, there was no difference, and we showed that like there was almost comparable outcome in RS negative patient in the upfront setting, comparing it with the ABO.
Prof. Ahmed?
Badr, I have a question. I have a patient with MDS, SF3B1 positive and ring sideroblast. However, she doesn't have hypoplastic anemia, but she has anemia due to severe hemolysis. Do you think she would respond to luspatercept?
Well, that's a question. I mean, autoimmune is autoimmune because autoimmunity has been linked to myelodysplastic syndrome before, but I'm not sure really if this will work or not. But this agent, it's been currently tested in myelofibrosis and different myeloid disorders.
And it's been tested in thalassemia. I mean,
and thalassemia, it's already it's already approved. Yeah, correct. Yeah. It's already approved in thalassemia. So it's erythroid maturating agent. So you would expect that. It will help.
Probably what she has is ineffective erythropoiesis, so I'm tempted to try it and see what happens.
Okay, that's an off-label use, so I don't have to say something about it.
Okay, if there are no more questions, we can stop here and we'll reconvene at 1:15. A group photo is invited. Prof. Ahmed is inviting you for a group photo. Please join us on the stage.
Good afternoon, everyone. It's my pleasure to introduce the next speaker, Dr. Aziz Nazha. He's the Executive Director of Early Clinical Development at Insight. He's an internationally known expert in application of artificial intelligence and novel digital technologies in healthcare and pharma. Dr. Aziz, the floor is yours.
Thank you. Thank you very much, Dr. Absi, for the invitation, for the organizing committee, and for the opportunity to be with you today. Such a great pleasure to be in Saudi Arabia. This is my first time, so it's been amazing, and everybody has been wonderful. So thanks for the invitation. Here are my disclosures. I have nothing really, these disclosures has nothing to do with what I'm going to say. So what I would like to cover in the next 30 minutes or so, I'll start by talking about what do we mean by machine learning, deep learning, AI, and why today. And then I'm going to talk a little bit about the application of AI in hematology. But then I'll move to talk about the future, and the future is generative AI, or what we call it Gen AI. So I'll explain what that means. And then we'll talk about ChatGPT and its application in healthcare, and finally talk about a new initiative with AI for healthcare. So what do we mean by artificial intelligence? So artificial intelligence is making machines things and do things like a human without explicitly programming the machine. So if a human can drive a car, can I make the machine drive the car without me telling all the instruction to the machine? Now, under this big umbrella of artificial intelligence, there is machine learning. And machine learning is training algorithms with data. There are two types of machine learning. There are supervised learning where we know the answer. So let's say I'm trying to build a model to predict a dog or a cat image. I know the answer, this is a dog, this is a cat. I build the algorithm and then hide the answer from the algorithm and say, is this a dog, is this a cat? That's supervised learning. Unsupervised learning when we don't know the answer. So we ask the algorithm to find patterns in the data, come up with the answer to us. An example of that in healthcare is RNA sequencing when you do clustering, for example. And then a subset of machine learning is deep learning, and that's what we call a deep neural network. And these are mathematical modeling of the neurons in the brain. So in our brain, we have the neurons connected, they fire up, and if we try to mathematically model that, that's deep learning. But really, the simplest way to think about machine learning is that you have an input. That input could be what we have today, and it went to this cold period of AI until 90s, in 1997, when Deep Blue beat Kasparov in chess, and everybody was like, now machine's going to take over, and humans are gone. But then that's also didn't really happen until 2016, when DeepMind AlphaGo beat the Go champion. Now, why this was important? Because in chess, you have about 36 moves per move, or 36 possibilities. In Go, you have 200 possibilities, which means you cannot program anything like that. So in each of those, you see this spike on hype, and the new hype now is ChatGPT. Now, behind ChatGPT is what we call generative AI, which I'll talk about. So why today? There are several forces that drive what we see today. The first one is big data. So for the first time, we start having a lot of data, especially in healthcare. So if you think about genomic data, electronic healthcare record data, radiology data, this is a huge amount of data. The second force is actually computational power. So if you think about computers, they used to be the size of this room. Today, you have a computer in the size of your hand, which is the iPhone. Now, if that trend continue in 2025 to 30, you can go to Best Buy in US and buy a laptop that has computational power of a human brain with $1,000. In 2050, you can buy the same laptop that has computational power of a human race. Now you can talk about your kids' homework getting very easy at that time. But this trend, what we see between big data and computational power, and we start having actually some successes. So in terms of the FDA, we start actually now having 500 cleared algorithms. Those algorithms cannot operate on its own. You have to have a human operate with the machine, and then you have some AI-designed drugs that start actually going to the clinic. So how can we use AI in hematology? I'm going to give an example of some of the research that we have done in the past for myelodysplastic syndromes, but the concept can be applied to anything. It doesn't have to be applied to MDS. So if you think about MDS, the way we diagnose the disease, you take a bone marrow biopsy, you evaluate for dysplasia, and then the next stage, you stage the disease, and this is blood cancer, so we do blood counts and cytogenetic analysis, and then we calculate IPSS or IPSSR, and then we try to make a treatment decision based on the risk of the patients. Higher risk patients receive transplant or azacitidine, and lower risk patients get supportive care. So the purpose of technology to solve the problems, now what you can say, do we have problems in this paradigm? We have a lot of them. So diagnosis of MDS is very subjective, meaning even in our hand, when I was in the Cleveland Clinic, about 20 to 30% of patients referred to us diagnosed with MDS. They don't have MDS and vice versa, because diagnosing dysplasia is very difficult on the slide. Now, staging is interesting because what we discovered through a lot of research that what we predict in terms of outcome and what the actual outcome of the patient is completely different. So there is a lot of heterogeneity in the patient and their outcome. And then today, even this is not an MDS, in cancer in general, we give chemo and we have no idea which patient can respond. So we have uncertainty in predicting response or resistance. So can we solve some of these problems using AI? So this is again a study to show that if you take a bone marrow biopsy, you showed those myeloid cells to multiple pathologists, there's a lot of discrepancy between whether the pathologists say this is plastic or not, and you see that discrepancy in the color between blue and orange. So this paper came out in 2017. What they did actually, they took melanoma images and they trained these deep learning model called Inception version 3, and then the question was, are these images malignant or benign? And they built a system that achieved accuracy comparable with dermatologists. Now, this is why we live in the best time in human history to do biomedical research, because we don't have to reinvent the wheel. You can tweak the first layer and change the melanoma images with bone marrow biopsy images from patients with MDS or AML or any type of cancer, and tweak the last layer of this deep neural network and say, is this MDS, normal, or AML? And you see a lot of examples of the use of computer vision. Now, what we ask, actually I should go back, do we really need a biopsy? Can we diagnose the disease based on the blood counts? So we did this international collaboration where we took patients' clinical data, so this is CBC with differential, and next generation targeted deep sequencing for patients with MDS compared to other myeloid malignancies. We trained a machine learning model, and then we extracted features. Feature extraction, meaning we asked the algorithm, what are the important variables that impacted the algorithm decision? We plot those variables to make sure that these variables are clinically relevant, and then we build the final model. So this is the patient population that we got, and the training cohort was from Cleveland Clinic and University of Pavia in Italy, and we externally validated the result from data from Munich Leukemia Laboratory, and you can see we can actually predict MDS from other myeloid malignancies with very high accuracy of 95%. But more importantly, the system was personalized, meaning we have explainability of the result. What you see here on the slide, the machine will tell you this patient has MDS, but this is why. Or the patient has CMML, but this is why. What about prognosis? Multiple prognostic models in MDS, as you can see here, where we use blast, cytogenetics, and cytopenia with different degree of cutoff. Recently, we have the IPSSR molecular, which was incorporated molecular data into the IPSSR. Now, the problem in heterogeneity, that's across even IPSSM, by the way. So if you take about 1,500 MDS patients, you plot them on this slide. On the x-axis, you have the staging by IPSSR, and the y-axis, you have the survival. So if you look at the median, which is the sort of the cut in some of these, yes, the median survival for patients with low risk is better than intermediate risk. But if you look at each patient as a dot, you see patients in green, patients are alive, and in orange, patients who are dead. You see there are patients in low risk, actually. They have worse survival than patients even in high risk. And if you look at the intermediate risk in the middle, you see all patients all over the place, which means what we predict and with the actual survival of the patient is completely different. So we ask a question, can we build a model that predicts survival that is personalized, that is specific for a given patient? So what we did, we took demographic, clinical, and genomic data. That was another international collaboration between Cleveland Clinic and Munich Leukemia Laboratory, where we trained the model. And it's very important always when you build a machine learning model to externally validate the model in data that is completely different and unseen. So we validated the model from Moffitt Cancer Center. We also validated the model from 3 other cohorts, one prior to transplant, one during the disease, and one from clinical trial. I'm not aware of any model published where you have 4 external cohort validation prior to publication. We built this machine learning model, and the model extract the features. And this is the clinical feature and the genomic features of the model. And as you can see on the right, there's improvement in the C index compared to IPSS-R, even when incorporated molecular data. Now, what was really important, how do you use the model? So what we did, we deployed the model on this user interface. And what you see me doing here, changing the clinical variables for the patient, and then hit calculate, and you see the survival sort of change to be personalized for that patient. Now I'm adding more like worse features. I'm adding very poor cytogenetics and TP53, and you see the survival is more personalized and changing. So why this is important? We went back and we took data from the SWOG study. So this trial was designed for newly diagnosed MDS with high-risk IPSS, treated with AZA versus AZA plus LEN versus AZA plus vorinostat. You can see the trial was negative. Now, when we looked at the data coming from that trial, we had 75 patients who had clinical and genomic data where we can apply the new prognostic model. And what's really interesting, this trial was designed for high-risk MDS. In our model, 68% of those patients actually lower risk, not higher risk. And if you look at the overall survival on the right, patients with lower risk actually, by our model, their survival was doubled on azacitidine. Where patients with high risk by our model in the second line, you see their median survival actually with azalin was much better than azacitidine. So the question, did we get the right patient to get the right treatment on the trial? And have we chosen the right patient? Would have been this trial positive? So what about predicting response? We use azacitidine, and about 30 to 40% of patients respond and take about 6 months. We have no idea which patient is going to respond. So the question at that time, can we build a model to predict response or resistance? Today, we don't have any clinical models to do that. As a fellow at that time, and you can play trick with your mentors, you ask, what movie did you watch last week? And then the question, what movie they're going to watch tonight? And then if you switch mentors with patients and movies with gene, can we use the recommender system algorithm to predict response or resistance to chemotherapy? So we did this exercise, and we were able to find those genomic biomarkers that predicted resistance in 93% accuracy on a validated cohort from outside of Cleveland Clinic. What was really important about this, we went back to the lab and actually we looked at those gene mutations, and we were able to show that some of those combinations are primary resistant cells in the lab. Then we asked a different question, can we predict response to chemo by actually monitoring the count? So we give azacitidine, the blood counts a change. Can we monitor the changes in the counts and predict how the patient will respond? So what we did, we used something like Siri use. So for Siri to understand the words, the sequence of the words matter. So we used the same sort of analysis to actually take blood counts on patients with azacitidine for 12 weeks. We built machine learning algorithm. Again, we extracted the feature, and we built the final model. And what you can see here, we were able, based on the first 3-month CBC changes, to predict response at 6 months with very high accuracy. That's precision recall at about 83%. And again, the model is explainable. What's interesting about machine learning, you can put actually a lot of variables, and then the most important ones showed up on the top. So if you look here for the non-responders, for example, if you look below, RDW is a very important factor to predict no response, even though in clinical practice I've never looked at RDW. So you can see those blue lines predicted no response in RDW. So if you look what the algorithm is chewing on, it's a lot of variables that we as physicians don't even look clinically. So what about the future? The future is generative AI. So what do we mean by generative AI? This is the buzzword today. So generative AI is generating something from something. So text to text. I can give a model a text like ChatGPT, and then I get a text summarization, text generation, conversational question and answer. It can be text to an image, so I can give a prompt to draw a picture, and then that's give you sort of the picture. Could be text to video, and could be text to code. So I can write the text and provide a video. Now think about this in the future. You can generate the text, for example, using ChatGPT, and then generate the entire movie using the AI model. It could be actually the other way around, could be image to text. So I can give the model an image and can give me the text on it, and I can do some image modification, as you can see here, of that. So this is sort of the future that's going to change a lot of our lives in general, but also in research. Now, I thought I'll have a mouse here to play these videos, but these are AI-generated videos. I don't know if we can play the second one. If you just click on it. Here we go. So the first one actually, it's you take 2D images, you feed them to the machine learning model, and then construct all 3D images for the house. This is all AI generated based on just the photos that you take, and actually can generate its own images. Can you click on the second one? This is actually, the second one is more interesting. So this is what generative AI, we talked about text to image and text to video. Now you can see here, for example, you can provide text to say, write something here, give me a mountain, for example. Just provide the text, and it drew the mountain for you. And this is happening today. This is not science fiction. It's already happening. Draw a lake for you, draw some leaves, and this is, again, taking some of the prompts and drew this, and now you have the entire video generated by AI. So this is another important research came out of Meta. So what they did in this research, actually they said, that it's for people with a brain injury. So what they did, they took first model, sound to text. So the model actually can take sound and transcribe that to text. The second model on the left, using MEG. So this is like magnetic electron, like EEG of the brain. This is an image to text. So they combine those models between sound and image to provide a text, and then they put the electrode on the brain, and what they were able to do, you have the patient listen to music, and the machine transcribe the music that the patient is thinking of. They did the same thing on the right where they use a FLAIR MRI. In other words, you can read what people, if you put electrode on their brain, what they can do in the brain or they listen to based on the changes in the model. Now you can see this research where it's going to go, and especially in the future if governments have some of that type of research. But this is just the tip of the iceberg of where this technology can go. And I would argue today that in war of AI, in some tasks, we're losing to AI already. And this trend going to continue in the future and probably going to be actually worsening in some of those tasks. So we have to see. So why ChatGPT was special? Because if you think about this product, this is the first time in human history that a product reached 100 million users around the world in 5 days. You can look at the right, even Facebook, Instagram, all of this stuff never achieved that. And OpenAI probably now get more than 1 billion visits, and over 60% of ChatGPT social traffic come from YouTube, and probably 85% of the traffic come outside of the United States, so there is a lot of use. So what can you do with ChatGPT, which has now become like sort of the image of generative AI? There's a lot of things we can do. Actually, you can use it as a chatbot to ask questions. Patients, especially in the United States, they start using it, which is actually dangerous because the information sometimes is wrong. And then you can actually ask ChatGPT to write a research paper for you. Just be careful because there are some journals that start recognizing that you have to disclose if ChatGPT help you to write this. ChatGPT cannot be an author on the paper, although it's been tried before, but now most journals, even if you look at ASH policy, now you cannot put ChatGPT as an author, which is not fair, because there are some ghost authors that you can put, but you can't put ChatGPT as an author. There's a lot of opportunity for productivity using the system. I just want to mention this research, just to be careful when you're using the system, because the problem with the ChatGPT, it can give you very compelling answer, but fundamentally completely wrong. So what they did here, they used ChatGPT to answer questions from about cancer patients. And what they found actually that about 12 to 15% those answers are actually not related to the NCCN guidelines or any guidelines. So it can be actually a sort of dangerous system to use, and there's still a lot of challenges, especially in healthcare, that we have to overcome when we're using the technology. So first is the validation and the accuracy of the information. Again, the answer can be very compelling, very nicely written, but fundamentally is wrong. There's biases, actually, there are ways to bias the system in terms of the answer of the systems, and there's a lot of interesting articles about that. And the answer is actually biased toward, if you think about ChatGPT, what they did, they took all the data in the world from like Wikipedia and everything online, and then trained the model. And most of this data comes from the United States, so definitely there's bias against data, for example, coming from the Gulf region, because maybe there's not enough data in that to train this model there. Privacy is a big issue. Anything you put on ChatGPT, they take it and retrain the model. So anything related to your hospital, related to patients, you shouldn't be doing or putting on ChatGPT, because you're exposing this information externally. And more importantly, it costs about $700 million to operate ChatGPT per day, and the cost of carbon emission just from operating ChatGPT is humongous, and nobody talk about this, obviously. So finally, I want to talk about one very important thing, and the problem that we have in AI in healthcare today is the lack of talent. And how can we build the future of doctors and physicians that actually can be able to speak the two languages, the healthcare and AI language? So this is an initiative we have put together to kind of try to provide some courses that enable you to actually learn about machine learning. One of them will be no-code, low-code machine learning. There's one course about ChatGPT, and you can see the global interest in this website is globally around the world. So I really encourage you to kind of go online and try some of those courses. So in conclusion, AI is changing our lives. You're already using AI every day. I think generative AI will change our life for sure. There will be multiple jobs either eliminated or redesigned. And I think AI will have significant impact on healthcare, but we just have to know how to use it. And I'll leave you with this final conclusion. The electric light didn't come from the continuous improvement of candles. So if we really want to change healthcare, we really need to embrace the technology and take the full advantage of it to apply it to our patients. So again, thank you very much for the opportunity to be here, and I'm looking forward to a conversation with you.
Thank you, Dr. Aziz. We'll leave the questions to the end. Our next speaker will be Dr. Nabil Al-Muallimi. He's the section head of palliative medicine at Princess Noura Oncology Center at National Guard Hospital. Dr. Al-Muallimi, the floor is yours.
Thank you. Assalamu alaikum. Alhamdulillah. Good afternoon, and I would like to thank the organizing committee and Dr. Absi for the kind invitation. I'm going to talk about the integration of palliative care in hematology. So I have nothing to disclose. And first, we're going to talk about the palliative care and the definition of palliative care from the WHO perspective, and then I'm going to talk about the role of palliative care, the challenges and barriers in the process, and how we can overcome it. So we have a case. So Abu Salim is 64 years old. He's a known case of diffuse large B-cell lymphoma. He came to clinic for symptom management. Before you see him in the clinic, his elder son just jumped into the clinic and talked to you that don't tell him anything about his diagnosis. He doesn't know anything about it. So when you see the patient, he complains of pain, low appetite, and low energy. So how are we going to proceed with that? So how common do we see this case in our clinic? In my clinic, I'll say like 10 to 20%. I have this scenario where someone will jump in and tell me, don't tell the patient anything. And I think it's the same story in all over the oncology subspecialties. So palliative care is a holistic approach where we try to improve the quality of life for our patient and their families through controlling the physical symptoms, the spiritual, and social as well as much as we can when they are diagnosing with life-threatening diagnoses like cancer. Our aim is to start from the beginning of the diagnosis, as you know. Unfortunately, this is not the case in most of our cases. Integration is difficult due to different reasons that we're going to talk about later on. As you can see, this is the model that we are suggesting. This is the BOTA model, where you can see that integration of palliative and supportive care should be starting from the diagnosis, where the curative treatment will be started associated with palliation of the symptoms that should be done as well. Till the end, either the patient will go through the survivorship, we will continue to see the patient to manage their symptom that can be produced due to the disease itself or due to the anti-cancer treatment that he's taken through his journey. Otherwise, if they're going through the bereavement stage, where we continue to communicate with the family and try to take them through this trip. So the WHO thinks that the palliative care is a crucial step to all oncology patients, not only just for the hematology, and it should be done for everyone that is needed. The ASCO, and there's a lot of articles in the ASH as well about the early integration of palliative care. I think the importance will be shown later on in some slides about the recent studies that show that as well. What is the challenges that we see in hematology patients? That most of the time, that the unpredictable illness trajectory, as you can see from different diagnoses. In long-lasting diagnosis, most of the patients, they will have strong relationship with their physician, and this can be issue for the physician themselves or for their patient when they're trying to stop the treatment or communicate that you have to stop and we have to go for another type of treatment, which is palliation, or think about advanced directive later on. If it is one of the short journeys, most of the time the patient will have problems with seeing many physicians, and they don't have still building any rapport with any of the physician, and that can be an issue for the patient themselves. High number of severe symptoms, as we see comparing to the solid tumors patient that we see, and the psychosocial needs following diagnosis. As well, most of the hematological patients, they are having on diagnosis, the median age about 70, and this is already having a burden on the treatment options and the survivorship later on. One of the barriers that we see from a point of the hematologist, that palliative care is only an end of life, which is not the case, as you know, all of you. And most of the time, they feel less comfortable to discuss the end of life or advanced directive with their patient. As we know, mainly because they have strong relationship, they are investing in curative treatment from the beginning. It is difficult later on to discuss other options with their patients. From palliative care physician, the barrier that they think that most of the times that the strong relationship between the hematologist and their patients. Also, late discussion about end of life, and as we can see later, this is not only about North America or the Middle East, other European countries as well, lack of clear interaction between the specialties as well. And this is a study done in the United States that 56 of American hematologists report that they have difficulty in discussing the end-of-life discussion later on. This is a study that was done in France, and they're looking around 50,000 patients in hematology malignancies. What we found that around 46% they were think about as a palliative when they are about to die. As you can see, it was very late. Only 5.5% they died in palliative unit. So it's very late referral on those cases as well. Here, this is a study that done to compare hematological patients compared to solid tumors. As you can see, most of the categories were very significant when comparing. As you can see that most of the hematological patients have more than 14 days admission, more admission to ICU, more significant to die in the hospital later on. Prognostication, it is one that we discuss most of the patient. When the patient have one of these, they have less than 3 months, so declining performance status, and I think you know that, presents for at least 2 comorbidities, and disease status, persistent bacterial infection, and fungal infection as well, and treatment limitation due to age or disease progression. This is another study that looked at the aggressive treatment at end of life, comparing solid tumors and hematological disease. As you can see, we have double aggressive treatment, when looking in hematological disease. And when you compare to the prostate cancer, they were less fortunate than the others. or more fortunate, let's say, to have less aggressive treatment in the end. Dr. LeBlanc looked at patients that were admitted to the hospice in the United States. And when they look at the hematological patient, what they found is that they are more seriously ill when they're admitting to the hospice. They have significant shorter hospice length of stay, and they're more likely to die within 1 day or 7 days to admission, and more physically deliberated than the solid tumor patients. This is the benefit of integration of palliative care in acute myeloid leukemia, a study done by Dr. Jawahari. As you can see from the first paragraph, that the quality of life was improved very well when we did the integration of palliative care, and all the parameters were improving when integration of palliative care early in hematological malignancies. Another study looked at the cost for integration of palliative care, and here is very significant change. So it's costless to improve the quality of life as well. And as well, so decrease the readmission, decrease admission, decrease the cost on the nursing, and also improve the quality of life of your patient. So how can we integrate or incorporate palliative care to hematological patient? So first, don't wait for disease progression. Introduce it as soon as you can, based on the service availability in your center. What is the time frame? This is where they ask 60 experts and when to introduce palliative care to oncology patient in general. As you can see, most of that, if the survivor is less than 1 year, if they fail the first line, then everybody says that's appropriate to refer the patient. If the ECOG is 2 or more, then the patient is appropriate referral to palliative care. Open communication. And this is one of the most important issues that we struggle when communicating with our patient in palliative or oncology in general. So you have to communicate well with your patient. And doesn't mean that you have to address end of life in the first visit. Just you have to communicate with them well about their diagnosis, prognosis, and choose the appropriate time when you should address these issues, not in the ER when they are dying or at first on admission, as we said. So first, partnership. Always make sure that the patient is, you're partnering them with them and you help them through the journey. And empathy, not sympathy with you. Acknowledge their feeling and apologize if there's any issues there. Respect their feeling and give them time. I know that most of the time we have busy clinic, we don't have time, but put yourself in their shoes and imagine that if it was you or your relative or loved one, are you gonna take it in a hurry or just answer all their questions? Legitimize, as we said, their concerns and support them as well. Always try to let them talk more, let them express themselves. So ask them more, what do you think? How can I help you? Open-ended question is always the answer for anything, and try to help them through their own concern and questions. There is a study that looked at the preferences of physician and patient from a hematological point of view. As you can see, the red one is the physician and the blue is the patient. Most of the patients were looking to go outside of the hospital as soon as possible, where the physician didn't care about that. They were looking at survivorship. So there is big difference in preferences between the two groups. And I think it is the best that we can go to the middle and try to reduce the gap between our preferences and the patient preferences through communication. Teamwork. Have a team around you to support the patients and the families through their own concerns and help them to go through the journey. And the team should be concerned always about the patient and their family, should have your palliative care physicians, your nurses, and your social worker, religious advisors, spiritual workers, and so on. Shared goals, ensure that all the team members have the same goal that we address for our patients. And symptom management through the journey. And always, as I said, timely palliative care can help through the journey to improve the quality of life and sometimes improve the survivorship as well. How we can achieve that, there's several things that we can say. Either you do the primary palliative care, whereas either you have somebody in your team or you have a family physician that can help you through the process. And you do the secondary when the patient need more care, you refer them to the consultation services, or when they admitted to the palliative unit, which is a tertiary palliative care. So all these depend on the services and the resources that you have around you in the center. Okay. Advanced care planning, and it is always the elephant in the room. Nobody wants to talk about it, but however, as I said before, choose the right time to discuss it with your patient and their loved ones so that you can make it easier when the bad things happen. Educate your hematology staff, and we're not talking about just the physician. We're talking about the physician, the nurses, whoever work with the hematology patient in the ward should be educated about the palliative care needs and how to assess your patient needs and how to address them later on. So in conclusion, incorporating palliative care into hematology oncology treatment offers a beacon of hope for the patient and the family. The symptom treatment can be done through interdisciplinary team, and palliative care is the most effective and preventive measure when to introduce early in the disease trajectory. Timely palliative care is associated with improved quality of life and end-of-life care as well. Thank you.
Assalamu alaikum wa rahmatullahi wa barakatuh. Our next speaker, Dr. Majid Al Ahmed, he's an assistant professor at King Noura, at Prince Noura Cancer Center. He's going to talk about amyloidosis.
Bismillahirrahmanirrahim. Assalamu alaikum and good evening, everyone. And I would like to thank the organizing committee for inviting me. So I've been asked to talk about AL amyloidosis. So I'll start with a case of mine, one of my patients. Okay. So this is a 31-year-old gentleman who came with a 4-month history of respiratory symptoms, cough, hemoptysis, chest pain, dyspnea and fatigue with significant weight loss and constipation. So he visited many hospitals and was treated with multiple courses of antibiotics, thinking that this could be bronchitis, but no improvement. Eventually, a CT chest done, which showed multiple lung nodules with mediastinal lymphadenopathy. So he underwent bronchoscopy, and all of the microbiology workup came back as negative. Also, his CT abdomen pelvis showed GI or mucosal thickening, and underwent scope, which showed the fibril mucosa, easy to bleed. So multiple biopsies were taken from his GI tract, and which complicated also by bleeding. The interesting thing about that, so the biopsies actually showed evidence of amyloid deposition with a positive Congo red stain. Also, a CT-guided biopsy was taken from one of these lung nodules, which also showed the same thing. So there was amyloid deposition in his lung nodules. He underwent echo, which showed left ventricular hypertrophy with thickened intraventricular septum with preserved ejection fraction. So he was referred to us, and by clinical examination, he looked chronically ill, very cachectic. His blood pressure was fine with no orthostatic drop. Saturation was fine. There was no organomegaly, and otherwise the rest of the exam was fine. His lab showed actually elevated BNP at 265. And his troponin was, troponin was 214, but there was no nephrotic range or no proteinuria in general. He had abnormal kappa lambda, so lambda was 153, and abnormal ratio, as you can see, 0.05. This is actually a picture of his ECG, showed low voltage, as you can see. And we did a PET CT on him, which showed diffuse uptake in the GI tract, with some lymphadenopathy and multiple lung nodules. He had also a cardiac MRI which showed preserved ejection fraction, but thickened ventricular septum with of 1.5 centimeter, and evidence of hypertrophic cardiomyopathy on imaging. So bone marrow biopsy done for him, and it showed plasma cells of 10 to 12%. Some of them had abnormal forms on morphology, and his bone marrow also was positive for Congo red stain around the blood vessels. So, final diagnosis, AL amyloidosis with involvement of the heart, GI tract, lungs, and bone marrow with significant plasma cell population, but he did not fit diagnosis of multiple myeloma since there was no CRAB features. So he was started on DARA VCD, and after the first cycle, he had significant improvement in his symptoms. So all of the respiratory symptoms were gone. And after 2 cycles of DARA VCD, he achieved complete hematological response with normal kappa lambda ratio and difference in the free light chains of less than 10, and patient was able to go back to work as a full-time. So, amyloidosis. So basically, this is the way how I describe it to my juniors, that this is a misfolded protein that act like a glue. So it sticks to any organ and causes organ dysfunction. So the problem with that, as I will show you, it doesn't have any specific feature because, you know, it depends on which organ involved. So, but we need to remember that not every amyloidosis is AL amyloidosis, because there are other forms of amyloidosis that we have to differentiate between this and that. So, for example, the transthyretin amyloidosis, which mainly affect the heart, and the AA amyloidosis, which happens with chronic infection, which affect mainly the kidneys. It's a rare diagnosis, so it affects about 10 person in 1 million population. It's mainly affect elderly people, but you saw in my case, the patient was 31, which is very unusual as a presentation of AL amyloidosis. More commonly, it's lambda, so whenever you see lambda light chain, think more about amyloidosis as well. It's a great mimicker, so it can, as I mentioned to you, it can present in any way, so there is no specific presentation. So it can present as symptoms of heart failure, so, and the differential diagnosis is quite huge. It can present with GI bleeding, peripheral neuropathy. So, so you have to keep your differential diagnosis broad and think about it. The problem with that, you know, it's been reported that there is always a huge delay in getting the diagnosis. Most of the patients get diagnosed after 2 years of starting the symptoms, which is result in significant delay and worsening of the patient's clinical condition. So by the time we get to the diagnosis, the patient had already like end organ damage that might affect his prognosis or affect the choices of therapy. It can affect multiple organs, you know, heart with evidence of cardiomyopathy, arrhythmias, sudden cardiac death, GI tract, which can lead to GI bleeding, organomegaly, liver dysfunction, involvement of the kidney in form of nephrotic range proteinuria, renal failure. It can affect the nervous system with different either motor, sensory, or autonomic neuropathy, as you've seen. So renal involvement, this is one of the most common presentation. It mainly presents as asymptomatic proteinuria, but it can lead to a nephrotic range proteinuria. Cardiac, also it happens in 60% of the patients in form of restrictive cardiomyopathy or hypertrophic cardiomyopathy. Usually there is involvement of the intraventricular septum, so that's something must be examined well during echo or cardiac MRI. As you can see here, there is significant thickening of the intraventricular septum in the upper echo, as you can see here. So also the late subendocardial enhancement on cardiac MRI. This is one of the features that goes with such diagnosis. One of the issues with cardiac amyloidosis is the arrhythmias that might happen in these patients leading to sudden cardiac death. and that affect even the choices of therapy. So medications like amiodarone or digoxin, it can put the patient into higher risk of arrhythmias. So you have to work with an expert cardiologist in that regard. Elevated N-terminal BNP or troponin associated with higher cardiac morbidity. Peripheral neuropathy, as I mentioned to you, it can be motor, sensory, or autonomic. And patient can also present with compression neuropathy related to carpal tunnel. So how we approach a patient with suspected AL amyloidosis. First, we need to confirm that there is an amyloid deposition. Then we have to specify what kind of amyloid, because not every amyloid deposition is AL amyloidosis. And then we have to identify the organ involvement, because by that, it affects the patient prognosis and choices of therapy, and look for underlying causes like myeloma or lymphoma. So how we confirm the amyloid deposition? The simplest way is by the congruent stain. It has acceptable specificity, but not very sensitive. The golden standard is actually mass spectrometry, but the problem, it's not widely available. So that's why immunohistochemical staining and electron microscopy could be an option, especially if the clinical scenario goes with diagnosis of AL amyloidosis. Also, there is an important hint, presence of clonal plasma cell disease. So finding a clonality of plasma cells in the bone marrow or abnormal kappa lambda ratio, that's a hint that there is ongoing plasma cell disorder that support diagnosis of AL amyloidosis. Organ involvement, extensive workup with history, physical examination, echo, cardiac MRI, liver testing with ultrasound, endoscopy sometimes needed, and nerve conduction study with possible nerve biopsy. You have to look for underlying cause, multiple myeloma, or other lymphoproliferative disorder like Waldenstrom. This is something need to be done. So these are the diagnostic criteria for diagnosis of AL amyloidosis. You have to confirm, as I mentioned to you, the amyloid deposition, the clonality, and you need to rule out other causes. So something I want everyone to remember, so if you have someone newly diagnosed myeloma, MGUS, or smoldering, as part of the workup, you have to make sure that there is no clinical evidence or biochemical evidence of cardiac amyloid. So it's been recommended for any newly diagnosed MGUS, smoldering myeloma, you need to do the NT-proBNP, troponin, 24-hour urine for proteinuria, just to rule out presence of amyloid, plus the history and physical. So in your interview with the patient, you have to ask about all of the symptoms that might suggest presence of AL amyloidosis. So prognosis-wise, so there is multiple, so based on the organ involvement, but the most commonly one that we use in our clinical practice is the second one, because it's involved the use of BNP. In most of our hospitals, we don't have the NT-proBNP. So if the cut limit of 700 or more, it tells you that this patient is more advanced and associated with a worse prognosis. As you can see here, the difference between patients with different stages. The stage 4 has a very worse prognosis, up to survival of 6 months only. The same thing also with renal, so more renal involvement affect the patient prognosis significantly. This is actually summarizes the response criteria based on which organ involved, and also it tells you how can you define the progression if the patient has responded initially. So what's the goal of therapy? So the therapy of AL amyloidosis, the most important goal is to suppress that clone of plasma cells that produces this misfolded protein. By this way, you are giving time for the tissue to recover from the injury that has happened. And this is best achieved if we achieved a very deep response with involved free light chains of less than 20 and difference of free light chains of less than 10. So remember these numbers. We need to be as deep to reach to that because that is associated with better prognosis. Management include multiple teams based on the organ involvement. It's not only a hematologist, so it has to be worked, patients with amyloidosis need to be treated in a tertiary center where expert multiple specialties can be available. So in the old days, conventional chemotherapy was the way to go. So melphalan with DEXA was the standard of care, but that associated with more toxicities, so like secondary leukemias, and even the response rate was not best until the proteasome inhibitor came, and then the VCD became the standard of care with response rate reaching up to 80%. But can we do any better than that? So that's actually achieved with the addition of DARA. So DARA VCD with the Andromeda trial, so newly diagnosed AL amyloidosis with multiple organ involvement and absence of myeloma. They were randomized to receive either VCD or DARA VCD, as we can see here. And the results were quite impressive. So almost the response rate was 100%. And most of the patients achieved the VGPR. And this is what we need to achieve, because patients who achieved VGPR, regardless what they receive, they do better with AL amyloidosis. Transplant is always encouraged to be done, but you have to select your patient carefully. So patients who are excluded, if they are elderly, poor functional status, significant cardiac involvement with drop in the ejection fraction, or there is some reports with the intraventricular symptoms of more than 1.5, because that's associated with worse outcomes. Liver impairment with bilirubin of more than 2, and eGFR of less than 50. If there is abnormal cardiac enzymes, that gives you a hint that patients might have a higher transplant-related mortality. You need to consider reducing the dose of melphalan if you are taking the patient for transplant, and transplant must be done in expert center because transplant-related mortalities in these patients are higher. But if that's done successfully, reports show that these patients, they do very well with overall survival of more than 13 years. Maintenance therapy, there are no consensus. In the Andromeda trial, they included DARA maintenance of 2 years. But after that, nobody knows what to do, and there are no consensus about doing maintenance. But if there is associated myeloma, definitely maintenance therapy would be indicated. So there are some special considerations that I'm going to mention. So cardiac amyloidosis, so you have to be careful, especially if they are stage 3B. These patients, they do poorly in terms of tolerance to therapy. So try to avoid DEXA, because that can worsen the heart failure symptoms, or at least reduce the dose. There are some suggestions that DARA as a single agent for advanced cardiac amyloidosis might be a better option. Neuropathy, you have also to be careful with the use of bortezomib, so reducing the dose or avoiding bortezomib at all. Other options can be considered lenalidomide, daratumumab-based therapy. Also with liver dysfunction, since bortezomib, lenalidomide, and alkylators all can be metabolized by the liver, and also added the hepatotoxicity. So if there is advanced liver dysfunction, stay away from these medications at the beginning at least. Use single agent DARA, and then you can escalate your therapy. Patient requiring dialysis, this is not a contraindication for transplant, but if the patient have a heavy proteinuria, remember that daratumumab is a protein, so it will be excreted in the urine, so that might affect the efficacy of daratumumab. If you are dealing with IgM amyloidosis, so here this is most likely related to a non-Hodgkin lymphoma, so the treatment option would be rituximab based as rituximab bendamustine, or rituximab bortezomib as an option for these patients. Relapse refractory setting. So what the definition of relapse in these patients? So it would be clinical, but I think the most important and the one that trigger our treatment is biochemical, because you don't want patients with relapse to come to you with end organ damage, because prognosis in these patients are very bad. So there are some suggestions that once you have these figures, so difference of free light chains of more than 20, or increase up to more than 20% from the baseline, or 50% from the best response you have achieved, initiate therapy. The option would be, there are also no consensus, but proteasome inhibitor like Ssbmt has been shown efficacy, as you can see here, in more than 50% of the patients. Immunomodulatory drugs also of help with these patients, although the tolerance in these patients are low because of the GI intolerability. So we have the options, lenalidomide, but the data from the pomalidomide showed superiority. Try to use a dose of 2 milligram, not 4 milligrams, since it's better tolerated with that group of patients. Monoclonal antibodies also, as it's shown, effective in the upfront. It's effective in the relapse refractory setting. There are some newer agents that being in the use of phase 1 and phase 2. So the monoclonal anti-SAB, the SAB depleting agent, and anti-febrile monoclonal antibodies. But unfortunately, there are some unfavorable risk-benefit profile and fatality with these agents, which affected the use of these medications. So this is just to summarize what I've said. This is my conclusion. So for patients who are low risk, consider induction with the Cybor-D or DARA Cybor-D, as you with the newer data. Consider stem cell transplant with melphalan. For patients who are intermediate risk, also the same thing, but you have to be careful. You might need to adjust the doses of your medications. For high risk, definitely they will not be transplant eligible. You can use agents like single agent daratumumab, reduced doses of bortezomib and dexamethasone for that group of patients. For relapse refractory, so it depends on the case, but pomalidomide, Ssbmt, monoclonal antibodies, all are available options and showed efficacy. Thank you, and happy to take any questions during the discussion.
Thank you, Dr. Majid. We're going to take the questions at the end of the session. Our next speaker is Dr. Khalid Al-Halahla. He's the Director of Adult Bone Marrow Transplant and Cellular Therapy at King Hussein Cancer Center. He's going to present CLL. Welcome, Dr. Khalid.
Assalamu alaikum. Assalamu alaikum. First of all, I would like to thank the organizers, Dr. Askar and Dr. Absi, for the invitation, and thank you, Mr. Germans, for the introduction. So for the next 20-25 minutes or so, I would summarize the frontline therapy for patients with CLL. So this is my disclosure. These are my agenda. And this is the timeline, with the improvement in the diagnosis and risk stratification of patients with CLL and the introduction of novel therapy for patients with CLL, and over the last 5 or so years, all of these novel agents, including BTK inhibitors and BCL2 inhibitors, went for patients with CLL. So to get you back to the risk stratification of patients with CLL, this is an old, since 2016 was published, the CLL IPI. They got the 2 sets of a training and validation set of more than 3,400 patients. And from this data, they get a training and validation set, and they compared it with the external set, and they identified 5 variables that were significant, and they did stratify patients to 4 groups: low, intermediate, high, and very high. And all of these risk groups were calibrated from your right-hand side with overall survival. And also into the risk stratification, they included patients who didn't respond to perenalog. This is at the time of chemotherapy, and those relapsing within 24 months after the chemoimmunotherapy. And the risk factors during the targeted therapy era, they classify patients to 3 groups: standard, high risk, and very high risk. including patients with 17p or TP53 mutation. And when you consider what factors you would consider when you want to treat your patient, definitely we treat patients when they are symptomatic and there is an indication to treat. And it's very important to take the patient's and disease characteristics. So from the age of the patient, the presence of comorbidities, the therapy available and the patient preference, of course, the prognostic features of the patient, genomic features, including the 17p TP53 mutation or LQ deletion, and also if you're going to choose the fixed duration therapy or continuous oral or intravenous. So the first question is, who should be treated patients with CLL? So if you go with the international working part of the CLL, we treat patients when you have an indication to treat. So when you have an active disease, those with advanced stages, stage 3B, stage 3 and 4, and Bennett C and Rye, stage 3 and 4, and when you have an active and progressive disease. So not all patients needs to be treated, and some patients we can observe, we can put them on which and what. And recently there is studies going on regarding the 0.2 years for patients with unmutated gene. And also the disease progression after 10 years are very rare, and only 4 or 5 patients in those with a mutated IVIG were progressed. And I like this, an editorial was published just recently, and when you compare the old FCR with the novel therapy-based approaches, venetoclax-based or ibrutinib-based, look on the curve using the FCR. So the curve is flattening, and we can say this is a functional or potential cure for patients with CML, with the CLL, and those patients are young, fit, carrying the mutated IVIG status. So don't forget, this is not a good approach for patients with a bad risk features, for those with deletion 17p or p53 mutation, because the median progression-free survival for those patients is only 11 months, and the overall survival only 33 months. But how to compare the result after 20 years of follow-up for those received FCR versus those received venetoclax fludarabine-based with like 5-6 years follow-up? So what's the preferred or the best option used frontline? So sure, these with BCL2 inhibitors and BTK inhibitors were the preferred, probably the preferred frontline agents in most of clinical scenarios, with the exception of the use of chemoimmunotherapy in the small fraction of patients, those with a fit, young, with mutated IVIG. So what BTK inhibitors we know till now? We have 4 BTK inhibitors approved for a frontline and relapse refractory setting. We have an ibrutinib, ecallabrutinib, zanubrutinib, were approved by FDA, approved by FDA for frontline and relapse refractory setting, and the pirtobrutinib was approved after failure of 2 lines for those with relapse refractory CLL. So what's the difference between all of these? Probably, I'm going to show you the result of phase 3 trials. The efficacy of all of these agents in the frontline were similar, but probably with a different safety profile between all of these agents. So this table, sorry for the busy table, but what I wanted to show, there is multiple phase 3 trials that were published and proven the benefit of continuous first-line BTK inhibitors and ibrutinib and ecallabrutinib in one of the studies with a reasonable follow-up time, with sustained, durable, progression-free survival and overall survival benefit in most of these studies. So I'm going to go through some of these studies just to show you what are the criteria and what is the benefit, what's the result of these studies. So the first one is the RESONATE-2 study evaluating the use of continuous ibrutinib frontline compared with an old drug chlorambucil. And as you can see, this study included patients more than 65 years untreated without mutational status. Again, the benefit at 7 years were in mutational status. Again, the benefit at 7 years were in favor for the use of continuous ibrutinib compared with the old standard chlorambucil. And as you can see from the subgroup analysis, all of patients, regardless of the age, gender, stage, and academic performance status or bulkiness of the disease, and baseline characteristics also, some of patients were p53 deleted patients, all benefited from continuous use of ibrutinib when compared to chlorambucil. And as you can see, the responses is high. Objective response is 92% versus 37% in those who received chlorambucil. And as you can see, the CR is progressively increasing with time. So when you give ibrutinib for a longer period of time, you're going to reach more, you're going to get your patient or more patient into CR. This is a study comparing also the continuous use of rituximab with ibrutinib versus the old standard of CR. And this is in a younger than 70-year-old. This is an ECIG 1912 study with a 6-year follow-up. Again, from the graph you see on your left-hand side, so the continuous use of ibrutinib with rituximab improved the 5-year progression-free survival compared with the old FCR. And also in those patients with unmutated LOC, the improvement in 5-year survival from 33 to 75%. And also the earlier result of the FLAIR trial also proved the benefit of the use of continuous ibrutinib in combination with monoclonal antibody, CD20 monoclonal antibody. So the median overall survival was not reached compared with only 66 months in those patients received FCR. Of course, there is not much of different. There is a different even in those with mutated. Even ibrutinib rituximab improved the patient with a mutated IVIG status. And this is the overall survival, look on the 5-year of survival using the ibrutinib rituximab. So 5-year survival 95% versus 89%. And regarding the safety profile, patients who received ibrutinib rituximab got higher risk of hypertension. These are the usual stuff of cardiac toxicities from ibrutinib, infection a little bit to do comparable, and the cardiac events, including atrial fibrillation, in 4.5% versus 0%. So more cardiac events with the continuous use of ibrutinib compared with the FCR with more neutropenia, more neutropenic fevers. This is the third, the Alliance study also compared the ibrutinib plus minus rituximab with the bendarituximab. And as you can see also, the use of ibrutinib continuous with or without rituximab improved the progression-free survival with a hazard, with a 4-year survival of 76 compared with 47%. So here you use ibrutinib alone or the rituximab, the results were in favor of compared with chemotherapy. The last eliminated study also compared the ibinitizumab with the ibrutinib compared with the chlorambucil ibinitizumab. Again, the median overall survival was follow-up was 40 months. The objective response were high, 88%. Versus 73 with higher complete remission rate. And at last update at 42 months follow-up, the progression-free survival was 74 versus 33%, but there was no difference in overall survival. And we're getting ibrutinib with ibinitizumab. Of course, it is better from your left-hand graph. Those patients benefit from the use of ibrutinib and obinutuzumab combination. So I'm going to show you the update from the ASH 2023. This is for patients using or used ibrutinib, only ibrutinib, and they followed them annually with for the first 5 years with the CT scans and the clinical examination, and they followed them also for MRD, and the primary endpoint was progression-free survival, and the secondary was overall survival. And as you can see, those are high-risk patients included. They compared it with the high-risk patients, including P53. And as you can see from your left side, the CR rate was, I think, 21 versus 27%, and the depth of response was increasing with the longer use of ibrutinib. So when you use continuous and ibrutinib for a longer period of time, you can get your patient into more CR, and you can get him into deeper response. And this is the progression-free survival. The median was 85.9. And and also on your right side, the survival of the ibrutinib front line for those with the P53 mutation. Looking overall survival at 117 months, 58 months for all patients, 74 for treatment naive versus 54 for relapse, for those with a p53 mutation. So longer use, the longer follow-up for those patients who received the ibrutinib still proved the benefit of using BTK inhibitors over chemotherapy therapy. This is again the study, the ELEVATE study, the use of acalabrutinib with or without obinutuzumab versus the old chlorambucil with monoclonal antibody in a previously untreated patient. They randomized patients less than 65 and more than or more than 65 with a SIR score more than 6 and creatinine clearance of less than 70. So these are high-risk patients. They randomized them to acalabrutinib versus with obinutuzumab versus single-agent acalabrutinib versus the old standard chemotherapy. And the primary endpoint was progression-free survival, and the crossover also allowed when there is a disease, definite disease progression. And these are the baseline characteristics of patients. Roughly 40 to 45 patients had high-risk cytogenetics and stage 3-4 disease, and in p53 mutation was present in 10% of patients. And this is the PFS at a longer follow-up at 6 years. You can see the median progression-free survival was not reached in acalabrutinib arm with or without monoclonal antibody, compared with only 27.8 months for those who received chemotherapy, with 6-year PFS of 84% compared with only 25%. And look, the 6-year PFS, 78% compared with only 17%. And those who were crossed over when they progressed, look on the PFS, 54%. So this is again to show the PFS in patient with p53 mutation and according to the treatment arm. So those who got acalabrutinib, they get improved progression-free survival, as you can see from your left-hand side. And sorry for that unclear scheme. So this is the update from the ASHA 2023. As I did mention, the median survival 87. There was no much of difference between all of the treatment arms, but those with a p53 mutation, they got benefit from the use of acalabrutinib. And this is the side effects, the common adverse events, and the serious adverse events from the patient used acalabrutinib versus chemotherapy. And most of the common adverse events were generally consistent with the previous data, previous result analysis, and the incidence of cardiac events, atrial fibrillation, and flutter remains very low. So this is one of the drug that's compared, when you compare it with the safety profile of ibrutinib, it's more favorable, has a more safety and favorable profile. This is the zanubrutinib data also used in the front line. Zanubrutinib versus chemotherapy, bendarituximab in patient previously untreated. They have two cohorts. One cohort, the first is without 17p deletion, and the second cohort with the 17p deletion. And they're randomized to zanubrutinib as single agent continuously versus bendarituximab. And the second cohort, they're just randomized to, no, they get only zanubrutinib, and the primary endpoint was progression-free survival. And as you can see, the zanubrutinib improved progression-free survival, and at 4 years, 82% were disease-free compared with the 50%. And those patients, when we compare those with mutated or unmutated IGHV, and to overall population, those who got zanubrutinib, regardless, they get benefit compared with patients who received chemotherapy. And this is the overall survival. So at 4 years, 90% versus 80%. And again, there is no safety signals from the use of zanubrutinib in those patients. This is the CLL14 trial using the fixed duration. So we talked about continuous use of BTK and compared with chemotherapy, and now we're going to discuss the use of fixed duration first line of obinutuzumab with venetoclax or chlorambucil. And this is the safety run-in phase. They randomized patients untreated CLL with existing medical conditions, high-risk features, again, high-risk profile, the stairs more than 6, and the clearance is less than 70. And they randomized them to venetoclax and ibrotuzumab. So it is a 4-week cycle to fixed duration of 12 cycle of venetoclax, over 5 weeks, combined with obinutuzumab, and the clombroxil also was given to 12 cycles, and the monoclonal antibody was given only for 6 cycles, and the primary endpoint was PFS. And as you can see, so those patients, they got 12 cycles, 1 year of therapy, and they randomized them, and look on the progression-free survival, there was an improvement in PFS in those patients who got the venetoclax-based therapy, but on the right side, you see there was a trend, but there was no survival. There was a trend in improving survival, but it was not statistically significant. Those patients with mutated IgG were improved their PFS, and those with no mutation or no deletion of TP53 also had an improvement of progression-free survival. So also another secondary endpoint for this study is the MRD, and those who got an MRD of less than 10 to the -4, they had an improved survival from the use of venetoclax fixed duration with ibinutuzumab. So this is the CLL13 trial, also the use of fixed duration of venetoclax with anti-CD20 monoclonal antibody with without ibrutinib, so what's called the triplet therapy. They randomized fit patients, CLL, with less than 6, clearance more than 70, and no previous therapy for CLL. Of course, here there is no p53 mutation or 17p deletion. They randomized them to the triple therapy of ibrutinib, venetoclax, and obinutuzumab versus venetoclax, ibinutuzumab, venetoclax, rituximab, or the usual conventional, all the standard of chemoimmunotherapy. And these, the primary endpoint was the MRD negativity. It is less than 1 cell in 10,000 leukocytes analyzed. So those patients got fixed duration, again, 1 year of therapy, compared with chemoimmunotherapy of like only 6 cycles. And when you get to the primary endpoint, the MRD, comparing venetoclax, obinutuzumab, compared with chemoimmunotherapy, there was an improvement in MRD negativity from 52 to 86.5%. And also when you get to the triple therapy using the ibrutinib, venetoclax, ibinutuzumab, and you compare it with chemoimmunotherapy, also still the MRD was significant and improved from 52 to 92%. So at a median observation time of 50.7 months, compared with chemoimmunotherapy and rituximab venetoclax, still those patients who got triple therapy or got venetoclax-based therapy, they had an improved progression-free survival and overall survival. This table showing also the fixed duration on the use of venetoclax with BTK inhibitors. And what I wanted to show you, look on the undetected minimal residual disease at a reasonable follow-up time with an improvement objective response and PFS, and in some of the studies, overall survival. So there are lots of studies. I'm going to discuss 1 or 2 studies regarding the use of combination of BCL2 inhibitor with BTK inhibitor. And this is a study using chemotherapy-free fixed duration regimen and 4-year follow-up for those patients who got fixed duration. This is not randomized, the fraction of patients. 159 patients, they got to 12 cycles of ibrutinib venetoclax after giving 3 months of ibrutinib. Sorry?
Dr. Khalid, you have 2 minutes more?
Just 2 minutes?
Okay.
Then I will skip some of the slides. Okay, and they followed them, and upon progression, they got salvage therapy. So this table showing the patient who progressed and patient who didn't progress. As you can see, in patient with CLL with the disease who progressed on this therapy, the risk factors were comparable with more in those CLL patients who progressed in therapy. And look on the at a median follow-up of 57 months, those patients with unmutated IgG had a 70% PFS, and the progression-free survival were improved across most of the high-risk patients. So I will skip these slides. And again, this is the GLUE trial 4-year follow-up, also showing the improvement in progression-free survival and those with unmutated IVIG. This is the last, if you allow me just 2 minutes, just elaborate on this in an experimental approach of patients using therapy based on MRD. So the first study we know that was published previously, continuous use of ibrutinib rituximab compared with chemotherapy improved the PFS, and the FLAIR follow-up trial comparing the ibrutinib venetoclax compared with FCR. Again, 6 months of therapy for FCR, and these 2 to 6 years of therapy with venetoclax ibrutinib. And this is an UK data. They decided to give those patients more extra 2 years after being MRD negative. This is the characteristics of patients, and these are the risk profile for those patients. And again, just one thing to say, at 9 months, you see the ibrutinib venetoclax, 60% of patients get into CR/CRi compared with the 50%, and even any time during therapy, the 92% got into complete remission compared with the 70%. And on your right side hand, one thing to say, those patients with mutated IgG, at 2 years, only 39% got into MRD negative, compared with more than 50% of patients with unmutated IgHV. Again, there is an improvement in the progression-free survival of ibrutinib venetoclax compared with chemotherapy, and there is also an impressive overall survival in this trial in particular. Regarding the safety signal, again, the usual classic, and there is no new signal, safety issues. And with this, I would conclude. So chemotherapy might be still an option in a small fraction of patients, especially in our region. So upfront BTK-based therapy resulted in sustained PFS and OS compared with chemotherapy. New BTK inhibitors have comparable efficacy profile with better safety data. And achieved of undetectable MRD is not a requirement for long-term disease-free survival based on the long-term 10-year follow-up. A prior treatment, P53 and unmutated status impact the prognosis. So fixed duration therapy might be a better option for young fit patient, and high-risk patient deletion 17p53 mutation treatment is still unclear, and the MRD guided approach is still experimental, but we can use it to decide on the duration of therapy, especially for those young patients. And with that, I would conclude. Thank you very much.
Thank you, Doctor. I will invite the presenter to join us here for a question for panel discussion. And we'll take questions from the audience. Anyone has any question to ask?
Thank you for all the presenters. My question to Dr. Khalid, first of all, congratulations on the Jordanian national team for what they did in the Asian Cup. Very amazing. My question is, for CLL, what are the phenotype of patients that you will choose fixed duration versus continuous therapy?
Regarding the fixed duration versus continuous, always we're aiming to use the fixed duration. You know, with the risk of having the mutation in the BTK, probably using the fixed duration probably is better than using continuous. Though, again, having like a continuous single agent like ibrutinib, it's also wise. So answering your question, still I would use fixed duration in those patients who are young, who are fit, where I am aiming to stop therapy and to decrease the risk of secondary clonal evolution and somatic mutations. Those patients, I would choose the fixed duration and not a continuous approach. I don't know if I answered your question or not.
Any other question?
My question is to Dr. Aziz. I want to ask you, what is the percentage accuracy acceptable for AI if you compare diagnostic workup?
That's an excellent question. So setting the right expectation of the technology will actually lead you to success in understanding that. So I think you have to, in any model you build, you have to benchmark it to what is the standard today. So if you're building a survival model and your survival model C index, let's say, is 65, 0.65, the new model is 0.75, that's significant improvement. When it comes to diagnostics, the question becomes, it's really hard to find a system that has 100% accuracy. And even as a human, we don't have 100% accuracy. So one way to think about it is a complement of a human to improve their accuracy. So the system on its own doesn't operate. It will collaborate with the physician to make a better decision. And then you can use the system, for example, for areas, underserved areas. So the question, can I bring physicians in the underserved area to become at a level that you have in a tertiary center using AI? So that's another way you could look at it.
Sorry, I have another question for Dr. Majid Al-Ahmadi. We clearly have a problem in early diagnosis of amyloidosis. On the other side, for other amyloid, for not AL amyloid, we get often referrals from other specialties, especially in neurology with neuropathy and positive serum amyloid level. And what is the role of hematology in this setting? Like identifying whether this is AL amyloid versus other amyloids, and what's next if it's, let's say, ATTR or other types of amyloid.
Yeah, so basically, as a hematologist, you know, we treat our focus mainly on the AL amyloidosis because the transferrin or the AA amyloidosis, it has different, background. It's inherited. The treatment is completely different. It has nothing to do with plasma cells. So the way of the management is completely different. I see your point, and I see it. I'm getting now more referral from, for example, from one of the nephrologists because he or she is more, interested in that area. So it's more of related to awareness. So when you have someone who is more interested in that and more aware about that, you will get more referral, which I prefer to see more patients rather than, even if they are not true amyloidosis, rather than missing one. So we are okay to get referral of 10 cases suspected amyloidosis, and then out of that 10, we have 9 of them are not amyloid, but we pick up one. That's fine. At least we get people early. Like as I showed you, most of the patients, they get up to 2 years till they get the diagnosis, and by the time they get there, they have more than 2 organs involved, so they will not be eligible for transplant. Their tolerance for therapy would be fine. So we want to see more referral. This is actually, I would be happy to have that. So.
Investigating and
it's awareness. It's awareness problem. It's awareness problem. People that and for example, MGUS. So if you've got a patient with MGUS, you cannot say 100% that's MGUS until you are sure that there is no associated amyloid, because sometimes the free light chain is not like in the 1,000. It's small, but it's just misfolded. It's a bad lambda light chain that will give the amyloid. So one of the things that you, as routinely done for any case of referred for abnormal free light chains, clinically and biochemically, you have to make sure there is no amyloid.
Perhaps we need to aware our clinical practitioner at the primary health care about the amyloidosis for early referral. Dr. Ahmed, تفضل.
Yeah, thank you, and great talks. I have a question to Dr. Nabil. I like the approach of integrated approach rather than a distinct palliative care, which is, I see, not acceptable in our culture. It may be acceptable in the West, okay, your care is done, we have nothing to offer, now you go and die in peace. This is not acceptable in our culture. People would like to have gradual, they will never surrender, they always have hope. So the care should be continuous, and I would encourage this approach that to be actually applied in our hospitals rather than palliative care.
Well, actually, thank you, Dr. Ahmed, for the question. I think we're doing that with the combined care with our hematologist, especially for hematology malignancy, as you know, and some other malignancies as well. As you know, one of the issues is the relationship between you as an oncologist and the patient. Most of the time, it's strong. So we try to invest in that relationship, to build on it, to have a combined care where the patient will accept to see us and to build a rapport. The issue that sometimes that the patient will be referred late. And when it is late, there is no benefit really other than symptom control. And that's why I think integration is the best approach, where you have a team in place to address these issues starting from the beginning. And I think it's always, as you said, the best investment in educating people, in educating the nurses, the team around, and how to screen the patients, and how to address the issues, and how to even start nursing-led consultations. That will be better and be more suitable economically for the program, where you have a nurse-led consultation that will start, and the nurse specialist will assist the patient later, or the palliative specialist will assist the patient within the unit. But as I said, I think integration is always the best approach to our culture, to our patients as well.
We have another question.
Do we have time? Okay, it's a comment rather than a question, and I mean amyloidosis with Dr. Majid. Actually, in Egypt, we are having heavy populations, so we can see all the varieties. We used to have a lot of referral for amyloidosis cases with macroglossia, for instance, from neurology and from nephrology particularly. And I will focus here the dialysis-associated amyloidosis, for instance, cases of non-mutated transthyretin or senile transthyretin. We have a couple of drugs now, tafamidis and diflunisal, which could treat such cases. But the point is, who should tackle, or who should be the treating physician for those patients? This is the issue. The third thing is, we do have some rare variants of amyloid deposition. In an Egyptian study, we found a good number of cases of leukocyte-related amyloid deposition, not only the common transthyretin. So I think, first of all, we need to know or to educate ourselves and others how to properly diagnose the patients, because if the patient is not plasma cell related, I will not find Congo red in the bone marrow. So we have to teach others that just a sample from the anterior abdominal wall fat could declare or disclose the presence of amyloidosis with Congo red, then to classify them if they are inherited or non-inherited, and what to do next, and who is the one to be responsible for their treatment. Any comments?
Well taken. Yeah, the problem, it's the rarity of the disease, and when we have these special situation, it's even more rare. I don't think it's who as a specialty, but who as expertise, because and that's the beauty of having a referral center. Like if we have nationally, if we have a referral center for such cases, so then the experience in that center will increase, okay? And it will be a reference for other places. Like, in some places you see that, some physicians, they just see these very weird and rare cases and they see none of that. So other than that, which is, I think might be an option in such cases.
Thank you for the presenter. We'll have now 10 minutes break for
one question. A question to Aziz, actually. Are you aware of any verified work that verifies natural language processing, NLP, and recognition systems for Arabic dialects for healthcare related uses? I mean, different Arabic dialects.
Well, depend on the Arabic you're talking about, but ChatGPT, GPT-4 in translation has very, I think in Arabic it's really good. Now the question is it at the level where like translator, it's maybe not at that level, but it's getting very closer. So if you translate even to Japanese and other languages, it's very good. The only language that is not good is Chinese. So they have like separate models for Chinese. There are some models built on Arabic data, like the model called Falcon, and that was built in Dubai. And I think that will do better for Arabic data than ChatGPT. But in general, if you look at ChatGPT, translation is not bad.
Okay, now we'll have 10 minutes break, and we'll come back at 3:15. Thank you.
بداية نشكر الجمعية السعودية لزراعة نخاع العظم والجمعية السعودية لأمراض الدم على الدعوة الكريمة والاستضافة الكريمة لنا إن شاء الله، ونتمنى لهم إن شاء الله موفقية والنجاح المؤتمر. Dear colleague, we'll start the last session. Last session will be with the distinguished faculty, starting with Professor Hanan Ahmed. Professor Hanan Ahmed, Hanan Hamid, Professor of Internal Medicine and Clinical Hematology at Ain Shams University, Cairo, Egypt. She will talk about anticoagulation beyond DUAC. Please, Dr. Hanan, thank you.
Thank you very much, Professor Ala. First of all, I'm so grateful for the organizers for giving me the opportunity to be with you here. I always feel home and very happy to join you. So, it does not move. Not at all from here, the remote. Okay, what I'm going to do is to give an idea about the new of anticoagulation. So most probably I'm the future, and then we will have the guidelines and thrombophilia. We know to have a proper hemostasis, we need to have prevention of bleeding and prevention of thrombosis. Both of them are of equal importance. And to have prevention of bleeding, we have to have a patent and competent coagulation cascade and platelet function. And the coagulation cascade, as we all know, is divided into intrinsic and extrinsic pathway. Later on, the extrinsic pathway have been called the tissue factor pathway. Besides, as I said, the activated platelet are the mainstay of such condition. So we do have, this is the intrinsic pathway with factor 12, then factor 11, 9, 8 activation. The extrinsic pathway, factor 7, then both of them activate factor 10, and by the aid of factor 5, we have thrombin generation and fibrin generation. And what is really interesting, that activated thrombin will do a sort of feedback and will activate more factor 8. And what's more interesting, that activated thrombin will do a sort of feedback and activate more and more of factor 11. We all know that factor 11 and factor 12 are called the contact factors. So we need to have a balance between the risk of bleeding and risk of thromboembolism and everything from the physiology to the treatment with anticoagulation. We have always to remember that thrombosis could happen in veins, which we mostly speak about in hematology, but arteries and intracardiac, I have patients with thrombotic manifestations, not only in veins and arteries, but even intracardiac thrombi due to a thrombotic condition. And we are all, up till now, for more than 100 years, referring to the Virchow triad, which is circulatory stasis, endothelial injury, and hypercoagulable state. In the field of anticoagulation, we should always remember that we are having a special population with a special consideration when we anticoagulate people, like extreme of weight is a challenging condition, chronic kidney disease, liver disease, patient with cancer-associated thrombotic event, antiphospholipid syndrome, heparin-induced thrombocytopenia, and the recent comer, which is vaccination-associated thrombocytopenia, pregnancy, and the concern of adherence, and the concern of feeding tubes. So in these huge special requirements, we have plenty of unmet need and the possibility of higher bleeding tendency. Another problem in thrombotic conditions is the unusual sites and unusual manifestations like splanchnic vein, abdominal vein, cerebral, upper limbs, or unusual site. Usually, we do have something behind that. It's not only the precipitating factor, we could have something related to hematology or related to something. And especially the cancer-associated malignancy, at least we lose 10% of cancer patients in whom cancer have been treated from thrombotic event, particularly venous thrombosis and pulmonary thrombosis without peripheral DVT is the cause of death of them. And the first one who alluded to the cancer-associated thrombosis was the French scientist Armand Trousseau, and with the irony of fate, Armand Trousseau described himself as potential cancer patient when he starts to have a migratory thrombotic event he described before for malignant condition. So let us speak about anticoagulation. These are the milestones of anticoagulation starting from the 50s, and with the warfarin, and then low molecular weight heparin, and then the era of DOACs. And with 2023, we do have another hope for anticoagulation. These are the different anticoagulatory mechanisms we know, either targeting activated factor 10 with the DOACs, or targeted thrombin with dabigatran, which is Pradaxa, or targeting both 10 and 2 with heparins, all types of heparins, and multi-factors targeting with warfarin. So we have the old one, heparin and warfarin, and heparin, as I said, is working on 10 and 2, factor 10 and factor 2, while warfarin is working on all of that. The unfractionated heparin, which is one of my favorite, I'm still a big fan of heparins, all the heparins, is not only having an anticoagulant effect, it have anti-cancer, it have a role to play with hepcidin and to improve anemia in many conditions, and it have an anti-sepsis effect. So it is a cave of jewelries, which we could use if we use it properly. It could add to the benefit of anticoagulation. Of course, low molecular weight heparin is another advancement, allowing subcutaneous and home treatment, and the hit incidence is much, much less than the unfractionated heparin. What I'm going to say about warfarin, that it does not block or inhibit only the coagulation factor. It also inhibits the natural anticoagulant, particularly protein C and S, and that's why in some patients who are having something else, allowing more thrombophilia on them, we might have skin necrosis as a complication of prolonged warfarin therapy. Warfarin, the common and most important uses of it, which is incompatible with, are in cases of mechanical heart valves, in cases of antiphospholipid syndrome. It is up till now the only guideline for anticoagulation in antiphospholipid. In severe renal impairment and hemodialysis, especially in patients on long-standing hemodialysis, those who are extreme of age, and those who are having drug-drug interaction, especially with the DOACs. The warfarin, the importance of warfarin, of antiphospholipid syndrome, have been documented through time over the last 10 years with many studies which showed superiority and less side effect comparable to DOACs, different DOACs, the three most commonly used. And we should admit that the landscape of anticoagulation have been totally changed with the introduction of direct oral anticoagulants. These are the different direct oral anticoagulants we have in the market. In our area, we have a fourth one, which is not available. But I think that we are witnessing now the fall of the Pradaxa. The complications from the Pradaxa, particularly the cardiovascular, limits its use, and we are now mostly dependent on activated factor 10 inhibitor, and these are the sites of their action, factor 10 and factor 2. This slide to show only that the renal clearance of DOACs is minimal with apixaban. That's why when we have reduced creatinine clearance or renal impairment, the only permitted DOACs, or the best permitted DOAC in those patients is apixaban. When we speak about 2013, the lion's share of anticoagulation was still warfarin. When we speak from 2020, the lion's share nowadays is mostly to DOACs. But we still have unmet needs in cases of anticoagulation, like bleeding tendency, post-thrombotic syndrome, and chronic thromboembolic pulmonary hypertension. I will take you to another area and we will join them together later on. We have noticed that the two factors, which are factor 11 and factor 12, which are called the contact factor, are having those patients who are deficiency in those two factors, are not having bleeding tendency, but having less thrombotic event. So, two coagulation factor, when they are deficient, we don't have bleeding, we have decreased thrombotic event. And these are the two contact factors. So they are having decreased ischemic stroke, decreased venous thromboembolism, no increase in intracerebral hemorrhage like other coagulation factor. Spontaneous bleeding is very uncommon. And this leads to why we don't use these contact factors as a target for anticoagulation. So these are the different evidences: human genetic, epidemiology genetics, and animal studies confirmed what we said before. And that's why we start to think not only of utilizing factor 11 and 12 as an anticoagulation target, but to think in a different way in the coagulation cascade. So the scientists have put two important end result of thrombus formation. If we have the thrombus outside the interior part of a vessel, this is a physiological hemostatic condition preventing bleeding. But if the thrombus is inside the lumen of a blood vessel, this is a thrombotic event, which is a pathological condition. Bear with me. So when we look at the mechanism of action of anticoagulation, we will find most of them are orchestrating both of them, like DOACs and warfarin, playing on factor 10, 11, 5, thrombin, which is factor 2. The only coagulation factor which can lead only, if we target them, we can lead only to prevention of pathological thrombosis without impairment of hemostatic condition are the contact factors, which are 11 and 12. And we will see that more. And that's why we got this paper a couple of years ago with the theory of rebirth of the contact factor as a potential therapeutic anticoagulation. And then we have in the publication plethora of papers supporting that, and even the pharmaceutical company tries to leap after the scientist assumption and to produce plenty of drugs to achieve this target. So the principle was, as I said, when we have hemostatic plug, the thrombus is outside the lumen. When we have a thrombus inside the blood vessel, this is a thrombosis. And this could be initiated by medical device, neutrophilic extracellular trap in an inflammatory condition, or molecules, macromolecules, something else. So, prevention of thrombosis, limiting of the bleeding tendency was the aim of the scientists when they approach the coagulation system like that. And this was the site we need to manipulate or to be aware of it. So the disconnection of the dangerous part, which is in the middle of this tableau, by attacking something peripheral leading to the thrombosis was the idea. And that's what happened. They did what we call uncoupling of the two pathways of hemostasis and thrombosis by attacking factor 8 and inhibiting factor 8 in the body. And this will lead to two important things: decreased bleeding tendency and keeping the function of anticoagulation, reducing the thrombosis and thrombotic event, and treating those patients in the proper way. And this very nice paper, which have been published maybe 15, 16 months ago, showing that factor 11 inhibition is the lowest risk of bleeding as an anticoagulant, and this is the safest ever zone we have been in as an anticoagulation. So it is a very important now potential target for anticoagulation. It's not only anticoagulation, it has been documented that inhibition of contact factor, particularly factor 11, will lead to two important things in thromboinflammation. It will lead to inhibition of the sepsis therapeutic target, and it will lead to inhibition of cytokine and biological active material liberated with sepsis, inflammation, and thromboinflammation. So by inhibiting factor 11, we will anticoagulate, prevent bleeding, and decrease thromboinflammatory markers. And that's actually what happens, uncoupling of thrombosis from bleeding, prevention of inflammation, calming down the cytokine release. So we have had the assumption of factor 11 and factor 12 inhibition. Are we translating that into treatment by drugs or whatever? So we do have many drug recipe for inhibition of factor 11 particularly. And we have different mechanisms of action like antisense oligonucleotide and the catalonic domain inhibition and serine protease active site inhibition. And to sum up, these are the three most important targeting for inhibition of factor 11. Antisense oligonucleotide will reduce hepatic production of factor 11. Antibodies will bind to factor 11 in the serum, preventing its action, and small molecules will inhibit the active site and block its activity. The level will be the same, but the activity will be impaired. Look at the table. We are having antibodies, small molecules, natural inhibitors, antisense oligonucleotides, and aptamers. And what is really was interesting to me when I saw this paper, which is very recently published, that we have antibodies to give it once as an anticoagulation per month. Believe it or not, anticoagulant to be taken once in a month, which is something never preceded before in our knowledge. And we do have some oral drugs which could be once weekly or once monthly as well. So the promise of contact pathway inhibition is attenuation of thrombosis, disengagement thrombosis from bleeding, and this will lead to disruption of hemostasis in the minimal possible percentage. So are we having a pharmacy near factor 11 and 12 to be present for us in nearby pharmacies? I think yes, within maximum 5 years or with this decade, if I will be alive, I will see that. So these are great news. Then I will go to something else. I was hesitant to say it in this presentation or not, but I said, coming from the future, I have to tackle it even with a couple of slides. In special situation, we do not need to do systemic anticoagulation. We need to do local anticoagulation. And this was a whispering thinking maybe a decade ago. And now the voice is very loud and well heard everywhere. So we do have something called macromolecules. And we do have periodics for these macromolecules. And macromolecules, the idea started maybe 3, 4, 5 decades when we classified the different macromolecules in our body into carbohydrates, lipids, proteins, amino acids, and nucleic acids. But now we have therapeutic, industrial, medical, and other macromolecules. And these macromolecules are, in the last 4 or 5 years, used in cardiovascular disease, especially with cardiovascular devices, used in blood-containing or implantable material, and with medication device. What are the types of these macromolecules? They are either natural, present in nature, or semi-synthetic or synthetic anticoagulant. And these synthetic anticoagulant and semi-synthetic coming from a lot of materials, either from the body or from chemically induced, but the natural anticoagulant, to our astonishment, are present almost everywhere in the animals, in the planets, and in the microorganisms. That's why maybe when we eat something in an excess amount, some people are getting maybe bleeding with brushing their teeth, maybe more hematoma on moderate trauma. So maybe the food we are eating not only antagonizing warfarin, but making us, if we are not taking anticoagulant, more prone for not bleeding, but something like that. So let us see what are the applications they are used now. They are used now with cardiovascular devices, with dialysis membrane to prevent blood coagulation with hemodialysis and to decrease the heparin doses in those patients, preventing complication of bleeding post-dialysis. They are used for bioelectronics, whether pacemaker or something like that, and they are used in the grafts, artificial grafts for vascular surgery. So these anticoagulant macromolecules, I think that we will see a lot of metamorphosis in the coming few years. Maybe they will be used for a target, localized anticoagulation for a site without systemic anticoagulation. So we are having a lot of very good surprises, so let us sum up. Anticoagulation is still the mainstay of prevention and treatment of venous thromboembolism, although the drugs have had a marked improvement of venous thromboembolism, but bleeding remains a concern. The current focus on factor 11, particularly inhibition, will, with the uncoupling of bleeding from thrombotic pathway, will provide a safer anticoagulation. And to be cheerful, we are having many drugs in the phase 3, and some of them, couple of them, are for the fast track for FDA approval. With that, I finish my presentation. Thank you very much.
Thank you very much, Professor Hanan, for this excellent lecture and update about the anticoagulation. And the question will be at the end of the session.
So our next speaker is Dr. Ashraf Warsi, consultant of adult hematology, Prince Noura Oncology Center, King Abdulaziz Medical City, Jeddah, Minister of National Guards. He will kindly update us about the anticoagulation guidelines. So the floor is yours, Dr. Ashraf.
Thank you very much, and thank you for organizing committee for inviting me. So to start with, the topic was really difficult. Finding out what's new updates in anticoagulation is really hard. There hasn't been many, so I tried my best to highlight some of the new. So the outline, I'm going to just go through the roughly some of the guidelines from the 2018, which has been reviewed July 2022 by the American Society of Hematology. You must have noticed now there's too many societies producing guidelines. The American College of Chest Physicians are still producing the guidelines as well. Other authorities, including in Europe, are producing it. So that would be my first part of the talk. Second part, I'll just go through the hot topic of updating the diagnostic criteria for antiphospholipid anti-syndrome. And lastly, I'll just present one of the abstracts that was presented at the ASH meeting, which I find really interesting in trying to answer a very big question. Which one is better, apixaban or rivaroxaban or warfarin in atrial fibrillation and VTE? So I'll just start with a case, and this is relatively, it's actually a real patient, except my patient was a 14-year-old. So he's a 17-year-old boy, presents with one-day history of dyspnea on exertion and 1-week history of right leg pain. He is previously healthy and does not take any medications. He has no family history of significance. His weight is 140 kg, his height is 175 centimeters, his BMI is 45.7, vital signs stable, Doppler of the lower limbs and CTPA have confirmed DVT and pulmonary embolism. So the first question is, he needs anticoagulation, definitely. So what are we going to start him on? Unfractionated heparin, low molecular weight heparin, DOACs, all have been approved as a first-line therapy. Now, definitely unfractionated heparin, if the patient is unstable on that, you want to admit the patient, intravenous infusion, then that would be the choice. But what would you do? And if you decide you're going to go with low molecular weight heparin, the only one available in Saudi Arabia is enoxaparin. So what would be the dose? Very commonly, we get this asked by the junior colleagues that there's the insert tells you that 120 is the capping dose for enoxaparin. Should we give him 1 milligram per kg exactly, or should we go with the capping dose? And do we need to monitor anti-10A in this patient because he's overweight? So actually the guidelines helped us in answering that question. Now, The first recommendation is actually go by weight base, so you give him 140 milligrams twice daily. I was taught this. I'm teaching this to my fellows, but at least there's a body of evidence, the American Society of Hematology, who have decided on that. You have to take these guidelines with a grain of salt. So they always, whenever they're mentioning the word suggest, that's a very weak recommendation. And that's why you see the only +1 on it. The other recommendation, which was also nice, that you actually do not need to monitor for anti-10A levels in these patients. I used to teach them to do monitoring in overweight or underweight patients. Occasionally we see patients who weigh 30 kgs and they're adults. So again, probably in overweight patients, they're recommending not to monitor that. And basically, how did they reach that? It's based on retrospective data, looking at how many times did they actually adjust doses based on anti-10A testing, and there wasn't many times. So they ended up saying it's not cost effective. You don't do changes in dosing. You probably don't need to test for that. What about his obesity? If somebody wanted to start DOAC and he said the patient is quite stable, yes, he has some pain or shortness of breath, but he can start him DOAC, which has been approved upfront without any bridging. So the International Society on Thrombosis and Hemostasis produced a guidance in 2016. And I just wanted to show you how these guidance were reached. Basically, they looked at retrospective data from all the randomized controlled trials, also from the phase 4, which is basically prospective data collection observation studies. And not all DOACs have actually evidence. The biggest evidence probably is from the rivaroxaban trials. Apixaban does have some evidence, but it's lower, whereas dabigatran apixaban doesn't have any evidence on that. So actually in those studies, there weren't many obese patients to get that much data on them. And you will not see a randomized control trial in this population as well. Nonetheless, they said that, and this was before, so up to 120, you can safely start DOAC as a therapeutic for these patients. If your patient is above 120, then rivaroxaban, who has a higher evidence, or apixaban would be the drugs of choice. And you can use them in both settings of treatment or prophylaxis. Remember, these DOACs are approved in prophylaxis post-hip and knee replacement. Whereas due to lack of evidence or lack of pharmacodynamic or pharmacokinetic data, edoxaban, betrixaban, and dabigatran are not recommended to be used in these situations. All DOACs should not be used in post-bariatric prophylaxis just because of uncertainty about the observation of these medications. So again, this is from the International Society on Thrombosis and Hemostasis from, I think, 2021. It's really helpful for our clinical practice. These are, again, low weight of evidence on them, but nonetheless, they're endorsed by the ISTH. So we continue with the case. So he started on low molecular weight heparin based on actual body weight, and he's also started on overlapping warfarin or vitamin K antagonist. After 8 days, his INR is therapeutic and low molecular weight heparin is stopped appropriately. You see him in follow-up in 3 months, and the decision is made to continue with vitamin K antagonist for secondary VTE prevention. 5 months later, he requires an elective surgery for a pilonidal sinus. So how are you going to manage that? And that's really interesting. So would you postpone procedure by 4 months to lower the VTE risk? Interrupt vitamin K before procedure, give him peri-procedure bridging with low molecular weight heparin, or interrupt vitamin K before procedure, give peri-procedure bridging anticoagulation with unfractionated heparin, or just interrupt the vitamin K and do not provide any bridging and go ahead with the surgery and resume after surgery. So as you would know that it's been already 3 months, more than 5 months, so it's out of the acute phase or acute period of risk of embolization, and it's appropriate just to stop the vitamin K 5 days before, continue on, do the surgery and resume afterwards. So that was what's endorsed by the guidelines here also, and that's based on strong recommendations. And while in DOAC interruption therapy, that's a very nice one as well. If your patient is on a DOAC, you do not need to bridge them. There are the guidance how you manage perioperative DOAC management, and there's no need for bridging these patients. and how we decide whether it's an acute, high risk, or moderate risk, or low risk. So low risk patients, basically more than 12 months previously, VTE more than 12 months, no other risk factors. VTE 3 to 12 months, classically we call them at moderate risk, and less than 3 months is the higher risk period. For those patients, we usually either you do bridge or sometimes you may consider IVC filter insertion. Okay, so the case doesn't end. So interrupt vitamin K and he goes for the surgery, uneventful, and after surgery, appropriately, he started back on vitamin K. 3 years down the road, while he's playing football, which is a very huge problem with young people being on long-term anticoagulation, he falls on his head and has a large subarachnoid hemorrhage with midline shift. Glasgow Coma Scale is 9, his INR is 2.4, and you called for the appropriate management because he requires surgery, or actually neurosurgery. So what would be your option? Either give him IV vitamin K alone, prothrombin complex concentrate, fresh frozen plasma, IV vitamin K and PCC, IV vitamin K and FFP. And as you would say, the right option would be IV vitamin K and PCC. As you know, PCC, or four-product prothrombin complex concentrate, has a half-life probably because 6 to 8 hours, and you need the vitamin K to take over after that. So we actually had guidelines mention administering both together. So, but if the patient has a prolonged INR and he has no clinically relevant bleeding, then you just need to hold the warfarin. You don't need to give them any vitamin K, and let the warfarin drop as long as the patient is competent, lives nearby, and he's close to health services. Whereas life-threatening, as we said, you need the four-factor prothrombin complex concentrate. And also, as you see here, these are recommendations based on low-quality evidence just because of the lack of randomized control trial in these populations. So, a new case, so 70-year-old male on rivaroxaban 20 milligram daily for VTE prevention after recurrent unprovoked pulmonary emboli. Past history, hypertension, epilepsy, seen in remission of anti-seizure medications for 5 years. He's seen in the emergency department with frequent melena times 48 hours. Last dose of rivaroxaban was today, 4 hours ago. Hemoglobin has dropped from 12 to 6 grams. Blood pressure borderline with tachycardia, and he has a diagnosis of upper GI bleeding exacerbated by rivaroxaban. So the patient is presenting with acute life-threatening upper GI bleeding while on an oral direct 10A inhibitor. What management would you suggest for his DOAC-associated bleeding? And as you would say, cessation of definitely stopping the rivaroxaban. Would you give him four-factor? Yeah, that's a correct answer. Or you may want to use andexanet alpha. That's a commercial name, but its scientific name is coagulation factor 10A recombinant inactivated zozo. So first, we will definitely stop the rivaroxaban. Then either you can choose giving him an andexanet alpha or the four-product PCC. Both are endorsed by the guidelines. And there's none of them is better than the other because there is a lack of trials looking at which one is better. There is retrospective data saying that probably four-factor PCC is as good as andexanet alpha. Also, there's an issue with andexanet alpha, whether you need to repeat the doses after 6 hours. That really depends on if you have ongoing bleeding or the surgical procedure is taking too long. But definitely, you can use either or in these situations if you have whatever you have available. So, if the patient was receiving dabigatran, what management would you suggest for him? And this has been clearly in the phase 2 trials of either Ssbmt, which is the Pradaxa-bind, the other name for it, which basically binds the medication, so the specific antidote for dabigatran. I don't think it was a randomized trial. It was all based on phase 2 trials, so probably that's the reason for the weak evidence. If the bleeding is controlled and the patient condition improves, and this is a very practical question, we always are faced that when do you resume anticoagulation? And I think because the patient in the scenario is a VTE patient, so recurrent venous thromboembolism, the correct answer would be 2 weeks up to 9 months. So it's in the guidelines mentioned that within 90 days of the bleeding. But again, if your patient was anticoagulated for a different reason, more serious one, then you have to reconsider whether to resume it earlier or not. Not in DOACs, but for example, on people who have metallic valves and on warfarin, probably would be very uncomfortable putting him 2 weeks without any anticoagulants, so probably earlier on that. But definitely for DOACs, what sounds reasonable is 2 weeks within the next 90 days to resume anticoagulation. So I highlighted the remarks from the guidelines, so this recommendation specifically applies to patients who require long-term or indefinite anticoagulation, are at moderate to high risk of recurrent VTE, are not at high risk of recurrent bleeding, and are willing to continue anticoagulation therapy. So you have to keep in mind all of these remarks. So that was the first part. I didn't go through all the other points in the guidelines. I just picked up the ones really clinically relevant. Now, I know all of us interested in antiphospholipid syndrome have seen this new classification criteria. As you know, antiphospholipid is an autoimmune disorder characterized by venous or arterial thrombosis and or pregnancy morbidity in the presence of persistent laboratory evidence of antiphospholipid antibodies. The manifestations ranges from asymptomatic or arterial or venous thrombosis, pregnancy morbidities, which can have different definitions. You'll see that in a minute in a slide. Microthrombosis, non-criteria manifestations. So the old criteria did not include many manifestations, for example, thrombocytopenia, pulmonary hemorrhages, and catastrophic antiphospholipid syndrome. So these are the manifestations that this syndrome can present in. Sapura criteria, very old criteria developed from 2006, and we have been waiting for probably 10, 15 years for them to be updated. Remember, these were unprovoked venous or arterial thrombosis or poor pregnancy outcomes as defined in the criteria, plus you needed a positive antiphospholipid antibody which was persistent for 12 weeks. Limitations, it did not include other manifestations of antiphospholipid syndrome, for example, thrombocytopenia, heart valve disease, levator reticularis, excluded patients with pre-existing thrombophilia, other thrombophilias, and some criteria needed more clear definitions, especially the pregnancy loss ones. So what's the differentiation between, what's the difference between classification criteria and diagnostic criteria? When I was a rheumatology resident, and I think everybody, I thought that rheumatology was really easy. Every disease has just some criteria you memorize and you get to the diagnosis. Unfortunately, all those criteria are developed for research purposes. So the goal of developing classification criteria is to homogenize your patient population for studies, not to get to a diagnosis. When you develop diagnostic criteria, you want to include every possible patient, and you don't want to miss that. So you want to be more specific with your classification criteria, but you want to be more sensitive and specific with your diagnostic criteria. You may lose some sensitivity in the classification criteria, which is acceptable. We are now midway between insurance and reimbursement. Eventually, we'll be having a universal insurance system. So the classification criteria should not affect billing or for the patients, whereas diagnostic are made for that. And as well as classification criteria should not affect your treatment management plan, where diagnostic criteria is made for the management decisions. Anyhow, so the American College of Rheumatology and the European League Against Rheumatism developed these criteria with the goal of to achieve high specificity relative to the revised Sapura criteria to improve homogeneity in antiphospholipid syndrome research. They went through a modified Delphi system, went through 4 phases of the criteria, and eventually the patients, in order to go through the criteria, should have 1 clinical event and 1 evidence of antiphospholipid before you start applying the criteria to them. I also highlighted here that they have different levels for the antibodies, anticardiolipin and beta-2 glycoprotein, with a moderate level and high level as defined in the slide. And they reached this, so it became more complicated. So actually, they have 6 clinical domains, and you have your laboratory criteria. What's interesting, now most of you know that phosphatidol, inositol antibodies and prothrombin antibodies have been associated with antiphospholipid syndrome. And personally, I was expecting that will make it to the guidelines, but unfortunately, it did not. And the reason behind it, which is I think very appropriate, that those antibodies do not occur separate from the 3 previously mentioned antibodies. So that's why they did not include them. Now, they really defined in very detail the obstetrical criteria. They included thrombocytopenia, they included pulmonary hemorrhages, cardiac valve disease, and they have some terms that it was for the first time for me to learn that, but basically livedo racemose or livedoid vasculopathy is a very specific presentation, and those are the images I had to look up from Google and print it out because I never heard about them before. But anyhow, so to get to the diagnosis, you need to score 3 points at least from the clinical criteria and 3 points from the laboratory criteria to reach a final diagnosis of antiphospholipid antiphospholipid syndrome. And now, did they achieve what they aimed for, which is higher specificity? And yes, they did. So they validated their new criteria compared to superior criteria on 2 different cohorts, and they did achieve that. Reminded you the sensitivity was a bit lower, but that's totally fine for their purpose of developing the criteria. My 2 bits on that will be, we have used the Sapporo criteria, which again was a classification criteria, not a diagnostic criteria, and people have already started using these criteria. There are already online calculators for the new criteria. You have to take it with a grain of salt. You have to think twice how to use these criteria. Yes, definitely they are helpful, but again, there are occasions where they may not be able to answer all of your questions. So we will be using them, people and physicians will be using these criteria, but definitely judge your patient case by case and decide on what's the best appropriate treatment for him. Now, in the last few slides, I'm just going to show you this abstract, which was an oral abstract presented at the American Society of Hematology 2023 meeting, which was titled A Comparison of Bleeding Events Among Patients on Apixaban, Rivaroxaban, and Warfarin for Atrial Fibrillation or Venous Thromboembolism. Now, as you know, both have been approved for atrial fibrillation, or all 3 medications are approved. Both have been studied separately in randomized controlled trial against warfarin as a non-inferiority trial, and the indications are, as mentioned before, atrial fibrillation and VTE. But then the question always comes up. We also have in the kingdom, in the private sector, most of the private sector do have edoxaban as well, so we have a 3rd DOAC available to us. Dabigatran, as Prof. Mentioned earlier, it's really falling down out of favor, and I think we won't see it in the near future, possibly. So this was an attempt to answer which one was better in terms of bleeding, in terms of prevention from recurrent thrombosis. We won't be able to see a randomized controlled prospective trial of these studies. So what they did basically was a retrospective study of registries, and they took their data from warfarin DOAC clinics. So yes, there are in North America clinics which are called DOAC clinics, where people on DOACs are monitored on a regular basis, and actually recommended to do that in your practices. And they looked at a huge number. They excluded patients who were treated for valvular AFib, anticoagulated less than 3 months of follow-up. And that's the number of patients they got. What they matched them in a propensity matching system, matched them for age, sex, alcohol, tobacco abuse, atrial fibrillation, venous thromboembolism, comorbidities, and they looked at different parameters, including also concomitant medications like aspirin, estrogen, non-steroidal antiplatelet therapy. They also calculated Hasbled scores for them, the Carlson comorbidity index, the duration of follow-up as well. What they were looking for was basically thrombosis and what type of thrombosis they developed, also bleeding, emergency visit, hospitalization, death, and requirement for blood transfusion. So, apixaban versus warfarin, I would say this was just confirmation of the randomized control trial where it does have non-major, apixaban has higher non-major bleeding, but definitely for major bleeding, it's lesser than warfarin, and we all know that from all the DOAC trials in randomized controlled trials. Rivaroxaban, very similar to that, except that in the major bleeding, probably slightly higher. It is higher there. Non-major bleeding was higher with rivaroxaban, any bleeding with higher with rivaroxaban, thrombosis recurrent didn't differ between warfarin. So what about both of them together? So which one was better, rivaroxaban or apixaban? As you can see, people had major bleeding more with rivaroxaban. They had also non-major bleeding more with rivaroxaban, any bleeding was higher with rivaroxaban. So it does help us. So the strength of this trial was basically in a large, robust data set. Bleeding and thrombosis outcomes were measured. It was a real-world data. The drawback on it, or the limitations, that it's an observational data, so there's always room for selection bias. It's a retrospective data, so recall bias is also an issue. Potentially underpowered, that could be also. The numbers were not very high, but this was just localized to the Michigan area. Again, that's a geographical limitation. Data on MI may not be well captured, and there was no data on adherence of patients as well. So the conclusion from their point was, for patients on oral anticoagulant, bleeding was highest with rivaroxaban, followed by warfarin, and then apixaban. So and that has been shown in randomized controlled trials as well, that apixaban has the lowest rate of bleeding. Thrombosis was higher with apixaban compared to warfarin, seemingly largely driven by other thrombotic events. Thrombotic event rates were otherwise similar between apixaban, rivaroxaban, and warfarin. We observed apixaban to be associated with lower mortality than rivaroxaban and warfarin, but that was just an observation. As I said, it's very difficult to conduct a randomized controlled trial prospective comparing both of these DOACs. But at least that may help us in slightly deciding for our patient population which would be the best DOAC to use in your centers. And with that, I finish my talk, and thank you for listening.
Thank you, Dr. Ashraf. And now it's our pleasure to have our last speaker in this nice conference, Dr. Iman Mansouri, Assistant Professor, Hematology Department, King Abdulaziz University in Jeddah. She's a consultant hematologist, and she will kindly talk about very exciting developments in hemophilia. So welcome, Dr. Iman.
Thank you so much, and thank you for organizers. I was asked to talk about hemophilia, exciting developments, and indeed there is currently so much ongoing in the field of hemophilia. I have no disclosures, and this is the content of my talk. So starting with the evolution of hemophilia therapy, as you can see in this figure, up until the 1990s, we really had nothing except some blood products. The first generation recombinant factor VIII came in 1992, and then 20 years later is when we had the first extended half-life factors. And then Ssbmt came in 2018, and in the last 3 years there has been just an explosion of research on hemophilia treatment options. Prophylaxis was only deemed the standard of care in 2020. And so a patient with severe hemophilia A on prophylaxis with factor VIII standard half-life usually receives 182 infusions a year. And that's a huge burden of disease that affects the patient quality of life in every aspect. As you can see in this graph here, with the standard half-life agents, there's a huge ups and down in the levels, with the patients being, for some period of their time, they are unprotected and at very low trough levels. This is a bit better with the extended half-life agents, where the patients are less of a fluctuation, but also better trough levels, and so a better protection from bleeds. With non-factor therapies, despite that there is not much factor there, but there is a good hemostatics support. And finally, with gene therapy, the patients are at near ideal near ideal levels and hemostatic state. So with the extended half-life agents, the whole goal is to reduce the burden of disease. With the factor VIII extended half-life agents, we are reaching 1.5 to 1.8 times the half-life, and this is because of the coupling of factor VIII to the von Willebrand factor. With factor 9, the extended half-life options are actually 4 to 5 times longer half-life than the standard half-life. There are a couple of mechanisms that makes the factor level has a higher half-life, and so this is including pegylation, FC fusion, or albumin fusion. And this table here shows you all the currently approved extended half-life options for factor 8 and factor 9. What you can see in the factor 8 options, there is a new player in the game, and this one is the L2V, or efanesoctagogue alpha, which was just approved in 2023. And as you can see there, the half-life is significantly better than before. And the reason behind that is, if you look at the molecule, there is a von Willebrand factor domain that is incorporated in the factor 8 product, in addition to the FC domain as well. And so with that, it is uncoupled from the von Willebrand factor. And if you look at the half-life here, by the day 7, the patient is at 15% factor 8, which is excellent. And the patient only needs 1 injection a week. So with all these development, unfortunately, there are some limitations with the extended half-life agents. They are still factor 8 products, so they can produce immunogenicity. They cannot be used in inhibitor patients. And they are still condition-specific, so factor 8 for hemophilia A, factor 9 for hemophilia B. And from there is a huge studies that are trying to look at other options. And so we have the mimetics, the prime example being Ssbmt, and we have the rebalancing therapies. A lot is going there, and gene therapy. And I will discuss those in the next few slides. So Ssbmt, as you all know, has really changed the face of hemophilia management. It is a humanized bispecific monoclonal antibody that kind of acts like factor 8 by binding factor 9 and factor 10. And through the phase 3 trials, Haven 1 up to Haven 4, it has been shown to be effective and safe in pediatric, adult, inhibitor and non-inhibitor patients. It is currently the prophylactic agent of choice in inhibitor patients, and that it is also commonly used in the non-inhibitor patients. This is just summarizes all the phase 3 trials for Ssbmt, Haven 1 through 4. And as you can see here, as of the end of the 6th month, the patients have an annualized bleeding rate that goes down to 0.8 and then 0.7, and up to 80% by the week 25 have 0 bleeds. 97% have bleeds less than 3 a year. And generally, it is a very well-tolerated medication. Now, unfortunately, nothing is perfect, and so with Ssbmt, some challenges do come. And number one is the laboratory assay interference. And so patients on Ssbmt, all their PTT and any APTT-based coagulation tests are basically useless, and I will show you a table next. But another issue is the management of bleeding and the management of the perioperative state in those patients. The Haven 1 up to 4 studies have shown that those patients that are increased risk of thrombosis and TMA when they are exposed to high doses of APCC. And so currently the preferable option to be used in patients who are going through surgeries or have breakthrough bleeding is factor 7. And if you need to use APCC, then to be just very careful with how much dosing you are giving and not to reach the 100 milligram per kilogram per day. There is also the potential loss of efficacy with the development of anti-Ssbmt antibodies, yet this clinically does not seem to be a very common problem. This table summarizes what tests can be and cannot be used while on Ssbmt. So the ones highlighted in yellow are the tests that are reliable on Ssbmt, and this include PT. Although it can be slightly affected, it still can be used. Fibrinogen has to be the class method to be reliable. And then if you're trying to measure factor 8 activity, it has to be a chromogenic factor 8 assay based on bovine reagent. And the same if we are trying to detect the factor VIII inhibitor titers, we have to check a chromogenic assay that is bovine-based reagent. All the other ones not highlighted are basically useless. There are a lot of reports over the last year talking about low-dose emicizumab coming from many parts where, low resource setting around the world. This one study is from India, and it looked at, instead of calculating a weight-based dose, they just give a 1 vial dose to each patient, and this ranged between 0.8 to 2.6 per kilogram. This is compared to a 6 milligram per kilogram in addition to a loading dose, and they didn't give a loading dose. So we're talking about 1/7 of the actual dose. And the patient had 0 bleed, and most of those patients were inhibitor patients. And so right now there's a dose-EMI phase 4 study that's trying to look at non-inferiority of a lower dose emicizumab compared to the standard dose emicizumab. Another study tried to look at cost, and so they compared low-dose emicizumab compared to a low-dose factor VIII product, and they showed that with low-dose emicizumab, the patient then did well on all outcomes, and the cost was exactly the same and much better than the full-dose emicizumab. So there are still some unanswered questions when we are dealing with patient on emicizumab. We've been only using it for 5 years, so a lot is yet to be learned. Number one is the bone metabolism and health. As you may know, patients with hemophilia are at high risk of osteoporosis, and there is a lot of research on the role of factor VIII in bone health and in inflammation. And so we don't know how will those patients do from that perspective, being on emicizumab for many years. Another issue is in PUPs or patients who are previously untreated. If those patients are started on emicizumab as, since infancy, and they stay on it with no exposure to factor VIII, well, how much inhibitor risk are they at? And if they need a surgery, what will be the implications there? Does ITI have any role or not? And all these questions are currently being addressed by some studies. One of them is the Haven 7 study. Finally, and I think with the recent improvement in the extended half-life agents, so like efanesoctocog alpha, which has a very good half-life, how will emicizumab compare to the newer agents? How are we going to choose between them is something that only time will tell us. This is another agent that is basically a next generation emicizumab. It's called MIM8, and it is said to be 15 times more potent than emicizumab. Currently, there are 3 phase 3 studies that are ongoing, Frontier 2, 3, and 4, and so we will be hearing about the results of those studies soon. Now, moving to a new group of medications, those are the rebalancers of hemostasis. And the idea behind this group is that patients with hemophilia have less procoagulant as compared to anticoagulant. And for the longest duration, we've been trying to fix this by adding more procoagulant to try to get the balance right again. And so the idea now is that, well, instead of adding procoagulant, let's remove some of the anticoagulants, so trying to attack the anticoagulant pathways to reach the balance again. As you remember here from the coagulation cascade, we have a number of natural anticoagulant pathways. One of them is the activated protein C, and currently there is a serine protease being developed. The phase 2 trial of that was just presented in EHAD just last week or the week before. There is also the tissue factor pathway inhibitor, and I'll mention those 2 medications, and then there is the antithrombin, and fitusiran is acting on that pathway. So fitusiran it's a single interfering RNA that basically interferes with the synthesis of antithrombin, and so you'll have a lower antithrombin level. There has been 2 phase 3 studies that have published in 2013. The issue with anti-fitusiran in these trials is that it has caused thromboembolic event. So it seems that we've tipped the balance a little bit too much with an 80 milligram subcutaneous monthly dose. About 2.28% of the patient developed a VTE or a thrombotic event generally. And so currently there is an ATLAS-ALL study which is trying to look at a lower, less frequent dose of fitusiran. So now it is given every 2 months and at a 50 milligram dose with targeting antithrombin to be between 15 and 35% and see if that has a better profile from a thrombotic perspective. Moving to concizumab, this is a subcutaneous weekly medication that is an anti-tissue factor pathway. And the studies for this medication was again paused in 2020 because of thrombotic events. And when they analyzed those events, it seems that the patients had other concomitant risk factors, and they were also given other hemostatic agents concurrently with concizumab that led to these thrombotic events. And so some risk medication strategies were put, and the studies were finished with no further complications. The Explorer 7 was published in 2023. The Explorer 8 is probably going to be published soon. Then we have marstacimab, which is another anti-tissue factor pathway inhibitor. This was just presented in 2023, and so far this one had no thrombotic events reported. And finally, just touching on gene therapy. And so in hemophilia, gene therapy is dependent on an adeno-associated virus that carries factor 8 or factor 9 product, gene, and then the vector homes into the liver. The genetic material incorporates into the liver cells, and the hemophilia patient can produce normal factor 8 or factor 9. There has been 2 agents that are already approved. First one was the Hemgenix, which is a hemophilia 9 gene therapy. It was only given to patients with no inhibitor, and it had good result. The patient had increased their factor 9 by a mean of 36%. The other one is Roctavian, which is a factor or a hemophilia A gene therapy. The patients by the end of the first year were at increasing their level by 42%. It seems that it did get lower from there. The issue with both those trials that the patients had elevated liver enzymes, and they were requiring significant doses of steroids. So I think the hemophilia B trial, the patients were steroid up to 500 days after the infusion. There are so many ongoing gene therapy trials in hemophilia, as you can see in these 2 tables. And if we are trying to compare gene therapy to all the other substitutors or rebalancers, with the rebalancers, they are all subcutaneous. They do have a low burden of disease, low burden of therapy. The patient do well on a steady state hemostasis. So for example, for imicizumab, they are around 15% equivalent or equivalent to a factor 8 of 15%. They are both can be used in pediatric and adults, in inhibitor and non-inhibitor patient. On the other hand, well, the patients are not yet normal. They do have their thrombotic risk, the assay issues and interference, and then the steep learning curve with managing their bleeding events and the annual expenses associated with these medications. On the other hand, with gene therapy, well, yes, it is a one and done procedure. The patients kind of go up to nearly curative levels, and there is an annual cost saving. But we have to keep in mind that the longest follow-up for a patient on gene therapy for hemophilia has been only 8 years. So there's still a lot to be learned there, and there's known risk as well as some unknown risk that only time will tell us. There's also the uncertain durability of gene therapy and the high initial cost. And so in conclusion, we are really in an era where we have so many options that are either already approved or are in the way to be approved. And so we really need to personalize the care of hemophilia patients, given all these options. Extended half-life agents are getting better and better. Ssbmt is, really revolutionized the care, and it is currently one of the leading agents. But also it is important to remember that about 83% of the hemophilia patients across the world have no access to even factor, and the access to all the other product is still very variable, and so it depends on the setting where you're practicing. Thank you for listening. Thank you for the invite.
Thank you very much. I will ask you and ask the other speaker to join us here to the stage to start the discussion. If there is any questions. Yes, Victor.
Yeah, I don't know if this is in the scope of this, but always we're having discussion in the bone marrow transplant. Are these dual anticoagulants are really safe, and what's the recommendation when you have, like, for example, a patient with a valve, with a metallic valve? How would they proceed with his anticoagulation during allogenic bone marrow transplant, for example? Is there any recommendation in the bone marrow transplant setup? Both of you. Thank you.
So it really depends what you're dealing with. Valvular AFib or metallic valves, the indication is warfarin. And a lot of these patients, if they're going allostem cell transplant, whatever transplant, that's really, it's a huge procedure, but let's say just chemotherapy. Sometimes you have significant interactions with warfarin, so we tend to switch them to enoxaparin. If they're going for allostem cell transplant, then yes, enoxaparin plus minus unfractionated heparin. There are some really strict people who will only use unfractionated heparin in metallic valves. Dr. Prof, you want to add something?
In metallic valve, for a long time, we go for warfarin. In my institute, we are having tens of thousands of patients who have had metallic valve over the last 3 decades, and we have a special clinic to follow them up. All of them are on warfarin, except when we want to bridge for something as an emergency or surgery, we bridge with heparin, most probably low molecular weight heparin. Other than that, we don't use DWACs, we don't use anything else.
Okay, I would like to add, we are facing now and then patient in hematology, acute leukemia or undeveloped DVT or thrombosis anymore. So with very low platelet, below 20. So how would you approach for this patient?
So looking at the ISTH guidelines for management of thrombocytopenia and thrombosis, especially in cancer patients who are receiving chemotherapy or who have thrombocytopenia for any reason, it's really a tricky situation. Some people, if they're platelet responsive and you have an acute pulmonary embolism, then it's better to transfuse platelets, bring it up to at least 40 or 50, and give anticoagulations. Sometimes that's really challenging and difficult, especially if your patient has platelet refractoriness or he has sepsis. Then you may consider inserting an IVC filter, remembering that itself on its own may cause thrombosis. So I tend usually to do what is, again, endorsed by the ISTH guidelines, a platelet count between 25 to 50, you can use half the dose or prophylactic dose, either once daily, enoxaparin 1 milligram per kg or prophylactic dose. Less than 25, you have to stop, and then you consider to insert an IVC filter or not. It's a decision-based.
Okay. I will answer in a different fashion. Maybe I'm rebel or a naughty doctor, but what I'm concerned about is I'm not treating papers, I'm treating patients. So the number does not matter with me so long as it's more than 20, 25,000. If we have competent coagulation function, We have no bleeding tendency. The platelet function is all right. And I go as simple as bleeding time. Then I can go further for platelet function. I will feel comfortable above 25. If the patient is indicated for anticoagulation, I go for the lowest therapeutic dose for that. And I prefer to do something with with short-acting anticoagulation, either low molecular weight heparin or one of the DOACs. But I do not gamble with that patient by using something long-acting like warfarin or something like that. So it is not the number, it is the coagulation status of the patient, the platelet function, the bleeding tendency, and what's more dangerous, that we do have patients having platelets count like 50,000 or 60,000, but it have been newly known in the last decade that those ITP patients might not having a problem with the number only, they are having a problem with the function, because there is something called acquired Glanzmann syndrome in those patients. And the antibodies which facilitate destruction of the platelets might block the receptors which get in attachment with fibrin. So it is not the count, it is the function, it is the bleeding tendency in this patient.
Thank you.
Yes. My question is to Dr. Ashraf Warsi. Antiphospholipid antibody testing is probably the most misused and abused test in hematology. And we have published our experience led by Dr. Iman Mansouri. We found 400 patients over a recent period had antibody testing, and only 42% of them had repeat testing. And of the 42%, most of them, they had one test of the three. So the testing is all over the place. What is your practice in your current hospital, and what applications that you suggest to reduce such abuse?
So as long as the patients are referred to hematologists, one way to reduce the over-ordering of the tests would be restricting it to hematology services, for example. That's number one. Again, rheumatology also orders those tests because SLE, the anticardiolipin or beta-2 glycoprotein are part of their criteria as well, or in the lupus anticoagulant. So you may consider a decision between you and the rheumatologist to reduce that. Now, on the other hand, in our center, for example, unfortunately, even OB-GYN orders those tests. Internal medicine, general internists are ones that are ordering a test. And it's really detrimental because sometimes the patient had a knee hip replacement and he developed a DVT, which we know is a very high-risk surgery, and he get testing and it's positive. So you're going to label him antiphospholipid and keep him anticoagulation for lifelong. That's very challenging. Now, so one way of doing it is basically restricting and ordering. The other part of the question, repeating the test, so I think once you're following the patient, so you would be some way flagging that's positive, you need to repeat it after 12 weeks, sorry. One of the challenges that are with the antibodies itself, and that was really published around 4 or 5 years ago, that these antibodies disappear and reappear again. And disappearing doesn't really, we do not know what's the clinical significance of that. And that's really challenging because you order an unprovoked VTE, you tested, it was positive, after 12 weeks it's negative, am I going to say he doesn't have it? So it's really a clinical judgment comes down to that. And in one of the papers that I saw in the Ssbmt in 2006, that they looked at it after another 12 months, and some of them became positive again. So what does that mean? We didn't know the clinical significance behind it, and actually we do not know till now. So I think most of the anticoagulation guidelines do mention whether it's provoked or unprovoked, and unprovoked regarding of the testing, if the patient agrees he's low risk of bleeding, anticoagulate extendedly. So I think that really overcomes that. Again, that's really clinical judgment that antiphospholipid is a very challenging diagnosis, very detrimental for patients, labeling somebody young for lifelong and on warfarin. It's really challenging. So that's my 2 bits on that. Thank you.
So may I have a question to Dr. Iman? regarding the hemophilia gene therapy. Where do you put this modality of treatment in the paradigm of management of hemophilia patients, especially, if there's antibodies, which will not be a treatment of choice? What do you think regarding these patients?
If the patient has inhibitors, you mean?
I don't know. Where do you put gene therapy in the paradigm?
So far, all the approved ones are in non-inhibitor patients. So we have still to see any gene therapy trials in inhibitor patients. And it is because I guess we don't still know if they're going to develop an inhibitor to the gene therapy as well. So all the current ones are on non-inhibitor patients, but also we have so many good products coming on the way and ones that we are already using. And so it is really, I think it's going to be a person by person kind of management, because every patient comes with their own background and challenges and other comorbidities, and all these things will kind of push you one way or another. But with the presence of all these agents, I think I don't know, but I think gene therapy is not as heavy as in other hematological disorders, maybe. But I guess you can disagree with me.
No, thank you.
Yes, please.
Okay, thank you for your session. It was really interesting and very informative. My question is to Dr. Hanan. The inhibitor for factor 11 is a new era, but yet as a hematologist, I do accept that factor 12 is only bothering us in diagnostic issue because it's prolonged. Sometimes the APTT is very prolonged, yet we do nothing for those patients. But for factor 11, always as a hematologist, we are well prepared for, even preoperatively or whenever they need management. So in the case of that, you want to induce kind of an inhibition to factor 11. Is there a cutoff point below which you don't want, or be above which are they aiming for? Would this affect the APTT? And does this show us that we don't need for those as a preoperative, that we can lower the range of factor 11 for preoperative preparation? Thank you.
Thank you very much. They are brilliant questions. Actually, what will teach us is practicing. So we need to have a sort of hands-on after getting sure that the drugs are safe and what is the most effective and safe dose, and that they are really useful in practice. Then we will learn from applying these drugs, the adverse events and things like that. But your point is quite respectable, because we used to call factor 11 deficiency hemophilia C in those old days. So maybe we might be a bit cautious in specific group of patients. So factor 11 inhibitors could be helpful in, for instance, metallic valve, in antiphospholipid syndrome, in patients with renal impairment, but it might not be the convenient anticoagulant for patients with problem with coagulation defects or problems, or patients who are going to have a major procedure. So we will have a big array of anticoagulation. We will choose each drug or each modality for its proper patient. We have to match which patient, which drug to give to which patient, So the points you said are extremely considerable and are very brilliant to think of. Thank you very much.
Okay, maybe last case I would like to take your opinion. It is an interesting case. It is a hemophilia B, age 50 years, on regular prophylaxis. He presented to us with the lymph node and lymphocytosis. Diagnosis of CLL was done, stage C. So we want to start him on treatment. So the MDT at that time, we are choosing between ibrutinib or arbendamastine. We go to arbenda because of the risk of ibrutinib for bleeding and his hemophilia B. And we start him on ibrutinib, but he Actually, he responded, but now, still till now, he has severe thrombocytopenia, necessitating the transfusion of platelet, and also the leukopenia, pancytopenia in general, but he's still recovering. So, what's your opinion regarding the malignancy with hemophilia?
And he's still on prophylaxis, doing okay?
Yes, yes.
From a bleeding perspective,
Yes.
he's doing okay?
Yes.
So I guess like my first thought was, well, this is, you know, with thrombocytopenia and the bleeding risk going to be higher. Is that a patient that you want to switch to Ssbmt to have a better, you know, instead of dropping the troughs with the thrombocytopenia and putting him at risk during these periods, that at least you're going to be at a steady state with Ssbmt. But if he's doing well on prophylaxis and not having
But
much bleeding.
Hemophilia B. Hemophilia B.
Oh, sorry, hemophilia B.
Yes.
I thought this was a hemophilia. Okay, so well, with hemophilia B, I guess we don't have much options then.
Yes.
So if he's doing well on prophylaxis, I'm not sure if is he on extended half-life, but then you can also consider that as an option. But it's with this story, I was like, I thinking this is a patient who's going to have a bleeding concern. Yes, the hemogenics is for hemophilia B.
So probably if you treat it with the you may solve both issues.
Okay, if no more question, we conclude the session. Thank you very much for your excellent presentation. The final remarks by Professor Al-Askar. Please, Professor, and Dr.
Well, I must say, I mean, the last session was, I mean, the talks were brilliant, and I was really listening with interest to the advancement in hematology, and I was thinking, you know, we keep sometimes criticizing each other that we have multiple meetings and conferences in Saudi Arabia about hematology, and it's like we wanted to minimize this. And I see this, you know, we hardly catch up with the advancement in hematology. I mean, every year there is something new. And the presentation last year is totally different. I mean, compared again, or this year compared to last year. And you need that amount, you know, of, I would say, networking, presentations, talks, discussions to catch up with the field. You know, the thrombosis is totally different than hemostasis, than stem cell transplant, than, you know, many fields in hematology, the cell therapy, I mean, and what have you. It's just abundance of advancement in hematology. I don't know if we should keep calling it hematology. Maybe we should start splitting and subspecialize. I know in the West, I mean, they are subspecializing without announcing, well, this is subspecialization. But I think one board to cover adult hematology or pediatric hematology, I think is not valid anymore, I think. You know, with this, you know, great program that is comprehensive, I would like to thank Ahmed Absi and the team who put this program forward. We enjoyed it very much, and it's good to see a number of people still staying at the last minute. And again, what distinguished this meeting, we have representation and great participation from different countries, especially in the Arab region. And this is where we wanted again to you know, enhance our network and collaboration, and hopefully you know, one day we will have our multi-center clinical trials and not only copy and paste, but maybe lead and innovate in our region. And thank you, Dr. Ahmed Barafa again, and the team again for you know, for this collaboration. And on behalf of the two societies, I would like to thank you and thank everybody again for a great participation. Thank you to our organizers again and our sponsors. Without them, we would not have such a meeting as great and as successful. Thank you, and we shall see you soon in another event in our region. Thank you.